risk or lower risk. One of the biomarkers that are promising nowadays, you can see 3 of them. I don't know if we're going to hear something good in the future, but these are the ones that are probably the ones that are the most studied these days with pre-malignant oral cancer. Still, for now, in 2023, our only way of kind of categorizing these patients between low risk and high risk is by looking at the age, as we did, looking at the site, floor of mouth, here, lateral border of the tongue. So here we have a 65-year-old male who is a smoker, mild dysplasia. This is a low-risk lesion compared to this one, who is 52-year-old female. So female, as we said, is a bit higher risk, non-smoker, a bit higher risk, and has a severe dysplasia on the lateral border of the tongue. So this one will probably need treatment versus this one who will probably be observed for a little longer to see if there is something that will change. Obviously, in the future, if we have molecular testing, we'll be able to test these lesions and then determine what would be the best treatment. Are we good for now? To determine the malignant transformation, the risk of malignant transformation. So if I go back to my example that I just gave you, lesion number E will probably be at the highest risk. So you have a patient that has erythroleukoplakia, so that is the mixed lesion, which is at higher risk, between 18 to 50% if you want. Lateral border of the tongue, we remember that this is a site of predilection for cancer, including the soft palate and the floor of mouth. Age is a factor. The older patients will have higher risk of malignant transformation. If you have, again, a same lesion on a 20-year-old patient, the risk of transformation in the immediate future, which is in the next probably 5 to 10 years, is lower than the 65-year-old patient. But don't forget that a patient who has 20 years old, maybe in his life, will have a chance to transform because he has more years to live than the 65-year-old. But on the short term, the 65-year-old patient has a higher risk. And the study usually captures a short term because they're following patients for 5 or 10 years. Okay? I hope that nuance is also clear. Male, we said female are at higher risk, never smoker compared to a smoker, and then moderate epithelial dysplasia, obviously more risk than mild, but probably less risk than severe dysplasia. Let's look at different lesions here, just to give you a little idea. If I look at this lesion, homogeneous leukoplakia, a big extent of the lesion, on the floor of mouth, maybe a risk that is mild to moderate here. But if I look at this one is probably at higher risk of malignant transformation. Why? Because it's erythroleukoplakia. It's a smaller lesion, it's true, but it's on the floor of mouth. And because if it is a non-homogeneous leukoplakia, this one I will probably treat. This one I will have a tendency to observe, see if there is any changes. And if there are some changes, we can always rebiopsy, see if the degree of dysplasia has changed, if we need to do something. Here, another example, a leukoplakia on the lateral border of the tongue. Here we have a erythroleukoplakia, bigger extent, on the lateral border of the tongue. Again, it's a predilection site. So this one will probably be treated. This one we can observe if the patient is also okay for that, and then follow them regularly. The treatment that we can do for these patients, unfortunately nowadays, the only thing we can do is surgical treatment. Surgical treatment is either by scalpel, removing the lesion, or with a laser. Both techniques are good. I don't use laser because, one, we don't have it available, and I'm not convinced that it is the best technique. But both of them are good. If you look at the advantages of one, will be probably the disadvantages of the other. If you do laser surgery, you evaporate the lesion, then you don't have the tissue to analyze it more in depth by the pathologist. But you can minimize the damage to adjacent structures because the laser you go more superficial, and you have minimal scarring after. The advantage of the scalpel excision is basically when you remove the lesion, you can send it in total to the pathologist and they can reanalyze it, because sometimes you do the biopsy at one side, you get, let's say, moderate dysplasia, and then when you analyze the full specimen, you might find microinvasive cancer or CIS or other lesions that we didn't expect to find them in this biopsy. So what do I do? In my practice, first we start by assessing the risk of malignant transformation by doing a good history taking, a good clinical exam, and a biopsy for these lesions. And with this information, we will decide as we did today. What do we do? For severe dysplasia cases, most of these cases will go for surgery because the risk of transformation is high. For mild dysplasia in a homogeneous lesion, a small lesion, most of these lesions will be observed. The question mark is for the one in the intermediate risk, let's say a moderate dysplasia. Some of them will be observed, some others we will treat. Let's say I have a moderate dysplasia in a non-homogeneous lesion on the lateral border of the tongue, like I showed you before. This patient will probably go for surgery. So to make it easy, high risk, high-grade dysplasia, low risk, low dysplasia versus a white lesion, and a white lesion we don't treat, we observe. The high risk we would treat, and then the one that are intermediate, we look at the other factors and decide if we want to observe and treat the patient. The treatment is usually surgical, as I said. So here we have a lesion that is on the lateral border of the tongue, severe dysplasia. So we go in and then we do what we call a wide local excision, remove the whole lesion with some normal tissue around it, and then have also a bit of depth. This is the specimen that we obtain. As I told you, when you do a scalpel excision, that means you have a specimen that you will send to the pathologist, and this is the specimen that the pathologist will cut into it, different cuts, and reanalyze the lesion to make sure what we have inside. Sometimes you start with severe dysplasia, and then you can end up with microinvasive or even a squamous cell carcinoma in these specimens. So, always start by establishing a good diagnosis, determine the risk of malignant transformation. The treatment should always start by eliminating the risk factors. If the patient has a theological factor for cancer, obviously you can tell them maybe 100 times to stop smoking. If they don't decide to stop smoking, they will never do, but it is our responsibility to tell them and to insist on every appointment that they have to stop, because if they come one day and then you tell them stop smoking, and then they come after 6 months and you don't tell them, they think, oh, maybe I should not smoke because it's okay, he didn't tell me to stop. So I do it at every appointment. Do you smoke? Sir, yes, I still smoke a couple of cigarettes. No, smoking is not permitted. 0% risk for alcohol, for cigarette. Alcohol, we would allow that. In Canada, in Kuwait, probably it's a bit different. Aziz told me no alcohol in Kuwait. Okay, but again, I think we laugh about it, but some patients, probably they drink alcohol and they don't tell you. So it's important also to open the subject, because even if you can't buy it probably from a store, or if they go outside Kuwait, they should be aware that this is also not allowed to in their case. So then we determine the appropriate management, and the most important is the long-term follow-up. Other people will have other protocols. I have put here another protocol that was published by one of my colleagues when I did my fellowship in Baltimore. What you see here is when they have mild dysplasia, if it is on a low-risk lesion, let's say a homogeneous leukoplakia, they won't treat, but if it is in erythroleukoplakia, they would treat, and then they would treat all the moderate dysplasias and the severe dysplasia. So the treatment can vary from one specialist to another. As long as you're working with a specialist that feels comfortable and he knows what he's doing, it's fine, and the most important is to follow up these patients. Why we want to follow up on them? Because there is a risk of recurrence, and because, as we said, there is a risk of malignant transformation even if you excise the lesion at some point. And then if there are any changes in the lesion that you are observing, you should rebiopsy the lesion after. I'm going to give you an example of a patient that I followed for a long time, It's anecdotal, it's one case, but it shows you the importance of the long-term follow-up in these patients. So this patient, I first saw her in 2004. She was 50-year-old, and she has erythroleukoplakia. So the biopsy was done, and it showed CIS. So obviously, with the protocol that we have, this patient was candidate for surgery. So we did a wide local excision for her on the tongue, as you see here, and she was okay for not a long time, for only 1 year. After a year, maybe we didn't do a wide excision as we wanted to or should have done, but anyway, after a year, the patient developed a small lesion that you see here, and then this lesion was re-excised again, and then the diagnosis was microinvasive squamous cell carcinoma. For microinvasive, so it's a tumor that it is cancer, but it is still very superficial. All you need is to do a wide local excision, and that should be enough. And that's what we did for her, and she was good. We kept following her till 2011. I redid another biopsy because she started to have some changes on the side of the tongue. It showed mild dysplasia. Again, in my protocol, mild dysplasia, I would continue to observe. So should we continue to observe? In 2014, there has been more changes if you look here, and probably with a non-healing ulcer in this area, rebiopsied, and at this time it was squamous cell carcinoma. Although she was followed by me and by a specialist in oral medicine, the patient within 6 to 8 months, as I would say, between appointments, she developed a squamous cell carcinoma. So at this point, we obviously did a wide local excision of the tongue, and there was enough indication to do also a neck dissection for her. So we did what we call we removed the lymph nodes in the neck, which is a neck dissection. And then the final pathology on this patient showed that she even had one lymph node that had micrometastasis. So the cancer has already spread into one of the lymph nodes. So the latest follow-up, I put 2021, I didn't update this note, but I saw her this summer, this patient, and she was doing well. So since 2014, we removed the cancer, we did a neck dissection, and we gave her brachytherapy, which is radiation treatment to the site, and she doesn't have recurrence up to now. So that tells you the importance of a follow-up from 2004, 2005, 2011, 14, she had the cancer, and then we're still following her up to make sure everything is good. Final point, I think I still have another 15 minutes. I still have a little bit of time, I think. Okay, good. Because I don't have the time with me. I didn't put my. So, what is the role of the dentist? That's your role. I think most of you are dentists in the room. First is prevention. Again, we spoke a lot about this. Assess the presence of the risk factors among your patients. Again, we'll go back. The most important risk factors are two, the alcohol and the smoking. And smoking, when we talk about smoking, it's any type of smoking. I have also lots of patients because obviously I'm Lebanese, so I have lots of Lebanese Egyptians that come to see me in Canada. Oh, shisha is okay. No, shisha is not okay. It's still smoking shisha. Maybe, they try with other things. So any type of smoking is not permitted in patients who have pre-malignant lesions, and it puts them at higher risk. So my patients, they all know that smoking is all smoke. It's not only cigarette that is smoking. In Canada also we have cannabis smoking now. So all of these categories of smoking are not allowed or not permitted. Tolerance should be 0 for this. Obviously, if you have a patient that is smoker, as I said, you speak to them, you counsel them, you might refer them to their medical doctor to try to stop smoking, especially the ones that have been smoking for a long time. The other role that is important for the dentist is what we call the opportunistic screening. There is no need to do screening for oral cancer. There has been no studies that showed that screening for oral cancer will help improve the overall survival. But we recommend what we call the opportunistic screening. That means the patient, when they come to your office for a cavity, for wisdom teeth, for implants, it's a good time to screen and look at their oral cavity in general to detect if there is a white spot, some areas in their oral cavity, and again to counsel them if they have the risk factors and to manage them depending on the protocol that we discussed. So that's very important. Look at the white, the red, the white and red lesions, establish a diagnosis, or refer them if needed. But it's very important that you do a good screening of the soft tissue. As I say always to the dentist that I lecture to, don't only look at the teeth, but you're the specialist of the mouth. You're not only the specialist of the teeth, so look at every part of the mouth. Okay? If you do see a lesion, then you can do your own biopsy if you feel comfortable with that, to be able to establish a good histological diagnosis and then follow the patient. If not, well, it's probably time to refer the patient to a specialist that works in your area, an oral surgeon, or an oral pathologist or oral medicine. I don't know if you have the specialty of oral medicine here, you do. So you can refer to either oral and maxillofacial surgery or oral pathology to establish the diagnosis and to follow up these patients and give the treatment that is needed depending on the protocol that they're used. As a dentist also, you have a big role in the follow-up. Some of the patients, they don't want to come and see me as a specialist and at the same time, 2 months later see a dentist, and then because these lesions would like to see them every 6 months, but they are already seeing their dentist every 6 months, so the dentist can follow up on these lesions, and if there is any change, either they rebiopsy or they send the patient to us for rebiopsy. So your role as a dentist is important. Us also in our practice in Canada, what we do, we follow our patients for 5 years, but after 5 years, just not to overload the clinic, it's more for logistic reasons. We tell the patient, now we're gonna stop the follow-up, you can go and see your dentist. But the follow-up has to continue with the dentist, has to continue with a professional, so to keep looking at these patients. And this is also an important role for you as dentist to play on this level. I guess prevention, we just spoke about this. You might be involved also in seeing patients after chemoradiation, but this is a different topic. We're not going to go in details. That ends my presentation. I don't know if you have questions or, yes. Thank you.
And I'm afraid to tell the patient it is very dangerous. You must see a specialist, yes, or it is just lichen planus. Sometimes it is not equally bilateral.
Yeah.
Other question, what do you mean by observe? Observe after taking the biopsy or observe in general without biopsy?
Yeah. So first, the white lesion, it's important to establish a good diagnosis. So yes, lichen planus could present as a white lesion. Most of the time, if we want to speak about lichen planus, it's bilateral. You can see the Wyckham stria. You can see it everywhere on the tongue, on the gum. So if you are comfortable with the diagnosis of lichen planus, it's good. You have to establish a good diagnosis. If not, refer to someone in oral medicine or oral and maxillofacial surgery to give you the good diagnosis. So it could be other things also. The white lesion, as I said, so you have to make sure that you eliminate everything else. And then when you see the lesion, you have to be comfortable enough that, yes, this is a lesion that is white and has a risk of malignant transformation. So I guess that answers your first question. And it's not always easy. Sometimes, we might also be like, okay, what could it be? Now I need a biopsy. And then you need to biopsy the lesion to confirm what it is. You observe only after you establish the diagnosis. So when you see the patient, you have an idea of what's happening. And most of the cases, you probably need to do a biopsy to see what's happening. And when you do the biopsy, you establish a histological diagnosis. And if your diagnosis comes back as dysplasia, obviously on the biopsy, then you say, okay, I have a leukoplakia. You determine the risk of it, as we just did now. And then you observe. Let's say the decision is observation. It doesn't mean observation, okay, we let the patient go. It means that the patient has to come back and see you as a dentist or as a specialist. Or if you are a specialist and you can't see all these patients, make sure that they have a regular follow-up with their dentist. So you can't tell them, take your, go and then go do your things and don't worry about this. No, they have to come back and see a dentist regularly. Yeah.
Thank you very much. I'm afraid we need to stop now. Yeah, that was very informative.
Good.
Thank you, doctor. And
It's
please
my
accept
pleasure.
certificate of appreciation.
Oh, thank you. Thank you very much. Thank you. Shukran.
Thank you very much. I think that was a very nice warm-up. So I think now more interaction, more questions. Uh, Dr. Michael is an oral and maxillofacial surgeon with sub-specialization in maxillofacial oncology and microvascular reconstructive surgery. He received his bachelor's with distinction from the University of Alberta in biochemistry and his dental medicine degree at McGill University and his master's degree at the University of Michigan. He completed his residency training in oral and maxillofacial surgery, as well as fellowship in maxillofacial oncology and microvascular surgery at the University of Michigan. Dr. Michael is Associate Professor and Associate Dean of Postgraduate Dental Education at McGill University and Chief the Department of Dentistry and Oral Maxillofacial Surgery at the McGill University Health Center. Dr. Michael maintains an active academic practice at Montreal General Hospital, as well as being largely involved in resident and fellow training. His research interests are in translational research as pertains to craniofacial tissues engineering and quality assessment and outcomes in maxillofacial surgery. So Dr. Michael is presenting medically related osteonecrosis of the jaw, review and treatment protocol. So he is most welcome to start.
Good morning, everybody. Let me get my laptop all set up here, and then, yeah, USB, yeah, USB-C.
Kindly remind you after 30 minutes and then 15 minutes.
Sure, no problem. Yeah, weird.
Just remind you after 30 minutes.
You want, 10 minutes for questions? That's it? Okay, sure, no problem. اشتغل. Yeah, perfect. حتى نشوف Yeah, okay. Laser doesn't work too well on the screen, but that's okay. Okay. Good morning, everybody. Once again, thank you very, very much for the opportunity to be here and this kind invite to your beautiful country, beautiful people, and thank you to Dr. Abdelaziz Al-Musawi, who is training with us right now, and my clinical fellow at McGill University in head and neck oncology and microvascular reconstruction, for the very kind invitation. It's truly an honor to be here. For those of you guys that don't know, McGill University has a very prominent oral and maxillofacial surgery program in Montreal, Canada. I welcome all of you to check out our website. It's mcgill.ca/OMFS. We're very proud of what we do there, and we've graduated some of the best, I think anyways, oral surgeons across the world, which are doing great work and treating patients everywhere. So, we're going to talk about medically related osteonecrosis of the jaw this morning, and I'm going to try to keep you as awake as possible, okay, while we do it. We're going to review the history of it, the definition, incidence of the disease. We'll go through a little bit of the pathogenesis, the stages, and definition of MRONJ, as well as risk factors. We'll discuss the management of at-risk patients, which is probably the most relevant part as dentists and dental specialists. And finally, I'll introduce to you an algorithm that I use in the treatment of patients with all types of medically related osteonecrosis of the jaw. So, MRONJ, or necrosis of the jaw, really is nothing new. This has been described since back in the 19th century and early 20th century in people that used to make matches. And matches, of course, contain phosphorus. And that phosphorus, as they would make those matches, would be released into the air, and these patients would be affected. And as early, again, as 1858, a description of 60 workers in France talking about a mutilating and miserable jaw suppuration or pus inside the mandible. And then in Britain, another 61 patients where they describe a small pain that's related to an infected tooth, which then becomes an ulcer, and that ulcer leads to death of bone and a miserable, relentless disease. And if you look in the Royal College of Surgeons in London, you'll see pictures like this and some of the earliest noted MRONJ, or specimens of medically related osteonecrosis of the jaw, in the museum. So this is something that's been going on for, obviously, a very long time. But it wasn't until the year 2003 when there was a letter of the editor, which was very ground-shaking for oral and maxillofacial surgeons, by Dr. Bob Marks in Miami, who described 36 patients, all of which had either metastatic bone disease of breast cancer, prostate cancer, multiple myeloma. They're all taking a type of IV bisphosphonate to control this metastatic disease, and either on concurrent chemo, steroids, or radiation. And they presented with this, okay, necrotic bone in the jaw, which we'll see more of. He then did a follow-up study after this letter to the editor in 2005 to alert the community and what we now know as medically related, or at that time, bisphosphonate-related osteonecrosis of the jaw, describing an additional 119 cases. Again, all these folks having multiple myeloma or some sort of metastatic bone cancer. And finally, including a few patients that actually had osteoporosis. But again, the common theme was that these patients were all taking some type of bisphosphonate, hence the name bisphosphonate-related osteonecrosis of the jaw. And now in my practice, I see this everywhere. I have, fortunately or unfortunately, a large practice in necrotic bone, and we see it in the maxilla, the mandible, we see it in multiple sites, we see it in one site, but we see it everywhere, and it's all over our practices. So, I lost my screen. Let's talk about the definition of medically related osteonecrosis of the jaw. If you're interested, a brand new position paper from the American Association of Oral Maxillofacial Surgeons was published in 2002. The definition really is you have to satisfy these three categories: a patient that is currently on anti-resorptive medications or anti-angiogenic agents, which we'll discuss. They have exposed bone or bone that can be probed through a fistula that has persisted there for longer than 8 weeks. And the patient cannot have a history of radiation therapy to the jaws or any obvious metastatic bone disease, okay? So we don't want this to be a metastasis in the jaw. It's necrotic bone and not actual cancer. The nomenclature is different from the literature you read. Again, when it was first described by Marks, it was BRONJ, which was bisphosphonate-related osteonecrosis of the jaw. In the European literature, it was bisphosphonate-induced, bisphosphonate-associated. And then we went through the phase of thinking that the bisphosphonates lead to a predilection of developing osteomyelitis, hence the term bisphosphonate-associated osteomyelitis of the jaw, which then was replaced by a drug-related osteonecrosis of the jaw, then to anti-resorptive. Anyways, all these together, because the literature was evolving and the number of agents that can induce necrosis of the jaw was increasing, led to the term medically related osteonecrosis of the jaw, or MRONJ. Now, who gets this disease? Again, we sort of talked a little bit about it. You have the patients with metastatic bone disease. Largely, these are patients that have either breast or prostate cancer. We have patients that have multiple myeloma, so you know the classic x-ray of a patient with multiple myeloma with these radiolytic lesions in the skull. And of course, the biggest population of patients that we worry about are not really the ones that are coming in with cancer or cancer-related disease. It's our osteoporotic patients, which we have many, many, many of. What are the most common medications? Well, these are the most common bisphosphonates that people take for osteoporosis. Is the list right here. Alendronate, which is your Fosamax, which I don't know about in the Middle East, but obviously in North America was an extraordinarily popular drug for use in osteoporosis. You have Resendronate or Actonel, which has fallen a little bit out of favor. Zometa is a very popular drug, again, in North America, and the most popular administration of it is given every 12 months IV. So it's very important to know that medications for osteoporosis can either be given oral or IV. So if you see that a patient, or intramuscular, if a patient comes in and they get one single dose of Zometa per year, that means that they're being treated for osteoporosis. If they're getting one dose of Zometa per month, that means they're probably being treated for something more like a malignant disease or metastatic disease to the skeleton. The second major group of medications that we're going to discuss today are the rank L inhibitors, which are denosumab. Denosumab, again, the most common names are Prolia, which you may have, a lot of your patients are on these days, which is, again, an intramuscular medication used to treat osteoporosis. The exact same medication, which is called Xgeva, is given, again, monthly, and that is treated for more patients with multiple myeloma or metastatic bone cancer. Now, the most important part of knowing about this disease is the incidence, okay, and who this affects. Now, you have to remember during this whole talk, we're going to talk about, again, two groups of patients, those that are being treated with anti-resorptive medications for cancer and those for osteoporosis. Now, if we look at patients being treated with IV bisphosphonates like Zometa or IV zoledronic acid for cancer, the risk of osteonecrosis of the jaw is a little less than 5%. If you look through the literature, it goes anywhere from 0 to 18%. But the risk in randomized clinical trials is 2 to 10 times higher in these patients than those that are receiving placebo. So we know, obviously, there's an effect, and these patients have a higher risk of necrosis of the jaw. Those receiving Xgeva, okay, which is the rank L inhibitor that I just talked about, is, again, around 5% is what I quote my patients for those receiving monthly doses of Xgeva for cancer treatment. Now, if we look at bisphosphonates, the IV bisphosphonates that are given yearly or intramuscular bisphosphonates given yearly for osteoporosis, the risk could be around less than 0.2%. Okay, so there's a vast, vast difference between 5% in our cancer patients and the osteoporotic patients of less than 1%. Those that take oral bisphosphonates like Fosamax, excuse me, are a little less than 0.05%. And then finally, the rank L inhibitor, which the trade name here is Prolia, is around the same as the IV bisphosphonate, or around 0.2, 0.3%. So, where does this data come from? This is a very, very large retrospective study which is published by Kaiser Permanente, which is a very large healthcare group in North America. And what they did was they did a cross-sectional study of all their patients in this healthcare network of about 13,000 patients, 9,000 respondents of people who had osteoporosis, okay? Of these people that had osteoporosis, they asked in their survey of these 9,000 patients, how many of them developed osteonecrosis of the jaw? The rate in this study here is 0.1%. Okay, very, very low, again, on patients that were taking Fosamax and had osteoporosis. What was very interesting about this study is not really the 0.1%, but to me, in those respondents that had osteoporosis but weren't taking Fosamax, there was still a reported rate of 0.02% of osteonecrosis of the jaw. And again, they were taking no bisphosphonates but had only osteoporosis. So It's important to remember, and I'll talk about this a little bit later, that you don't necessarily only have to be on bisphosphonates to develop necrosis of the jaw. Now, of course, why is this an important issue? Again, I don't know about here. In Canada, it's probably more like here, but in the United States, you get sued for just speaking to a person the wrong way, right? So there's multiple lawsuits that revolved around Fosamax and all these anti-resorptive medications. In fact, it led to one of the biggest settlements that Merck had to offer, about $27 million to settle 1,200 osteonecrosis of the jaw cases, and lots of different lawyers out there and television ads in the United States to sue Merck through class action lawsuits. So let's go on and discuss a little bit more about the sort of pathophysiology of this medication. Again, this is a drug, or these drugs are very well known. They used to be used in the anti-scaling industry and automotive industry in 1860. Their use in bone mineralization around the 1960s started to come to realization, and then in the 80s is when we started prescribing this more for osteoporosis. And finally, in the early 2000s, for reasons that we'll talk about, this became a very, very, very popular drug for treating patients with malignant bone disease. And how do these medications work? Well, really, it all comes down to bone remodeling. And the majority of the physiology, or sort of the pathophysiology, relates to osteoclast differentiation leading to changes in bone remodeling. So let's look first at a group of drugs called bisphosphonates. Okay, and what are bisphosphonates? Simply, bisphosphonates have a phosphocarbon backbone, as you can see here. And then they have these different side chains, and these different side chains will relate to the different strengths and the different binding capabilities of this drug. But the most important factor is that phosphate carbon backbone allows it to integrate into hydroxyapatite into our bones, okay? And as I said here, you have all these different side chains, and these different side chains relate to different potencies. This most potent bisphosphonate that we give, again, this is why this one is used mostly for patients with metastatic bone disease, is zoledronic acid. You can see alendronate, which is Fosamax, is probably middle of the road, and then you have Iridia, which has fallen out of favor, is a little bit less potent than the other ones that are more commonly prescribed. Now, how does this work? So I just told you that bisphosphonates have this incredible phosphate carbon backbone. We take it, and once we take it, it gets embedded in the crystals of hydroxyapatite in our bone. And this will relate to something that's very important that we'll talk about after, which is drug holidays. But once it's embedded in the hydroxyapatite of bone, it remains in the hydroxyapatite of bone. And the half-life of these drugs is somewhere around 25 to 27 years because they're embedded in the crystals. So with bone remodeling, we all have normal bone remodeling. Our osteoclasts start activating. The osteoclasts start eating away the bone. The bisphosphonate gets taken up by the osteoclast, and that causes death that we'll see through different mechanisms of those osteoclasts, leading to, obviously, a stop in the bone remodeling cycle. On a cellular level, bisphosphonates cause an inhibition of a very important protein called a farnesyl pyrophosphate synthetase. I can't believe I said that on 2 hours of sleep, bravo. And so by inhibiting this very important protein, what happens is that you get many different effects. One of those effects is decreasing the differentiation of plasma cells into osteoblasts. You get an inhibition of the very important rank receptor that comes off of the osteoclast and leads to differentiation of osteoclasts. And then finally, bisphosphonates, through the inhibition of this protein, will also cause apoptosis, or cellular death. Another very important mechanism of action, which was only elucidated in the last, I guess, 20, 30 years, really is the ability of bisphosphonates to inhibit angiogenesis. And this is the really important role in high doses that bisphosphonates are given for metastatic bone disease. By inhibiting osteogenesis, we have a decrease of the metastatic bone tumor's lytic effect on the skeleton, which is why, again, it's given for cancer. How about RANKL inhibitors? So this is denosumab, this is Prolia, this is Xgeva. How do those work? So the RANK receptor is possibly the most important receptor that is expressed by pre-osteoclasts and osteoclasts, which lead to activation of the bone remodeling cycle. And they have to bind this little protein called RANK, or RANK ligand, excuse me. Denosumab itself is a soluble antibody which competitively binds the RANK ligand so that it can no longer bind the receptor on the osteoclast, again, leading to apoptosis of these cells because they don't get stimulated and stopping the bone remodeling cycle. A very interesting story about denosumab. Denosumab in 2009 in the New England Journal of Medicine was published, and there was a lot of excitement about this medication because after they started using it for osteoporosis in postmenopausal women, they found that, again in 2009, the incidence of osteonecrosis of the jaw was 0 on this medication. And everyone was excited as it could be a potential replacement for Fosamax, and we'd get rid of this risk of osteonecrosis of the jaw. It was about 7 years later where the FDA had then updated the black box warning on Prolia and Xgeva, stating that there is indeed a risk of osteonecrosis of the jaw, and it's something that we have to all be very aware of. So how does MRONJ occur? Now that we understand a little bit of the boring sort of cellular activity of how these medications work, how does MRONJ happen? So there's a lot of potential mechanisms out there. But it all really comes down to the effects on these medications on the osteoclast, like I spoke about, suppressing them and causing apoptosis. Both of these medications actually have an immunosuppressing effect on our immune system. Remodeling we talked about, endothelium we talked about, as well as ischemia, leading to a decrease of vascularization and toxicity of the soft tissue. So in practice, how does this work? In practice, well, we have patients that are on these medications. As we all know, the alveolar bone is under a very high level of remodeling due to occlusion and constant microtrauma on that bone. And when patients come in, and one of the theories is for, say, a tooth extraction in the area, you get release of the bisphosphonates from the bone into the soft tissue, leading to a local ischemic reaction or necrosis in the soft tissue, which then leads to exposure of the bone in a bone that has a decreased ability to remodel, making it susceptible to osteomyelitis, infections, etc., and propagation of necrosis across those structures. So, why is it important to know all of this? Well, I can tell you that on almost all of our medical history intake forms that we use in the hospital, in my practice, we always ask about patients, ask in our history if patients have a history of osteoporosis, because it's very important for us to know the risk factor for developing MRONJ, and in our medical history, if these patients are taking bisphosphonates or Prolia, it's important to know what the indication is. Again, you know, a patient taking it for cancer is very different than a patient taking it for osteoporosis. It's important to ask the type, the dose, the frequency. Is it once a year? Is it once a month? The duration. Comorbid states are extraordinarily important to know about, okay? Yes, if a patient has osteoporosis and is taking Fosamax, let's say, but they also have lupus and are taking high-level corticosteroids, that automatically increases the risk of developing osteonecrosis of the jaw. Other things include anemia, patients that are malnutritioned or cachectic, menopause, and of course smoking and alcohol. Co-medications, I talked about corticosteroids, patients that are being treated for chemotherapy, for any other type of cancers, anti-angiogenics, anything that really affects tissue healing or bone healing. Oops. Our clinical assessment, so we know that these patients have a risk. What are they coming in for, right? So if they're coming in for a routine cleaning and anything that is above the gum, the risk is low. But if they're coming in for alveolar surgeries, extractions, bone grafts, deep cleanings or periodontal therapy, obviously the risk is higher. Comorbid oral disease states. So it's been also shown that patients with periodontitis or aggressive periodontitis or mucosal diseases have an increased risk of osteonecrosis of the jaw, particularly if they're susceptible due to medication, poor oral hygiene. And then finally, one of the most important issues to ask is when you have a patient in your clinic who's on this medication, is to see when they started taking the medication, because we know that there is a time effect, and those that may have been on the medication for 1 year have less of a risk than those that have been on it for several years, and most notably the magic number for patients that are receiving oral bisphosphonates is around 4 years. What are the vulnerable sites? Well, you have alveolar bone, obviously, which I just discussed. The mandible is more susceptible than the maxilla. Tori are very susceptible, most likely due in the mandible due to a very thin mucosal lining in the area. And very interestingly, there's also a large report of mid-shaft femur fractures in patients that take alendronate or Fosamax. The symptoms associated with this disorder, well, pain, obviously, swelling, infection, you can have loosening of the teeth, you have your exposed bone that you can see in that picture. This can occur spontaneously, or most of the time it occurs after some type of alveolar surgery. And lots and lots of our patients may be walking around with necrotic bone but have absolutely no symptoms. So our physical exam, what are we looking for? This one's obvious, right? Necrotic bone everywhere. Sometimes they present just with fistulas that are probable with or without suppuration or pus in the area. Sometimes it can be a dry fistula with absolutely no pus. If they have a very large infection, obviously swelling in the face and neck, drainage, and loosening of teeth. How about imaging? Can that help us? Obviously, of course it can. The imaging used, you use your routine Panorex, you can use CBCT, medical grade CTs, MRIs, bone scans, and PET CTs. Conventional radiography, so here you can see, again, sorry, I don't have a pointer here that works, but you can see in this area some osteolytic lesions of the bone on the right side. You also have areas of osteosclerosis that occur. CT scans are great to see sequestrum, so you can see a very large sequestrum here forming in the left maxilla. Loss of cortication of the mandible here on the lingual and buccal aspect. Periosteal reactions, most likely secondary to a chronic or an acute on chronic osteomyelitis of the area, so you can see the expansion or periosteal thickening in that area. And then a delayed healing of extraction sites on the bottom there. Some early signs, which we'll discuss as well, are thickening of the periodontal ligament space. So you can see here a very thickened lamina dura around these teeth on this periapical. And then finally, a very, very easy one is pathologic fractures, which you see in late stage osteomyelitis. Can MRI help? Well, MRI does help because you can see very well marrow changes, especially in acute osteomyelitis. So if you get an MRI on T1 weighted imaging, you'll see a low density signal, which is here. You can see the marrow is quite bright everywhere except here in the anterior, which is a sign that that marrow has probably an infectious process going on. On T2 weighted images, you see the opposite. So you'll see a brightening of that area, and if you have gadolinium that's given as a contrast, you'll see thickening of the soft tissues due to the infection due to gadolinium in the area. A very interesting article in the Journal of Oral Maxillofacial Surgery is using a PET scan or a PET CT scan to detect early lesions in patients that are at risk, and so these are all patients that have no necrosis of bone in the area. but may have some type of symptoms. So we'll talk about that in our staging. And they get these PET scans, and they can see that there's a activity without necrosis of bone in the area. Again, a little bit experimental. We don't necessarily order them, but it's an interesting concept. So now that we've discussed a bit of the imaging, we have to talk about staging. Staging is very, very important for medically related osteonecrosis of the jaw. Our biggest stage is those that are at risk. And what's an at-risk person? Well, we discussed it already. Those that are taking any type of anti-resorptive medication, but they're asymptomatic, they have no exposed bone. Stage 0 MRONJ is really those patients that I was alluding to in the last slide with the PET scan, are those that have these weird non-specific symptoms. They're at risk because they take the medication, but they have no exposed bone. So what are those symptoms? It can be pain, it can be sinus pain, it can be altered sensation in V2 or V3 distribution of the face. They can have loosening of teeth and fistula, again, but with no exposed bone in the mouth. And radiographically, we can see a whole host of changes in the bone, anywhere from thickening of the PDL space all the way to osteosclerosis and osteolysis, but not having any exposure. Stage 1 are those patients that have exposed bone in the mouth but no signs of infection. Normally, these patients come in asymptomatically and don't really have many symptoms when they come in, except for they were noted by their dentist to have lesions in their mouth with exposed bone. Again, the radiographic signs are very similar to what we just discussed. Stage 2 is the same, except you have evidence of infection, okay? So here you can see pus in that bottom middle photo on the right-hand side, associated with some exposed bone there. The same on the lingual aspect of the left mandible down there. The radiographic signs are very, very similar. The most key difference here is you have suppuration, or you have pus exposed with the exposed bone. And finally, stage 3, which is the last stage of MRONJ, are those with exposed bone, evidence of infection with one or more of the following. Either you have necrotic bone beyond the level of the alveolus. So here in the new update, it's really below the level of the inferior alveolar nerve, or at the floor of the sinus or above the sinus. Those that have pathological fracture, okay, mostly occurs obviously in the mandible, and either a fistula that is extending to the face or to the cheek or the neck, and oral antral or oral nasal communication. So, how do we treat these patients? So now we know about the risks and the staging and the radiology. We have to know how to deal with them when we see them. So let's first talk about our at-risk patients. Why is it important to know how to treat our at-risk patients? Obviously, because what we do as dentists or oral surgeons, as periodontists, can take a person from at risk to having necrosis of the jaw. And so if you look at some of these studies, this is from the Journal of Clinical Oncology. Again, it's important to know when you're reading to look at what you're reading. And this is looking at patients that are receiving bisphosphonates, for cancer-related treatment. So very high-level bisphosphonate therapy. Patients have a 33-time increase in osteonecrosis of the jaw when undergoing things like dental extractions or dental alveolar surgery. Denture use was also a risk factor, obviously because of what we talked about in the area of the tori and the thin mucosa. And so the risk is quite high in these patients on high dose. So the management of these patients, again, patients that have cancer, prior to initiating therapy, I believe anyone who is going to get bisphosphonates for cancer treatment should see a dentist before. It's just like a patient who's going to have radiation to the head and neck. They should see a dentist prior to starting radiation to avoid any incidents after. And that means extraction of hopeless teeth, stabilizing the periodontal disease if they have any, and optimizing oral health. Now, what if you don't see them before, or they have complications during treatment? Well, you want to avoid alveolar surgery as much as possible, okay? And that means possibly doing coronectomies with root canal treatments to leave the roots in place. It is, however, very important to know that you have to treat the infection. And so this is sometimes a very hard thing to deal with. If you have a patient who's at very high risk, but they have an infected tooth, okay, or they have infection that extends outside of the periapical area, maybe they have swelling in the vestibule and they have a lot of osteolytic changes around that tooth due to infection, leaving that tooth and saying you're going to do a coronectomy and a root canal treatment could be just as much detrimental than removing the tooth. And so at some point, you have really no choice. You have to remove the tooth if you have lots of infection in the area. And unfortunately, more times than not, these folks will develop some osteonecrosis of the jaw. Patients that have osteoporosis, well, prior to initiating therapy, I mean, do they really need to get cleared before they start Fosamax for osteoporosis? No, they don't, because we saw in the incidents before that the rate is very, very low. But it is important for them to maintain proper oral hygiene and have good follow-up with their dentist. How about during treatment? Now, this is always a question that I get all the time. So again, remember that the risk is quite low on patients that have osteoporosis and are taking bisphosphonates. And so does that mean we can't do dentoalveolar surgery on them? The answer is no, it's not. But informed consent is very, very, very important for these patients, okay? So I always have the discussion with them. Look, there is a tiny risk of increased risk of osteonecrosis of the jaw due to the medication you're taking. However, the risk is really 2 out of 10,000, which is really quite low. What about drug holidays? So this is a very popular topic, and lots of people ask me questions about it. So drug holidays for patients on osteoporosis medications, there's very limited data to support this. There are some regimens of 3 months on and 3 months off. For Prolia, there's a 6-month holiday that is being described and skipping 1 dose. Again, as I discussed earlier, you have to really know how long your patients have been on the medication and if they have any comorbid risks like rheumatoid arthritis, diabetes, they take high glucocorticoids, or they're heavy smokers. But what's important to know is that the FDA in the United States has really released a paper, again, this is for patients being treated for osteoporosis and bisphosphonates, that there is no substantial data to suggest that stopping medication will do anything to decrease the risk of developing osteonecrosis of the jaw, okay? So I personally, in my practice, do not stop patients on bisphosphonates or Prolia if they're getting dentoalveolar surgery. However, as I just mentioned, I do consent them and let them know of the risk. And that's basically a consent that talks about the risk of osteonecrosis of the jaw. Now, what about drug holidays for patients that are on high-level bisphosphonates or Xgeva? Now, it's really, really important here that we weigh the risk and benefit. And you always have to think and make a decision with that patient's medical oncologist, what is the best interest of that patient? Now, if they're taking Xgeva and it's stopping the growth of the metastatic disease in their vertebrae, which is keeping their spine from collapsing and causing them to become a paraplegic, well then obviously you don't want to stop that medication, okay? It's very, very rare that we would stop these medications for these patients unless they have very severe osteonecrosis and have to undergo major surgery, which I'll talk about here in a few minutes. So that's dealing with stage 0. Sorry, that's our at-risk patients. For stage 0, it's quite simple. If you remember, stage 0 are patients that have a history of use of this medication, have some non-specific symptoms, so you want to control that. Usually we give them Paradex mouth rinses, we control their pain, and we monitor them because they have no exposed bone in their mouth. So there's really not much to do for a stage 0 patient. What about stages 1, 2, and 3? Exposed bone with infection, or exposed bone that extends through the whole thickness of the bone leading to fracture or fistulas in the face. How do we treat those? Well, there's 3 basic ways to treat patients with necrosis of the jaw, and that is conservative medical treatment, which is normally either antibiotics, always Paradex, and pain control treatment. Conservative surgical treatment, which involves really curettage or sequestrectomy of the area, and extensive surgical treatment, which can either mean if the disease is above, say, the inferior alveolar nerve, which would treating that would result in a marginal mandibulectomy or a sort of marginal resection of bone, versus if it's extending all the way down to the inferior border of the mandible, which you would have to do a complete resection, which we'll go over. So, the tenets of treating these patients has actually changed quite a bit. I finished my residency in 2011, I think, and in 2011, the way I was treating, I was taught to treat patients with MRONJ is quite different than the way I treat them now. And the reason is, it really came down from this article in 2005 in the teachings of Bob Marks, who was the godfather of osteonecrosis of the jaw. And really what he said is that you should do nothing to these patients, and that living with necrotic bone is just what's going to happen for them, and there's not much we can do about it, okay? And why did he say that? Because he wanted to cause no harm. And causing no harm was, well, some of these patients have cancer, right? They have metastatic cancer. Why would you go do surgery on someone who has metastatic cancer? It doesn't really make sense because of the outlook of their life. Progression of disease because we know that I told you that these bisphosphonates penetrate all the bone and hydroxyapatite in your jaw. So if we go in there and stir something up and do some debridement, maybe we cause more problems, right? And complexities of treatment. Well, these are very hard surgeries on healthy patients, regardless if they start taking these medications, it just becomes more harder and more complex. So let's go through these reasons and see why the treatments have sort of changed and what people are doing now to treat these patients. So let's start with quality of life. So again, the majority of patients with osteonecrosis of the jaw have metastatic bone disease or multiple myeloma, are on high-dose anti-resorptive medications, but there's a lot more of these patients, and there's a lot more of these patients living a very long time. Metastatic bone disease from breast and prostate cancer is not a very terminal disease anymore, especially with immunotherapy and advanced chemotherapy. So they can live many, many years with stable disease. However, sometimes they have more pain from the recurrent infections, broken jawbone, than they do from their metastatic bone disease. So we have to treat these patients. And in fact, this is a study from the Journal of Oral Oncology, which looked at the quality of life of patients with stage 2 and 3 MRONJ that had metastatic bone cancer. All of them were treated with some sort of resection, either a marginal resection of bone or a segmental resection of bone, and all of them had an improvement in their quality of life through their quality of life assessment. 3 of them notably had recurrent pain during the study, and all 3 of those that developed recurrent pain actually developed recurrent osteonecrosis of the jaw. So the pain was really a herring to tell us that they're going to have more necrosis in their mouth. And this is a case that I did a few years ago. This is a lady with metastatic breast cancer, as you can see in the scrolling CT scan here. Let me see if I can get it to come back. She has a osteonecrosis of the left mandible, which goes down to the inferior border. She has a transcutaneous fistula in the left neck there, which means she's stage 3 disease. Again, she had stable metastatic breast cancer and otherwise was not very unhealthy. So we took her to the operating room. We did a resection of the jaw. You can see the pathological fracture that she has in the area. When we do these resections, it's very important that we go to healthy bone. So on the back there, you can see that that bone is much different looking than the one where you have the fracture in the area. So we can't leave her without a jaw, and so I went and I harvested a piece of her scapula with some soft tissue and skin to close the hole in her mouth. And we harvest this with the blood vessels in the back, and we take those blood vessels and reconnect them in the neck so that bone is immediately vascularized and is not just a bone graft, but more of a tissue transplant from the back. And that's what that bone looks like there with the blood vessels that we revascularize with. And this is here 2 years post-op, and what's really remarkable here is you can see that the bone that we resected, the healthy bone here, had healed mostly to the scapula on the side, and so those two healthy pieces of bone had formed a union and healed like normal bone would heal. And that's her 3 years post-op, and then I haven't seen her since. I don't know if she died of her metastatic bone disease, but the important thing is she was suffering beforehand because of this pathological fracture, and we improved her quality of life by doing this. This is another case that my friend, Dr. Al-Hakim, who you just heard, did many years ago, but it's a really great case to show the quality of life. And this is a patient that had again, a stage 3 osteonecrosis of the jaw, the right mandible. She was on an experimental treatment for back pain, getting high-dose IV bisphosphonates. And so here he had resected the jaw, very similar to what I showed you, to healthy area of bone. He put in this piece of leg bone called fibular bone and reconstructed her. But the reason why I show this case is I don't get many of my patients come back for dental implants. Dr. Al-Hakim is better at selling dental implants than me, I guess. But here she came back, and this is a lady who had necrosis, right? And then we were able, or he was able, to put in these implants on her and get her to a state where she actually has teeth again after having a pathological fracture due to necrosis of the jaw. So, quality of life, yes, when I was in training, we were not supposed to touch these patients with a 10-foot pole, okay? And you let them have their exposed bone and you treat their infections with antibiotics and you leave them alone. However, I think that appropriate selection of patients and appropriate interventions can improve the quality of life in these patients. What about this disease progression? And this really made a lot of sense to me again as I was training. I had an attending, Dr. Hellman, who always used to tell me, Nick, osteonecrosis that you see in the mouth is only the tip of the iceberg. And the tip of the iceberg, because everything underneath was necrosed, and if you touch it, it's all going to fall apart, and they're all going to do terrible, okay? And that's the leading theory as to why people never used to treat this. And when I first started out of residency, I had a patient here who presented with a very similar thing. He had, in this photo, this is stage 1 osteonecrosis of the jaw. I don't know if you could see it, but there's necrotic bone on the lingual aspect of the right mandible. There's a little bit of osteosclerotic and osteolytic change there on the panorex. So I said to myself, I'm not going to do anything here. I'm going to treat him with antibiotics when he has infection. When there's dead bone that's mobile in the mouth, I'm just going to push it out and we're going to get rid of it and we're going to leave it alone. And so I did that for several years, 2 or 3 years. He kept coming back. He kept having more infections, more antibiotics. And I kept removing just little bits of bone on him until after a couple of years of me doing conservative treatment, he shows up looking like this and having necrosis from here to here and all the way down to the inferior border of the mandible. And after learning from that case, I went back and I looked at all the literature and looking at systemic reviews and treatment approaches for bisphosphonate-related osteonecrosis of the jaw. And I found a very good systematic review, reviewed 22 studies. There was hundreds of patients that they looked at through all of these different studies. The important thing to know is that this is a trend that you see. Non-surgical patients, stage 1, if you treat them with just medication and antibiotics, a little more than 25, 27, and 29%, will have resolution and go back to stage 0. You treat them with conservative therapy, it's higher. Treat them with a marginal mandibulectomy or like just cutting out the bone to healthy bone there. They have a much higher response rate. The same trend for stage 2, and obviously stage 3, medical treatment had a 0% success rate, and all of them needed either conservative surgical therapy or extensive therapy. And so that's my patient, Mr. Ziadi again. And with his area that now has a very large, extensive area, of necrotic bone, we take him, we do a resection of the mandible to remove all of it to healthy margins. And then Dr. Al-Hakim and I go ahead and do a reconstruction with a piece of his leg bone, his fibula, and cure him of his osteonecrosis. And that's the inside of his mouth. That's not bone, by the way, that's leg skin that we transplant with the fibula in the mouth, and everything is healed and closed, and he's doing well. The same thing applies to the maxilla, and here's a patient that was treated with conservative therapy, not by me, but someone else in the community, over many, many years of just getting antibiotics and Paradex or chlorhexidine mouth rinse, and came to us with a very large oral antral communication in the maxilla. Here we have to plan. It's much harder, obviously, to do these surgeries on the maxilla due to the 3D complexities of the zygomatic buttress and the piriform buttress, but we plan a nice resection in the area to remove all the dead bone. This is an example of the leg bone that we harvest from the leg, the fibular bone with the blood vessels and a piece of skin attached. And we use that to reconstruct the maxilla and close the hole with a piece of skin that we take from the leg. Now, finally, there are other arguments to be made when we talk about reconstructive surgery on patients that have a predilection for bisphosphonate-related osteonecrosis of the jaw, or MRONJ, in that if you go and you strip the periosteum of the bone, that can lead to necrosis. The patient population is obviously not healthy enough to have these surgeries. And if you think about it, the bisphosphonates that you take are systemic. So it should really affect your leg bone. As you see, it doesn't really because it heals, as well as your jaw bones. And some of the first people that published on the use of this extensive therapy or vascularized reconstruction are from LSU on this patient population. And here they only reported 2 patients, but it was one of the first times that we heard about the possibility of doing this on these patients. This is followed up by a larger study from an ENT group out in Portland. And they show that all of these patients here were treated with this very extensive surgery. They all had either multiple myeloma or metastatic cancer and stage 2 or 3 MRONJ and at least one comorbidity. In their study, they showed minor complications, which we'd expect from this type of surgery. One failed reconstruction or one failed flap, but more importantly, to me, this study showed out of all these 13 patients, none of them had malunion, which means the bone healed in all 13 patients. None of them had recurrent disease because in theory you would have resected all of that to a clean, healthy margin. And all of them went on to resume a normal diet, et cetera, et cetera. So, my sort of treatment algorithm for these patients, as I wrap up here, I hope I'm doing well on time, is stage 0, no exposed bone on these patients. You treat them for symptom control, pain medication, Paradex usually I give to them. You want to make sure you remove any precipitating factors. If they have a denture that's rubbing on the inside of their jaw, that it's relieved and all these sorts of things. Stage 1, exposed bone with no infection, chlorhexidine mouth rinses. You can remove the mobile bone if there's any mobile bone in the mouth gently. If that doesn't work, I move to a sequestrectomy in cleaning the bone and doing a very good curetting to healthy bone margins and monitoring them. Stage 2, those with exposed bone above the inferior alveolar nerve and below the sinus with infection. Obviously, we treat them with antibiotics. My antibiotic of choice for this disease is usually using something like Avelox or moxifloxacin because the IV, oral bioavailability is equivalent to IV, and I do that for 6 weeks typically. Treat them with chlorhexidine. They don't have any response. I will give them one trial of a conservative surgical therapy, sequestrectomy, cleaning the bone very well, and if not, then we proceed to more of a marginal mandibulectomy in that area or resection as needed. And then finally, stage 3, typically we have to treat them with IV antibiotics, and then because the amount of necrosis is so extensive and going to the inferior border, typically they need extensive surgery if they can withstand it, which includes resection and reconstruction. So, do no harm. I think we can improve quality of life. We can decrease the progression of disease by doing surgery. And I think we can treat these patients with the appropriate level of complexity as long as we do appropriate case selection. And again, I welcome you all to come visit our wonderful program in Montreal. Don't come in the winter if you don't have to. Otherwise, if you have any questions, I'm available for you. Thank you.
Thank you. see people came up with questions.
Thank you, Doctor, for the amazing lecture. My question is about timing. What the meaning of during, and if there is any after? My question rephrased, like during, if the patient is taking bisphosphonates, sometimes like a yearly injection or every 6 months, is the drug like engraved in the bones that will never go out and there is no after treatment? Like it's always there?
So that's a great question. For bisphosphonates, the half-life, as I said, is in the 25, 27 years, okay? So stopping the drug will not necessarily do anything to change the amount of drug that's in the bone. Some people say that it decreases the level of soft tissue toxicity if they're off the medication, but there's no evidence to substantiate that. And so you cannot make the promise. Say a patient comes in who's on yearly Zometa injections for osteoporosis, and they want an implant. I cannot promise them that if I tell them, come back 1 year later, and you will have no risk of osteonecrosis of the jaw. You can't make that promise, right? Instead, I counsel them and tell them that you have a risk. The risk is very low, but it may be higher than the risk of someone else who's not on the medication. But it is very, very low, and I monitor them after I do any surgery on them. Now, the same does not apply for a patient on Prolia, because Prolia, as you saw, the mechanism of action is it's a monoclonal antibody, and that can be sort of wiped out of the system faster than something that integrates into the crystal of the bone. Now, there's no data to substantiate stopping it or not yet. And some people say you wait 6 months and that'll clear it out of the system, and then you do your surgery, and then wait 6 months after your surgery to get your next dose. Again, there's no evidence for or against. In the next few years, we may know because more people are doing that regimen. And when I talk to my patients who are on Prolia, if I tell them there's a risk of necrosis of your jawbone and they jump out of the chair and they're like, no, 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 I don't want that, then I say, okay, then wait 6 months, come back, we'll place your implant, and then in another 6 months, you take your medication. Why? It's osteoporosis. If they miss 1 year, it might not be the end of the world if they're not very, very, very osteoporotic, okay? But if they're saying, okay, I understand, doctor, there's a risk, the risk is low, but I want to get my implant, I make sure it's noted in their consent and that they know. Good. Thank you.
Thank you. Dr. Nick, can you please accept certificate of appreciation? Photos.
Test 1, 2, 3. تعال شلون will start again in about 5 minutes time. Welcome back from the break. Our next speaker is a German and European board certified oral and maxillofacial surgeon, fellow of the European Board of Maxillofacial Head and Neck Surgery. He is a licensed physician and dentist in Kuwait in Germany. He is currently working as an assistant professor of oral and maxillofacial surgery at Kuwait University. He is also a well-published doctor in several international and medical journals. Please welcome Dr. Mohammed Kamal.
Good afternoon or good morning, everyone, and welcome to this lecture. Okay, good morning, everyone, and welcome to our lecture today. Is going to be about utilizing advanced digital technology in orthodontic surgery. My name is Mohammed Kamal. I am an assistant professor at Kuwait University. I've completed my undergraduate studies in dentistry at Boston University. My medical education, I spent it between the University of California, San Francisco, and the American University of Beirut. I then completed my training in maxillofacial surgery at Aachen University Hospital in Germany and completed my PhD at the University of Maastricht in the Netherlands. So the reason I'm telling you this, because across the years, I came across so many technological advances in different countries, in different departments, and now it's our job to amalgamate all of this and try to combine them together to deliver the best protocol for our patients. Before I start, I'm going to go ahead and express our solidarity with the doctors in Gaza. It is devastating. This data is from day 45, and now it's day 48. We have a huge number of casualties, and here we have Dr. Ghassan Abu Sitta, who was born in Kuwait, born and raised in Kuwait, and he was a chairman of the Plastic and Reconstructive Surgery Department at the American University of Beirut when I was there. He's a close friend, so I learned a lot from him. We operated a lot together, and it is heartbreaking for me to see him standing in this epical picture in which surrounded by corpses. So again, we'd like to express our solidarity. So let's go ahead. When we're talking about dentofacial deformities, we're talking about a patient that comes to you having some sort of a malocclusion that is complex enough not to be able to be treated by orthodontic treatment. So in this case, we have a patient with an open bite and biting only on the posterior molars. The patient here was taking orthodontic treatment and tried for so many years. So now this is after 8 years of orthodontic treatment, and still he's trying to solve the issue by receiving only orthodontic therapy. But is it possible? So it is, you can see, we can appreciate that the occlusion is completely off. It's open from the first molar all the way to the anteriors, and we had to convince the patient that this case cannot be handled using orthodontic treatment. So these kind of cases are the cases that we call surgical orthodontic cases. Let's look at the CT scan. So if you take a 3D CT scan of the patient, you can appreciate the occlusion, how it looks, and this patient was unable, like his description, I was unable throughout my life to bite on an apple, or a piece of an apple or carrot. So it is difficult for them to bite and chew and function properly, and if you look at the hygiene is compromised in these cases. So we need to evaluate these cases carefully so that we can find out what is the best treatment approach for them. We know it's going to be a surgical case. We need a comprehensive approach when we treatment plan these cases. We have to know there are many technological advances being available in the market. And the technology, we have to utilize it in a way that makes the process of performing the surgery easier and more accurate. But this also comes with a special learning curve and extra education that you spend time trying to attaining it. So our focus is not to increase the speed of the surgery. Our focus is to increase accuracy. In the old days, so this picture from my residency days in San Francisco, we used to take regular impression, manual impression, pour them in plaster models, and take a lateral cephalogram and measure the cephalometric value, the SNA, the SMB, width appraisal. And we had to sit, like you can see me with the textbook here, trying to write down all the numbers, come up with a plan, think simultaneously, and read at the same time, trying to come up with the best plan for this case. And the best that could be done from this point on is to use a semi-adjustable articulator and try to do the model surgery. So if you look down here, you see that the mandible, the lower cast was separated. It was moved, and we mark it with a pencil, and then we measure. So if we plan to move a jaw in a certain direction, we do it on a plaster models. Now, what about the soft tissue changes in the face? Well, there are soft tissue changes, but we were not able to predict that before. We had to do the model surgery, perform the surgery, wait for a few months. Of course, soft tissue changes will take a long time for it to manifest. So we had to wait few months, 6 months to 9 months, and then perform retrospective studies and evaluations in order to know exactly what has happened. But now we have many technological advances such as the cone beam CT. It allows us to get a 3-dimensional and a 3D skull that is accurate and with high precision. Intraoral scans, now they are considered ubiquitous. We use them a lot on a daily basis in orthodontics and prosthodontics and all across digital dentistry. We're using intraoral scans to create 3D digital occlusion. What about the printers? Now, printing using 3D printing technology is becoming more affordable. It used to be expensive in the past, but nowadays it's more affordable. You can buy a printer, keep it at home, and print your own cast. So 3D printing now is possible. Facial scanning, this is the latest technology that is becoming available, in which there are cameras that you can use to capture the face from the outside using 3D technology, and that's called 3D facial scanner. Then there are special surgical planning software, in which these softwares, you combine all of these data. So all of these data that you acquire digitally, you can feed them into a software, and based on your clinical evaluation that is done and you enter the data in the software, you are able to simulate the surgery and plan your surgical steps. And then you plan your surgical guides and you plan your surgical splint. Then again, using special 3D printers, you can print the splint or the surgical guide, or you can use higher resolution 3D printing of titanium and print the actual plates and screws. Now we are using prefabricated plates and screws, but with the modern technology, you can also print your plates and screws. And you enter the surgical procedure with a step-by-step surgical protocol that is printed, and you can take it to the OR and follow it like a recipe. A recipe that is written by you, that is designed by you. So, 3D facial scanner. This is a technology that ranges from stationary to mobile to telephone-based facial scanner, and then the intraoral scanners and the 3D CBCTs, all of these are done separately. Each of them is executed in a precise way. Then you get these data and you put them into the software. You have to have an accurate clinical examination. You have to have a special form to evaluate everything in the oral cavity and from the outside, in order to feed that data into the software and plan surgically. Remember, no matter what you do, there is no substitute for your clinical examination. Examination is the pivot point of this workout completely. So, clinical exam, digital data, digital workflow, and from that we can take a step further and evaluate. So, evaluate the facial proportions, evaluate for symmetry and asymmetry, and then you can predict your surgical procedures. You perform the surgery digitally and virtually. From that, you create a surgical splint. A surgical splint, the white one and the pink one, these are surgical splint and a surgical guide that tells us how we're going to move the maxilla and the mandible. This is the most accurate way so far to deliver the information from the software to the surgical procedure by having some sort of occlusal splints, and it's called wafers as well. So also you can define the nerve, so you can know exactly where to avoid the nerve. So once you have the splint, that is digital information, you convert it to your printer. Using the 3D printer, you can print your splint and then go ahead and using that to perform the actual surgical procedure. Now, you can see here these scanners from the outside, from the oral cavity, but if you focus on the facial scanners, what's going to be adding to our surgical planning if we use them regularly and routinely? And these facial scanners would allow us to evaluate the face from the outside. So in the past, we used to evaluate the occlusion and try to do the surgery based on occlusal correction. But now we are doing facial correction. Look at this patient with class 3 deformity. We have to advance the maxilla. If you look at the video here of the profile, I'm going to advance the maxilla. You can see how the nose is changing. Not only the nose, we're talking about the whole centrofacial area is changing. The nasolabial fold, the infraorbital area, the whole central part of the face in terms of soft tissue is changing. And the morphology of the face is all changing together simultaneously when we conduct the procedure. Now, is that a good thing or a bad thing? Keep in mind that when we do a movement, we do it in a 3D. Is that a good thing or a bad thing? Let's have a look. We have a patient here on the left. This is before surgery. And let's look after surgery. I'm going to put it in a 3D format. Look at the patient after surgery. We're talking about 2.5 months after surgery. We can look sideways, up and down, and the procedure that was done was only Bimax in this case, just doing the right movement in terms of maxillary advancement, mandibular advancement, no setback, correction of asymmetry, and tilting the occlusal plane altogether. But what do we have here? We do have nasal changes. Most patients will be worried and asking about these nasal changes. So there is increased nostril visibility. There is nasal tip up rotation. So the nasal tip goes up. This is nasal change. So some patients are worried about it. And there is increased widening of the nasal alar base. So widening of the nose. And these are scary terms when you look at them. But look at the actual result. Is that a favorable or unfavorable outcome? Once you have a solid understanding of how the skeletal movement will affect the soft tissue of the face, then we can predict our movements. We can try to decrease the unfavorable effects and accentuate the favorable effects. So having nasal changes after orthognathic surgery or having soft tissue changes is not a bad thing. It is a thing that we have to modify, and according to our modification and understanding of the procedure, we can make it bad or good. So why do we have these soft tissue changes? Because the surgeries are like this, and the artist trying to make it nice, but it is still aggressive. Look how many retractors in the face. Look at the detachment of the muscles and the mucosa and the area of exposure. All of this is a major stripping and severance of the muscles. Look at this area, the area that is outlined by the black line. This is the area of degloving. Degloving means area of exposure. So everything in this area has been manipulated and pushed aside or cut or burned. So something has been done to that area and severed the muscles. Now, how many muscles do we have in that area? Many. And the answer is yes. All of these muscles, they have to be attached together and aligned together, and knowing which muscle does what so that we align them together so that the soft tissue effect after surgery is favorable. If you look, there are cadaveric studies looking at the muscles, and the muscles involved during orthognathic surgery, especially in the maxilla, it's more than what we think. Many of us probably don't know the names of these muscles. Levator anguli oris, now these are common ones. What about the mertidiformis muscle? How many have heard of it? So many muscles are involved. Some of them are at micro levels and very thin muscles. And these muscles have dramatic effect on the face, whether it's in dynamic or in static areas. Look at these muscles. So these are small muscles the pars transversalis of the nasalis, the levator anguli oris, all of these, once they are severed, the dynamic of the face is dynamic. There is an animation, periorbital, perioral animation of the centrofacial area. So I want you to understand this. We cannot focus on occlusion. Many of my orthodontic colleagues, they focus on the occlusion. But from my part, I focus on the soft tissue and the face and how the soft tissue face. So my colleagues probably, they talk to me about SNA, SMB. I don't know. 10 years ago was the last SNA number I saw it. I don't use SNA. I don't use SMB. I don't use any predefined values to evaluate the face. Many of our patients have done further enhancing procedures in the face. Many have done surgeries, rhinoplasties, many cosmetic procedures such as fat augmentation. So from our part, this is a slide just from a study that's going to show you dynamic movement because of muscles, so I'm not going to go much through it. But from my perspective, as an oral and maxillofacial surgeon, I look at the occlusion, and then from that point, I set back and I have a general look at the patient and evaluate everything from a soft tissue standpoint, because that's what's going to change at the end. The occlusion is going to be class 1. But it matters for me if it is class 1 here or here or there, how you tilt it, the position of the complex itself. This is the job of the surgeon to evaluate how it's going to be. And that's why we need to utilize every single technological advances available to predict these moves and trying to optimize it. So have a look here. We have increased nasal changes, increased nasal width, nostril visibility, tip of projection, nasal dorsum changes. These are not going to be, I'm not just going to tell you about it, I'm going to show you in 3D, using heat map on 3D images, how that happens. The changes might affect the temporal area. We're talking about the temporal area. So the soft tissue changes is more comprehensive than what we think. Periorbital area, so around the eyes, especially on the lower border. Volumetric cheek enhancement, the whole cheek is going to change in terms of three-dimensional values. Soft tissue draping and the pulling of the tissue, lip positioning and reshaping of the mentolabial fold. All of these are issues that we have to think about when we perform the procedure. And this slide is for surgeons, there is an algorithm. I have an algorithm, a detailed algorithm of what to do with during orthodontic surgery in order to solve each problem. So increase nostril show and alar width. I know that's going to happen. If I want to decrease it, I do these things. If there is a turbinate problem, we cut the turbinate, we remove them. If there is downturning, curling of the mouth, then we have to reattach these muscles. These are all names of muscles, but because they are long, I'm going to just use them like that. So I mean, practically, when we enter the surgery, we are aggressive somehow in trying to, when we perform the procedure. Indeed, we are injuring and severing many of the muscles available, but we take our time trying to evaluate what's going on and what has happened so that we reattach all of that and put them back again. What is the way that we can evaluate these three changes? And here what I'm going to be talking about next is the 3D facial scanning. The 3D facial scanner is a modern kind of technological device. It's been used a lot in other fields, but in medicine, it's much less common. But in the gaming industry, in the movies, in forensics, archaeology, it's been used in many disciplines heavily since the 1960s. But in medicine, we've been shy from it. We are always the latest in utilizing 3D imaging technology. Now we are using it, but still the usage has been kind of slow. So handheld cameras, what we're using a scanner in order to evaluate facial symmetries or cranial synostosis here, or scoliosis by orthopedic surgeons, or even more than orthopedic surgeons are physiotherapists, because physiotherapists are the one they're going to create the braces and all of that. So mostly people who are working with prosthetic part of medicine and surgery are the ones who are using it, not much of surgeons. But nowadays we have more and more understanding of how this works and how we can use this technology. In the field of oral and maxillofacial surgery, it could be used in a different way. Also in dentistry, it doesn't have to be maxillofacial, but I'm focusing on my field of oral and maxillofacial surgery. You can do surgical treatment planning, so I can create a 3D shape of the patient, and from that I can simulate and predict. Or I can compare a 3D picture of the patient before and after a procedure. This is not simulation, this is actual. 3D photo before, 3D photo after, combination, and creating heat map for research and knowing exactly what has happened. There is a difference between simulation and actual results. And this, when we do, the more we do from these studies, then the more we understand how the soft tissue will change. Now, it's different from before that we used to evaluate way after surgery what has happened. Now we can do it as temporal evaluation. This is regular camera, the regular camera. It's not a scanner, so you can take a picture every day. There is no ethical approval that's gonna stop in your way. Technological-wise, we have structured light technology, and we have stereophotogrammetry, and we have the telephone, the iPhone, such as the iPhone X, and after there is special IADR cameras in it. The structured light technology, it reflects, like shines a light on a patient and then capture it. Stereophotogrammetry is using cameras with high resolutions from different angles and using special algorithm to extract the 3D image. So structured light, the red color, that means there is a light source, and there is a camera that captures. And the active photogrammetry and the passive ones, it relies on the camera itself. The camera has to be high resolution. You can add a light on the side in order to have a higher resolution picture, but the cameras, several cameras or a single camera with movements, we rely on them to create a special algorithm to extract 3D images. This technology is still under development. This study is showing the most commonly used 3D facial cameras in big maxillofacial surgery departments. And here, the study is from 2014. Look at the prices of these machines. So this is complex, but at least we have an idea what is that. Each company is showing you the camera that they have, the model, the picture, how long it takes to process the algorithm, how much time it takes, 8 milliseconds, 2 milliseconds, how does it create it as a mesh. But what catches me here is the prices. The lowest one is 9,000 euros. It goes all the way to 40,000 euros. So these machines are expensive. This is a 3D facial scanner. I'm going to go over a couple. This is a 3D facial scanner from Access 3 from Ireland. Here we have a projector, and we have 3 cameras and a lens. It can get a picture at 180 degrees and can combine it in less than 2 seconds in a 3 megabyte size file that is a 3-dimensional format. 13,000 euros. That is, the price is still the same. 3DMD from San Francisco and Atlanta, USA. It is using more cameras. So we're talking about 6 cameras here. You can get a bit more behind the ears. So behind the ears to behind the ears from both sides. So bigger portion of the face. And the price, of course, is even more than 20,000 euros at that time. Now, what I'm using is a Vectra 3D scanning technology. There are 2 technologies. This is the mobile one, and this is a stationary. And the idea that the mobile one means a single camera, you move, you take a picture, number 1 from the right, number 2 from the left, number 3 from the center. And then the software will combine all 3 pictures together. Or there is a stationary with multiple cameras, okay, multiple cameras and lenses, and the patient sits and the picture is taken once. So this one is going to take 2 minutes and you have to move, and the one on the right, it's taken once. And the same thing, the file size is a bit bigger, 8 megabyte, 20 seconds, but the algorithm is very accurate. In fact, it was originally made for dermatologic purposes, in which you can enlarge and look at the skin texture and complexity directly from 3D picture. It was not made for surgical use, it was made for dermatological uses. But again, in our field, it's becoming very useful. So here I'm going to show you how I take the stationary picture. Patient sits, I'm the patient here, I'm looking at the mirror. We have 3 cameras with 3 lenses, so 6 in total. The pictures are now being combined together. It takes less than a minute. Look at the resolution. You can enlarge through a touch screen camera. You can enlarge, rotate, evaluate the patient from every perspective. In fact, you can superimpose the right side on the left and the left side on the right in order to evaluate the asymmetry from right and left. You can use artificial intelligence to define the soft tissue cephalometry of the face. Now let me look if I can evaluate the symmetry. The symmetry, right and left. So my face, if I reflect right on left and left on right, how it's gonna be looking? Let's look, and you can then evaluate the facial proportions. So my duplicate right face, duplicate left face, and then facial proportions based on the cephalometric points that was defined. And then I can look at the nose, look at the chin projection, look at all the values and everything that we've read in the books in order to evaluate the aesthetic of the face. Look at the nose. I'm going to do rhinoplasty now, simulation. I'm playing with the nose, increasing nasal tip support, up rotation, projection, deep projection. This is the nose. Now let's go ahead to what we like, the chin. Let's look at the chin. We know the values. We know there is an E line and the chin is, I'm kind of class 2, so my chin needs a bit of projection, but I can simulate that here. Look at the chin, forward, backward, lengthening, shortening. So it is possible to simulate. Now we are dealing with mesh, with a 3-dimensional mesh. We can deal with that mesh and then export the data as a recipe for the surgery, as a step-by-step recipe, as a PDF format. Everything you saw was done on a software for this Vectra camera. Now, this is our resident, Dr. Ali Akbar from the university. He's now in Houston. And it's, the camera here, it's the same as the other ones, but this is now mobile. So we cannot, this is the second option in which you let the patient stay still and take pictures from the left, from the right, and from the center. And then a special algorithm in the same software combines everything, and we go back to the point where you can do manipulation of the soft tissue. Nowadays, in the last 5 years, since iPhone X came out with the IADR camera, with the true depth camera, there is an algorithm called Visual Structure from Motion, SFM. So using motion in order to extract 3D pictures from it, and this is what we call 3D facial scanners using mobile phones. Now, you will see some of them are coming out, being available, and it gets withdrawn of the market, mostly because of security issues. But it is available now. There are many softwares, such as the Billis, the Higgins, the Scandi. Many phones are available, many applications for iPhone mostly are available in order to take a 3D camera. And this is how it works. Let me try to show you. It tells you, look at the camera. The voice is not going, you cannot hear it. So turn your face to the left, turn your face to the right. It tells you, so there is a voice, there is a prompt that tells you, turn your face to the right, turn your face to the left, look up, and then it tells you, look down, and then the picture is completed. It's processing the picture now, and that picture, actually the one that I took here, it's the same one that is in the middle. The one I'm showing now in the middle, 3D in the video, it's the same one that I actually took there and exported it after a minute to the computer. Is that accurate? Let's see how. It takes 2 minutes, maybe 2 now, that picture. It's in the 3D, I check it, I confirm it, I click send, it goes to my computer as a 3D facial scan. Now, is that accurate enough? We did a study comparing stationary with mobile, with the smartphones, This study was done with a group in Germany, and we found out that the low-cost scanners, they still do as good as the more expensive scanners. So we can see the spectrum here, going from iPhone all the way to $30,000 machines. Now, the intraoral scanners are very common. You know how to use it, and we're going to go ahead. I'm going to show you how the process is utilized to plan our surgical cases. We have a special software called the IPS Case Designer, and in this case, the plan is done by converting everything digitally, and you can see there's a splint in the middle. This is a splint. So after I do the movement, I create the splint. This splint is sent to a printer. The printer is not expensive. Again, you can see the printer is becoming available. You can buy it on Amazon, and you can use the printer to print the splint. So you print the splint, and then you are ready for surgery because you have everything now imprinted and programmed in this splint. So everything that we have done is to reach to this point where we have the data available as a digital splint. Splint comes out like that, and then you have to do some cleaning and preparation, put it in alcohol, put it under light, let it cure. It just needs a few extra steps, but then at the end, you have the splint ready for the procedure. Then I can do it and take it to surgery right away. So this is now after fixation, after curing. It's all plastic. So these parts that we do, so we print the cast, we print the splints, and we can print surgical guides. For example, if you want to do genioplasty, we can print surgical guides as well. And that becomes very helpful. The whole idea of using 3D planning is very helpful, especially if you have complex cases. This patient came to us or came to me wanting to do surgery as soon as possible because he was accepted as a pilot at Kuwait Airways and wanted to start after 3 months. So he said, I'm starting as a pilot in 3 months and I'm not allowed to take time off for surgery. So if you want to do surgery, and he has prominent class 3 deformity, if you want to do surgery, I'm not going to wait for orthodontic treatment for a year and then do surgery. I want to do the surgery right away within a week or 2 or 3 weeks. So this was a surgery first procedure. I did that with my colleague, I think Dr. Faraj Wabahani. So this case was a surgical surgery. First, we planned the surgery. After the surgery, by a couple of months, we went ahead and did the orthodontic intervention. So let's look, evaluate a 3D facial scanning, and then intraoral scanning, and CBCT, and all the data, clinical examination, everything now is ready to be fed into the software, and from there we can go ahead and do our planning for the procedure. Now we can simulate. This is simulation. This is not actual. So I do the cuts, Lefort, BSSO, Genios, advance, and simulate. That's a procedure how it's going to be. And I reflect that on the soft tissue. Look at the soft tissue. Simulation. This is not real. Simulation. This is the real. Now, I did the surgery. Everything is good. A month after the surgery, I called the patient back. I took the 3D picture before surgery, the 3D picture after surgery, and then we have to evaluate 3D. Let me see. The blue, this is when I superimpose. This is before and after, okay? 1 month after surgery. And this is when I superimpose both before and after on top of each other. The blue means volume enhancement. The yellow means volume decrease in volume. So we know that the upper lip went forward because we did Lefort 1 advancement. So the upper lip and the whole centrofacial area came forward. It's blue. The darker means the more advancement. And then we can see we have decreased volume in the orbital area and the temporal area. Look at the temporal area. There is some decrease in volume. Look at the cheek. Because of the advancement, we have some slimming in that area. And look at the nose. We have widening of the nose, increased tip production. But look at the top of the nose. There is decreased volume. So The soft tissue changes here, we can tell it objectively what has happened. Second case, this is conventional. This patient wants to do a correction of her class 2 malocclusion. We're going to do impaction, advancement. Again, by doing a simulation, this is how it's going to look like. Widening of the angles, advancement, a little bit counterclockwise. So we are correcting the patient in three-dimensional shape. The occlusion is the easiest thing to do. It's the easy thing because it's defined. But how much forward we go, how much up, how much do we rotate the whole complex? That is the thing that we have to evaluate using a 3D, and we are able to do that accurately. So this is a patient before and after surgery. Before, 2 weeks after surgery. She was complaining of gummy smile. Now the gummy smile is gone, but this is not final results. This is 2 weeks. After attaching the muscles, it will look better after a few months. But 2 weeks after surgery, before and after. Now, if I superimpose on top of each other, look, nasal tip went forward, bit wider. Look at the whole maxilla, mandible, everything went forward. Look at the submental area, there is decreased volume. So there is no need for liposuction, there is decreased volume already that took place. Peritemporal area, or periorbital and temporal area, still we have volume changes. Minor, but there are volumetric changes. Look at the preauricular area, there were changes. If I take the pictures on top of each other accurately, we have tip of projection of the nose, up rotation. This is without any rhinoplasty, without any intervention in the nose. Of course, we did some intervention with the cartilage part of the septum, but we did not open the nose with a conventional rhinoplasty. And you're getting results that are favorable because this is what we planned for. The whole lip and the central part of the face came forward, and the whole chin came forward. And you have shortening of the face, if you notice, because we wanted to achieve that. She had a long lower face. So 3D planning helped us into predicting the soft tissue changes in order to plan accurately. In this case, this is multi-piece Le Fort of the maxilla, and again, it's the same issue. This patient wants to do the surgery, and then we need to do rhinoplasty for her afterwards, but we had to control her nasal changes. So this is a big class 3 correction. A little bit shortening of the face, rhinoplasty, genioplasty, and we're trying to correct the lower part of the face in terms of proportion. The chin, we had to create surgical guides, design a special surgical guide. Now, surgical guide, we have something called cutting guide. This one has holes, so you can put the saw and cut. And then we remove the blue and green. We put another blue like this sideways, and this is called positioning, because you want to position now, so we change the cutting guide. We put the new one with the new position, and this is after predicting and creating surgical guide according to our plan. So even the plan of the genioplasty, we can do it accurately with that. Now, patient before and after surgery, a month after surgery, look at the nose, there is tip production. She has low radix of the nose, but we did not want to do simultaneous rhinoplasty. So look at now this is superimposition, real photo before, real photo after surgery, combination, and analysis using heat map. Blue means increased volume, and orange means decreased volume. Look at the nose, increased volume forward, sideways, but if you look at the radix, the bridge of the nose, there is decreased volume. Soft tissue got stretched a little bit. The whole centrofacial area has moved forward. The chin, because we repositioned the chin area, it went up, so there is decreased volume. It's yellow here. So this is what I'm talking about, knowing the soft tissue movements objectively, not just predicting it in 2D format, but doing it in 3D format. You can predict these movements. Now, what about osseous genioplasty? Genioplasty is a nice procedure, very simple, but you can still need to have your evaluation done. And then based on the evaluation, I'm going to go ahead and move the lower jaw. Look at the chin. Did you see how I moved it? Now this is what's called simulation. and then simulation before and after. This patient before and after. This is simulation again. And based on the simulation, I can predict how she's going to look like and how much I'm going to, oh, sorry, this is real photo before and after, not simulation. And combining it on top of each other, we know that this is what we have changed. That was before, and the shadow means after. So we're coming closer to the end. This is our patient that we spoke in the beginning. We're going to do complete digital planning, measure all the values in the face, do complete evaluation and surgical simulation. And in this case, there's asymmetry. You have to measure if you do your osteotomy, where is going to be touching it? Is there going to be balance in the touching of the bone on each side? So here you can plan everything. In fact, I take pictures of a cross-section of the CT. I define how long. The red dot means the nerve. Because we're going to split the mandible, the nerve has to be protected. So here I defined exactly how far is the nerve from the lateral border, from the inferior border. So we're talking about increasing accuracy. And even during the conduction of the surgery, I want to know how far is the tooth and the lingula from each other. So we can predict every position during surgery and predict the result after surgery. And this is how we can do to deliver the best results for our patients. So, in terms of advantages of surgical treatment planning, it's increasing our accuracy significantly. We can customize our treatment approach and our treatment design completely using these digital technology softwares. You can have improved communication with the patients and increase patients' understanding and our understanding and our colleagues' understanding of the procedure, and we can share data better, and mitigation of complications also an option is better done by using complete digital planning before surgery. So it seems like the trend is definitely now is in favor of using digital technology. Where are we going next? Next, we are going even more advanced using augmented reality. So in this study, this is our study. So in the way I designed this model is using cone beam CT in a 3D format, converting the data to augmented reality models, and knowing. So this case now has a patient has a tongue cancer. Using CT scans in the 3D, I can move the maxilla, the mandible, go inside, even the wisdom tooth. Here is the wisdom tooth that is deeply impacted. And using the camera, you can move and go and dive into the three-dimensional shape of the mandible. So you become as if you're standing in the middle of the skull and looking at everything. So this is augmented reality, and we can use that. Is that advanced? Can we go further? And definitely yes. Now, next step is the mixed reality. I told you now, in that you were sitting in the middle of the skull looking. Now I want to go ahead and take something and cut the skull digitally. Is that possible? And this is what mixed reality in maxillofacial surgery is. In mixed reality, this is an actual procedure that we did using converting the CT data to augmented reality model, using mixed reality models as well in order to be able to touch upon these structure and cut them. How? I'm going to show you next. Of course, that is also a publication, but I'm going to stop here. This is Lebanon. We went to Lebanon serving helping underserved population and refugees in Lebanon to perform surgeries. And here is during the surgery when me and Dr. Rakijian from Cleveland Clinic, that electricity went off. Only the upper light is moving and the machine, anesthesia machine. This is not staged. This is actually during the procedure. Dr. Joseph came to give me a material, and the electricity went off. And somebody took picture. You took picture? I think you took, somebody took picture right away. We said, take a picture. They took a picture right away. So this was spontaneous. The electricity truly went off. And then we continued the procedure without electricity, just with the anesthesia machine and the light. Why I'm showing this? Because here we were unable to have the software and plan, 3D print, everything. So we use this mixed reality model to take CT scans. So we saw the patient, and we took the CT scan. We took a CT scan. We sent it to America to Immersive Touch. We asked them to convert it to mixed reality model. They send it back to us, the file, after an hour in a 3D format. Then, using the software, we are doing mixed reality. Mixed reality now, that means I'm in the camera, I go in, I cut the osteotomy, I hold the maxilla in 3D, I bring it back, complete interaction with the 3D structure in augmented reality, and we're stepping a step forward. This is called mixed reality. In fact, so in this case was a Bimax. So I did the Lefort, did the BSSO, moved everything, genioplasty, but the condyle is an issue. So I go ahead, cut the condyle, let me show you the next, cut the condyle in this virtual model, and then we want to reconstruct the condyle, the TMG. How do we do that? We have a stock model in the software that we copied the TMJ processes in the software. We take it, medium size for example, put it there, fix it to the skull base, make sure does it fit, move it, interact it, you change the tool. This is mixed reality. This is not the same as augmentation, just looking at the reality. Now we are interacting. Now I know I use that model, I have all the numbers, go back with a pen and a paper, write all the details, put everything, full recipe, and go to surgery now. We performed the whole procedure digitally using mixed reality, and went ahead and did the surgery, and everything went good with that patient. This mixed reality is published. We published that also in different models with my group in Germany. So now I think running close to the end. I love digital technology. Digital, this is Ibn Sina. Don't guess it's somebody else, but it's Ibn Sina. I'm trying to do it in a 3D format using digital technology. But despite all of that, analog and going step by step from zero using analog hands-on is definitely something that you must do. You cannot just jump into digital technology without going ahead and trying everything that is done in the manual protocol in order to create a 3D format. I love to show this because I've put a lot of effort working on each of them. Each of them needs 3 weeks of work, about 9 hours, 10, 12 hours a week. So I love to try to augment my skills into 3D evaluation and touching, using art, trying to simulate faces and use my hand skills. At the same time, technology definitely will help us into coming up with the best result and the most accurate result. All of my data is here. My phone number, personal phone number is here. You can take a scan from here, and you can reach me at any time should you have any question. Thank you very much for your attention.
Thank you, Dr. Mohammed. Does anyone of the audience have any questions?
Dr. Mohammed, thank you for your presentation.
Thank you.
So, anecdotally, like you, I'm not big on cephalometric numbers, but looking at these soft tissue predictions, anecdotally, how good are they in portraying what the patient will look like in reality?
So there are standardized numbers that you can use to predict the movements, or you can do the changes freehand. So sometimes if you're talking about certain aspect of the soft tissue that you cannot evaluate, or you're not sure how the changes will look like, then you can go freehand and evaluate. The thing is, we are evaluating data based on CBCT. This is soft tissue. It's like 3D facial scanning. This is just a coloring. We just have a color that is created in 3D. You have the CBCT. The CBCT does have its own soft tissue, but it's in gray. So as if you're going and coloring every pixel on the CBCT scan and deliver the right shape. So when you combine it for surgical procedure, we are going back to the basics, to the CBCT data in terms of skull and soft tissue that is attached in the same data set. But the prediction, and when you're telling me, what about the prediction? The prediction goes according to cephalometric values. So there are anthropologic values that we can use to predict moves, but the movements that we're doing are not radical. So when you tell me, Mohammed, I need this in class 1 occlusion, okay, class 1 occlusion. بس وين بحطها؟ So I'm going to move 3 millimeter forwards. Then I go according to the anthropometric value that I use اللي هي glabella, nasion, انزين, subnasal, والrelation حق الupper incisor from the lateral point of view. فأنا I will take your point of view and deliver it into this format of 3D soft tissue analysis to improve this area only in the anterior part of the maxilla. ما راح أسوي شيء significant and it's going to affect the whole face. It's just single area. Advancement and decreasing nasolabial angle and increasing centrofacial projection. Or height, facial height. أنت مثلا ما راح تركز عليها. But for me, I will find out this facial height. It has to do with the lower facial height or higher facial height. This is all soft tissue راح يكون بالنهاية.
Okay, as a follow-up, compared to the software simulation of these soft tissue predicted changes.
Yeah.
How does that correlate with the actual patient results, soft tissue-wise?
In our results, it's close enough. That's why when I showed you the simulation, and then the slide after is the actual. Simulation, actual. How accurate? It is accurate enough. So all the changes, حتى الchanges اللي كانت على الtemporal, اللي احنا توقعناها, when you do actual, it is still there. The nose, the same thing I predict, it does happen. Unless if you violate the procedure. إذا أنا بالprocedure رايح aggressively and stripped more muscles, I'm playing around now with the dynamics. I injured more muscles, I didn't attach the muscles, the corner of the mouth نزلت, بدل لا تصعد نزلت وصعدت تغير, فصارت الكاميشور shape تغير because of me, not because of the simulation. But when looking from, especially from profile point of view, it is very accurate.
يعطيك العافية دكتور محمد على المحاضرة الجميلة. Dr. Mohammed, do you need any cutting guide or positioning guide for the maxilla to put it back to its place, especially for these cases when you cut the maxilla in multiple pieces?
Okay, thank you very much. It's a very nice question, but it's very general. Because if we are doing a case that is just a Lefort osteotomy and advancement, معناتها أن I'm just going to cut and move. Visually I can cut right and left, زين, at the same level. I don't need a cutting guide. Now, what about if I need to do, حتى لو multi-piece, إذا multi-piece symmetric, it's okay. But if I have a case with a major asymmetry, I'm talking about more than 6 degrees. احنا عندنا 6 degrees, okay, still ما يخالف, 6 degrees we can guess it. زين, إذا كان 20 degrees, move the maxilla. Even if I do a Lefort, if I do a movement like this, the changes will be 3-dimensional form. لأن مو بس هي بالأسنان. It's the whole lateral side of the maxilla will change. In that case, it will be helpful to use a cutting guide. But in general, no, we don't need cutting guide for every case, unless if you have major asymmetry or something that makes the procedure harder. In that case, the cutting guide will increase your accuracy. مو بس cutting guide, 3D plates. If you want to go full accuracy, cutting guide زين كاملة and 3D printed plates and screws. Now we're going extra cautious and doing everything accurately. بس هذه مو حق الحالات، هذه حق الحالات اللي تحتاج extra accuracy. المشكلة شنو؟ cutting guide are big. So you want me to use a cutting guide? Okay, حاضر. But I have to cut 2 centimeters here more, cut 2 centimeters here, وتعال cut 6 more muscles sideways. زين لأنه big surgical guide عدل شلون هي مو قطعة صغيرة كبيرة.
فمعناته ما يكون tooth borne ما يصير. الcutting guide.
لا cutting guide for the maxilla معناته أنت الاريا اللي أنا I showed you in the maxilla degloving I have to deglove more because the cutting guide is this big. فأنت you have to cut more, retract more, cut more muscles, everything. So it is more invasive, more accurate, but more invasive. وتعال deal with the complication of doing all of these soft tissues at the end because you use a cutting guide. So you use it when you think it's accurate. إلا إذا تسوي الcutting guide نفس الليجو. You do it 3 piece, you design it 2 piece, okay, ليجو هني، ليجو هني، ليجو هني، 3 كل واحد سنتي ونص عشان طوله يصير 6 سنتي. at the end, are you making the procedure better or safer? هني احنا we are doing the full digital planning. إنزين, what we can execute by ourselves at this level, we can do it freehand. If we need to do something more accurate, and we define pre-operatively بالdiagnosis إن لا هاي حالة صعبة ترى فيها asymmetry الchin اللي مساع أوكي هذا الchin فيها asymmetry how do you move it سويت له cutting guide زين so the more asymmetry and the more difficult the procedure is then we can escalate the level of accuracy you want but for me this is my conventional method for 90% of the cases
يعطيك العافية كواكب.
الله يعافيك.
I think we lack of time. Thank you very much, Dr. Kamal. We just want you to receive the appreciation. واحدة ثانية. So Dr. Yahya, he's currently the head of oral and maxillofacial surgery unit in the new Jahra, as well as the Al Jahra Dental Specialty Center. He's a part-time faculty at Kuwait University. He also a lecturer at the Kuwaiti Board for Dental Specialties. In 2018, he has got a fellowship of American Board of Oral and Maxillofacial Surgery. He is double qualified oral and maxillofacial surgeon in 2016. In the same year, he's got a certificate in oral and maxillofacial surgery. He obtained his medical doctor degree in the University of Texas, Houston in 2014, and Doctor of Dental Surgery degree, Virginia. That was back in 2006. Dr. Yahya is presenting today maxillofacial trauma in a non-ending journey. So he's most welcome to start.
شغال؟ تمام. بس slides are not working for some reason. قولي يبا. شلون يبا؟ Yeah, it's not going to work if you're not connecting it. Okay. يعطيكم العافية. Oh. And anyway, السلام عليكم ورحمة الله وبركاته. اسمي يحيى اليحيى. I am an oral maxillofacial surgeon working in the Jahra Hospital. I will be talking about maxillofacial trauma today. Why do شو المشكلة؟ I am known to have issues with computers and connections for every lecture, so it's normal for me. That's why I tell them I have to check it before ahead of time because this always happens. It's fine. It's gonna work out at the end, inshallah. كده تمام؟ أنا اقمز لي شيء قمز. اقمز لي يمين ب 30 دقيقة، اقمز لي يسار بال 45 دقيقة. Is it working now? Okay. Okay. Sounds like it's going better now. I want to take a moment first to أدي حق الناس المساكين اللي قاعد يموتون في فلسطين. Last night I was watching a video that killed me. I'm a father, I have a daughter, and I've seen a guy that says, روح الروح, with all my heart. I've never felt how disgusting this occupation is until that day, which is last night. And I think إن شاء الله ربنا بيعطيهم حقهم وأرضهم إن شاء الله يا رب العالمين ويصبرهم ويثبتهم بإذن الله تعالى. So please, no photographies, no videographies of any of the patient's pictures, because granted that we take permission, yet it's always good to keep their identity because of the drastic pictures that you're going to be seeing. The New Jahra Hospital, 4 towers, very nice. Medical, surgical, pediatrics, and women's towers. The number of ORs are 36, upgradable to about 56. Has a lot of really fancy stuff. When I first moved into Kuwait, Jahra Hospital was the oldest hospital right now. It's the most, the newest, most advanced. Probably has the nicest. It looks like the avenues, maybe an airport. So if anybody is interested in moving there, this is the best place to work at right now. Jahra Specialized Dental Center. I don't have to talk about it. We have about 86 clinics, upgradable to about 120 some clinics, but enough of this. So etiology of facial fractures, it depends on many factors. It differs on the location, socioeconomic factors, geographic, of course, and cultural factors. So in a culture where there's a lot of car driving, there's going to be more MVAs. Yet in developing countries, MVA, motor vehicle accidents, is the #1 reason, to actually predominant cause of that doesn't work. Huh? No. I'm sorry, you have to stop the live. I apologize, yes. Please do. Please do. So road traffic accidents is the predominant cause of facial fractures in developing countries. Yet, patients' altercations, fighting, this is a very common industrial injuries as well. Fall from heights as well. In Kuwait, there is an accident every 10 minutes based on the statistics that from July of 2017. However, after Corona, for some reason, facial trauma and other traumas as well have decreased. I think what happened is that people got accustomed to staying at home and not going out as much. So I've seen this, the numbers. I don't have actual data. They're probably going to collect.
Hello, everyone. We're very happy here today to have Dr. Fatma Al-Hindi joining us for the KDC. Dr. Fatma obtained her undergrad degree from Kuwait University before pursuing her passion in oral medicine by joining the oral medicine residency program at the University of Pennsylvania. where she also received her master's in oral biology and diploma in oral medicine. She's currently working in Farwaniya Specialized Dental Center. A warm welcome to Dr. Fatma, and have fun.
Thank you. Good afternoon, everyone. My name is Fatma Al-Hindi. I'm an oral medicine specialist. I'm currently working at Farwaniya Specialized Dental Center. Today, I'm going to present some of the cases that I have managed and still managing at the oral medicine clinic. I would like to thank the KDA for allowing me to promote for oral medicine. I think we need some publicity. And I would like to thank my patients for allowing me to share their cases, their stories, for educating me and everyone else in the medical and dental profession. So I would like for this lecture to be as interactive as possible. If you have any question regarding any of the cases, please write them down and we will discuss them at the end of the lecture. So I have nothing to disclose in this lecture. The main objectives for this lecture are to shed some light on the role of oral medicine specialists in both medical and dental professions. I would like also to familiarize oral healthcare providers with some of the orofacial conditions that they may face at the dental clinic, their clinical manifestation, and how the oral medicine specialist, also when to refer to an oral medicine specialist. It is also important for the oral healthcare providers to distinguish pathology from variation of normal. Another important point that I would like to focus on is the importance of the multidisciplinary approach in managing our patients. The multidisciplinary team can So Dr. William Osler is a physician. He is considered the father of modern medicine. He is the first one who created residency programs for physicians. So he brought the medical students from lecture halls to bedside clinical examination. He is also one of the greatest diagnosticians. He said that the good physician treats the disease, but the great physician treats the patient who has the disease. This focuses on the importance of including the psychosocial factors in managing our patients. And speaking of great diagnosticians, the American Dental Association defined an oral medicinist or oral medicine specialist as a doctor who has special training in managing different orofacial conditions, including oral mucosal disorders, precancerous, cancerous lesions, salivary gland disorders, taste and smell disorders, also some of the orofacial pain conditions like temporomandibular disorders, neuropathies, neuralgias, and headache disorders affecting the head and neck area. Also managing medically complex patients. So the oral medicine specialist is considered the physician of the mouth that bridges the gap between dentistry and medicine. The oral medicine becomes the 11th ADA recognized dental specialty in March 2020. And as I said in the objectives, it's in the core of oral medicine practice to work in a multidisciplinary team. So, for example, rheumatological, gastrointestinal, and dermatological conditions can have a manifestation inside the oral cavity. So we often refer patients to these specialists, and it's a two-way relationship. These specialists will refer these patients with oral manifestation to the oral medicine specialist. Of course, patients with temporomandibular disorders, we often refer to physical therapists. Patients with chronic pain conditions, we refer to pain specialists or even psychiatrists. So also in diagnosing purposes, we also refer patients for oral pathologists and oral radiologists. So the multidisciplinary approach is a must in the oral medicine specialty. Now we will start with today's cases. The first case is of a 23-year-old male presented to the oral medicine clinic with chief complaint, I have severe pain and ulceration in my mouth and I cannot eat. The patient was actually on a wheelchair because he is so fatigued, so tired, he cannot eat anything, cannot speak even, And he said that the ulceration and pain acutely started 3 days ago. It was along the, on the lips, inside the mouth, and it is very difficult to eat and swallow. In the review of system, he said that there was no skin, nasal, genital, or eye lesions, and also no history of any new medication or oral health care product use. He went to the polyclinic, and the local dentist prescribed topical anesthetic with only mild relief of the symptoms. So regarding the patient's past medical history, he did mention that he had recurrent herpes labialis more than 6 times a year. The past surgical history was positive for tonsillectomy, no known allergies. Regarding the family history, he was single, not on any medication, non-smoker, no alcohol or drug abuse. And the review of system was as the history of present illness. The physical examination extraorally, the patient was alert, the vital signs were stable, no facial asymmetry, no salivary gland or thyroid gland abnormalities. The cranial nerve exam was within normal limits. Also, the TMJ and masticatory muscles were within normal limits. Except for bilateral lymphadenopathy, cervical, it was painful and movable. Intraorally, the patient had widespread ulceration, bilateral buccal mucosa with marked erythema and lip crusting and bleeding. The tongue also, the anterior 2/3, was ulcerated with marked erythema. And there was mild coating on the dorsal tongue. So this is the clinical picture for the patient. You can appreciate the lip crusting, the bleeding, the intraoral ulceration at the tip of the tongue, and the buccal mucosa. So at that time, my differential diagnosis, the top differential was erythema multiforme. And we will explain in the later slide an overview about erythema multiforme. Another differential would be primary herpetic gingivostomatitis, and I ruled out this differential because the patient is adult. Usually this is a condition of young individuals, and the patient did say that he had recurrent herpes labialis, so this is not his first encounter with herpes simplex virus. Another differential that I ruled out is autoimmune vesiculobullous diseases like pemphigus and pemphigoid. But because the gingiva was spared, I ruled out this differential. Usually, pemphigus and pemphigoid have gingival manifestations. Another would be Stevens-Johnson syndrome. It would be also a good differential, but the patient denied any skin or nasal or genital or eye lesions, which is pathognomic for Stevens-Johnson syndrome. And at the end of my differential was fixed drug eruption. The patient didn't mention in the history of present illness any history of medication intake, so I ruled out this differential. So because erythema multiforme is a clinical diagnosis, I started the patient with 40 milligram prednisolone a day for 2 weeks, and also a prophylactic valacyclovir 500 milligrams twice a day for 6 months. After 2 weeks, the patient came back, complete resolution of the ulceration, and he is still on valacyclovir. I will explain why we are prescribing prophylactic antiviral for a non-viral infection in later slides. So what is erythema multiforme? Erythema multiforme is a hypersensitivity reaction, and it can affect skin and mucous membrane. It is of a type 3 hypersensitivity or immune complex type, and I will explain in the next slide about types of hypersensitivity. It is classified as either a minor or major erythema multiforme. Both minor and major erythema multiforme occupy about 10% or less of the body surface area. But the minor form is usually affecting the skin, while the major form usually affecting the oral cavity, the oral mucosa. So for our patient, we would classify him as erythema multiforme major. It's more common in young adults and in females, although our case is of a male patient. 90% of the erythema multiforme is triggered by an infection, and 80% of these infections would be herpes simplex virus infection. Please note that erythema multiforme is not a viral infection. So if the patients have, let's say, herpes labialis for 2 weeks, everything is resolved after 2 weeks, the system still has some of the non-infectious particles of the virus. And for certain individuals, this will trigger an immune reaction. So hypersensitivity is basically an exaggerated immune response toward a harmless antigen. In type 1, we require pre-sensitization or pre-exposure to the antigen. So after second or third exposure to the same antigen, we have sensitized mast cells, meaning that these cells have IgE antibodies attached to them. Once we have the exposure to the same antigen in the second or third time, this antigen will activate the sensitized mast cell. This will release histamine and inflammatory mediators. An example would be anaphylactic shock. In type 2 hypersensitivity, we have an IgG type antibodies that is directed toward a tissue antigen. So basically, this is the core of autoimmune diseases. So once the antibody attached to the host tissue antigen, it will cause the activation of T cells that will result in phagocytosis or cytotoxicity and tissue destruction. In type 4 hypersensitivity, or sometimes called delayed type hypersensitivity, we actually don't have any type of antibodies involved, but we have a cell of the immune system called antigen-presenting cell that presents the antigen to the T cells, either T helper cells, and this will cause the release of inflammatory cytokines and tissue destruction, or it will present it to a T killer cell that will result into cytotoxicity. An example of this would be a contact allergic stomatitis or contact allergic dermatitis. But in our case, type 3 hypersensitivity, we have soluble antigens bound to a soluble antibodies in the bloodstream. And these form immune complexes that will activate some of the immune system cells and cause the release of inflammatory mediators and causing vasodilation. After that, these complexes will deposit themselves at the walls of the endothelial, the small and medium-sized capillaries. It will deposit there. Now the endothelium becomes the battlefield. So everything in the inflammatory system will act on these sites of the endothelium, causing tissue destruction and vasculitis. So what is the cause of erythema multiforme? As I said before, about 90% of the cases are triggered by an infection, usually a herpes simplex virus infection. And I have seen cases of COVID-19 also triggering erythema multiforme. A bacteria also, Mycobacterium pneumonia, I have seen cases of this infection causing, triggering erythema multiforme. 10% of the cases would be drug-induced, meaning that there is a new medication, usually a sulfa-containing drug, like Bactrim, also some of the anti-epileptics, like carbamazepine, and other antibiotics like penicillin and tetracycline. They can trigger erythema multiforme. But the erythema multiforme caused by a drug is a little bit different clinically than the ones caused by a virus. It's more aggressive, actually. And it is preceded by prodrome of flu-like symptoms. Another causes that can trigger the erythema multiforme would be immunization. We have seen cases of COVID-19 vaccines triggering erythema multiforme, and also Hep B vaccines also triggering the condition. Another would be food additives like benzoates. So you remember that we said that erythema multiforme minor can have or mainly having skin manifestations. And this is called target lesion. A target lesion is a pathognomic for erythema multiforme. So we have basically 3 concentric layers. The central part is dark, is crusted, surrounded by edematous pale area, and everything else is surrounded by an erythematous border. This is called target lesions or bull's-eye lesions. So how can we manage a patient with erythema multiforme? First, we have to identify the cause. If a drug involved, we have to discontinue it. We can provide the patient with topical anti-inflammatories like antihistamine mouthwashes, also analgesics, anesthetics. But usually the patient is, because of the acute and severity of these lesions, we would start with systemic corticosteroids. A preventive therapy would be antiviral, prophylactic antivirals, as we did in our case. And if the patient cannot tolerate systemic corticosteroids, like for example, a patient with uncontrolled diabetes, we can prescribe other immunosuppressives like Cellcept, Imuran, or even biologics. Moving to our second case. So we have 36 years old Caucasian female presented with chief complaint, my tongue is getting darker in color. The brownish spots are getting darker every day. The history of present illness also was positive for abdominal pain, fatigue, multiple episodes of fainting. She reported also unintentional bronzing of the skin. So not only the oral cavity is getting darker, but also the skin is getting darker. Although the tongue color is bothersome for the patient, it was asymptomatic. There was no pain. So the patient past surgical history were non-contributory, no known allergies. The family history was she was married with 2 children and she was not on any medication, non-smoker, no alcohol or drug abuse, and the review of system was as the history of present illness. The physical examination was within normal limits extraorally, but intraorally the patient had widespread hyperpigmentation, brownish to grayish in color bilaterally. Also, the dorsal tongue is with widespread areas of hyperpigmentation. So this is the clinical picture of the patient tongue. Now, here's a question for you. Just waiting for this page to reload. Please scan that code and answer the question. What would be your next step? Would you do incisional biopsy for this patient? Would you reassure the patient that this is a physiologic pigmentation? Or do you think the patient needs some labs? Answer the question by enter your answer in the code by scanning the code. Finish answering? Okay. So 84% said need lab, and 11% reassure, 4% incisional biopsy. Okay, you're really smart. cannot move forward. Yes. So for this case, my first assessment would be adrenal insufficiency. Since the patient had an extraoral manifestation, I was thinking of something systemic of the endocrine system. So the first two differential would be either Addison's disease or Cushing disease. I ruled out Cushing disease because the patient didn't exhibit any signs or symptoms of Cushing. And also another differential at the bottom would be melanoacanthoma, which is an oral mucosal condition where the patient have widespread oral pigmentation. But I ruled out this also because it usually affects the intraoral mucosa, nothing extraorally. So let's go back to physiology. We know that there are two endocrine conditions that can cause pigmentation inside and outside the oral cavity. These are Addison's disease and Cushing disease. The adrenal glands are pyramidal-shaped glands on the top of both kidneys, and they produce an important hormones and mediators. We have two parts of the adrenal. We have the medulla that produces catecholamines, an important neurotransmitter for the sympathetic and the parasympathetic nervous system. And we have the adrenal cortex that produces glucocorticosteroids for homeostasis, sex hormones for sexual differentiation, and also mineral corticosteroids for electrolyte balance and balancing blood pressure. So in a normal situation, if we have a low cortisol level, let's say a patient is coming for dental treatment, he or she is stressed, or for example, somebody like me giving a lecture to a very smart individuals, we need cortisol to maintain our bodily functions during these stressful conditions. So if the cortisol is low, the hypothalamus will sense that and will produce a hormone called corticotropic hormone. And that hormone will act on the anterior pituitary gland to produce another hormone called adrenocorticotropic hormone, or ACTH. The ACTH will signal to the adrenal gland to produce glucocorticosteroid or cortisol that we need for our stressful situation. Once the cortisol level is maintained at the desired level, then the hypothalamus will sense that again and will stop producing CRH and ACTH. This is called negative feedback inhibition. But if we have destroyed adrenal cortex, like for example in cases of autoimmune disease, infection, iatrogenic during surgeries of the kidneys, they can also iatrogenically destroy the adrenal cortex. In these situations, the adrenal cortex is non-responsive. So low cortisol level signal to the hypothalamus will produce CRH to the anterior pituitary, then the anterior pituitary will produce ACTH, but still there is no response. The ACTH keep piling up there, and there is no negative feedback inhibition now. So this is actually the core pathophysiology of Addison's disease. Every time we have ACTH elevated, we have another hormone gets elevated, which is alpha melanocyte stimulating hormone. So as the name implies, it stimulates melanocyte to produce melanin. Hence, we have the hyperpigmentation of patients with Addison's disease. So what are the signs and symptoms of Addison's disease? You know that signs are different than the symptoms. Signs are the manifestations the doctor sees, while the symptoms are the manifestations the patient sees. We will have hyponatremia, low sodium. These patients will be having an episodes of fainting due to hypotension. Also, high potassium level causing hyperkalemia. The patient also will suffer from anemia, low cortisol, and also hypoglycemia. The patient will feel abdominal pain, muscle wasting, extreme fatigue, also weight loss, salt craving, and hyperpigmentation. Also some abdominal symptoms like nausea and vomiting. So you answered right. We will order some labs. We will order ACTH, cortisol level, CBC, and complete metabolic panel. And this is the patient's labs. So the patient had hyponatremia, sodium is low, hyperkalemia, potassium was high, and hypocortisol level, which is an indicative of a primary adrenal insufficiency. So we referred the patient to endocrinologist, did another testings, and confirmed the diagnosis of Addison and started the patient on a daily corticosteroids. So the 5 S's for the management of Addison's disease: sugar, the patient will have hypoglycemia, so we have to supplement with dextrose. Salt, the patient also will have low blood pressure, so he needs salt. Support, if the patient have an infection, we have to treat aggressively with antibiotics. Steroids, of course, we have to give the patient the lowest effective steroid to maintain body functions. And we have to search for underlying cause for the adrenal destruction. Why it is significant for dental practitioner to know about Addison's disease? This is because if the patient has Addison's disease and he is coming to the dental clinic for dental treatment, he will be most probably stressed. And a stressful situation needs cortisol. These patients cannot produce cortisol, and they may have what we call adrenal crisis, which is a medical emergency. And we have to call the EMS to start dextrose, IV, and also hydrocortisone for the patient. The patient will be hospitalized. It's a life-threatening situation. So it's important for a dental practitioner to know about the signs and symptoms of Addison's disease. Our third case. We have 18 years old Caucasian female referred from ENT to the oral medicine clinic for bilateral earache and difficulty swallowing for duration of 6 months. The ENT ruled out any ear, nose, or throat pathology. She actually went to several ENT specialists, no abnormalities of the ears. But the ENT did prescribe eardrops and antihistamines, no improvement of the earache, but the patient benefited a little bit from the NSAIDs prescribed. Patient otherwise healthy, and she's not on any medication. In the history of present illness, the patient denied any trauma to the head and neck, but she reported occasional frontal headache and neck pain. She denied any TMJ sounds or any episodes of jaw locking, but endorses mild to moderate jaw pain. The patient is aware of a clenching habit day and night. And she has ear pain that is bilateral, dull, achy, constant, but increases in intensity throughout the day with a pressure-like feeling. Symptoms are always there, but worsen with the use of computers and when she's stressed. So the patient, past medical history, past surgical history was non-contributory, no known allergies. She was single, not on any medication, no non-smoker, no alcohol or drug abuse. And the review of system was as the history of present illness. The extraoral and intraoral examination was all within normal limits, but because the patient had jaw complaint, we did a TMJ focused exam. So the patient's maximum incisal distance was 40 millimeters, which was normal, but she experienced mild masseter pain bilaterally. The lateral excursive movements were within normal limits. There was no deviation. There was no clicking or crepitation. And there was no periauricular area pain or no external auditory meatus pain. But the muscle palpation was positive for most of the muscles of mastication. So we palpated the anterior temporalis muscle. Here is the anterior temporalis muscle. You know that the temporalis is a fan-shaped muscle which has a first part, which is anterior part here, a middle part here, and a posterior part. And we also palpated the masseter muscles and was positive bilaterally, mildly to moderately. We also palpated the sternocleidomastoid muscle here bilaterally, and it was moderately to severely tender. The pressure that we have to apply when palpating the muscle of mastication should be about 1 kilogram for 5 seconds to elicit referred pain. We also ordered some imaging like OPG or Panorex, just to rule out any odontogenic cause, it should be the first step you do to rule out any odontogenic cause for the patient pain. So we ruled out any odontogenic cause or any gross pathology of bone. We have mild flattening of the condyle head, which is normal for this patient because she did reported clenching and grinding day and night. So our assessment for this case would be otalgia, ear pain bilaterally, cervicalgia because of the SCM and trapezius, and also myofascial pain of muscles of mastication bilaterally. She also had dysphagia, difficulty swallowing, and parafunctional habit. So we started the patient with a semi-selective COX-2 inhibitor like meloxicam once a day for 2 weeks, conservative treatment like a moist compress, soft diet, and we also prescribed a referral for physical therapy for the patient for the neck muscles and the muscles of mastication, postural modification, and asked the patient to control stress level. Also, at that point, we considered fabrication of an upper occlusal appliance, a night guard. And we asked the patient to come after 3 weeks. So this is actually a very important slide. If you cannot remember anything from this lecture, please remember this slide. If you want to take some pictures, you do that. Because it shows you the concept of heterotropic pain or referred pain. So, for example, if we have, so the X is the site of the origin of the pain, and the red areas are where the pain is felt, the referred pain. So if we have tenderness of the masseter here, the patient will feel pain in the lower molar area. He will feel tooth-like pain in the lower molar area, and also can have pain around the eyes or frontal headache. If the patient have temporalis tenderness, let's say the tenderness is in the anterior temporalis, the patient will have temporal headache and will have central incisor pain. He will feel pain in the central incisor, toothache-like pain. The same for the middle. He will feel pain in the canine premolar area. And for the posterior temporalis, he can have a referred pain in the posterior upper molar area. Our patient had sternocleidomastoid tenderness. It was actually severe. And tenderness in this area will result in earache, like pain, frontal headache, around the eye headache, top of the head headache, occipital headache, and even chest pain and dysphagia. So it can explain the causes of dysphagia for this patient. This is a very nice slide done by Simone and Travel. They are both physical therapists, and I use this to explain this to my patients, the concept of referred pain. So this patient, she came back after 3 weeks, reported 80% improvement of the earache and the headache. Now she doesn't have any dysphagia. She's still doing a physical therapy for the neck and the muscles of mastication, and she started doing exercises for posture and stress relief. And we also took an impression to fabricate an upper hard occlusal appliance. Okay, now we will move to our fourth case. 51 years old female, referred from periodontal department with chief complaint, I injured my tongue with my water floss. It has been there for 4 months and it's not healing. I only have mild pain though. So the patient reported several visits to periodontists to do dental implants. She has plans to do dental implants and seen by multiple oral health care providers for that lesion on the tongue. They did prescribe topicals. She also reported some pain in the right ear, but the pain was mild. So regarding the patient's past medical history, she had colon adenocarcinoma and did surgery and radiation therapy, and she is on remission since 2012. And she doesn't have any known allergies. She's married with 4 children, not on any medication. She is non-smoker, no alcohol or drug abuse, and the review system was as the history of present illness. Regarding the extraoral exam, everything was normal except for right anterior cervical lymphadenopathy. This lymph node was non-tender and was fixated. And intraorally, the right dorsal and lateral tongue was with exophytic growth with moderate erythema and induration. When we palpated that lesion, it was fixed. So this is the clinical picture for the patient tongue. We have another question for you. I think there is something wrong with the connection. So what would be your next step for this patient? Would you do incisional biopsy ASAP? Or would you ask the patient to come after 2 weeks and give her some topicals? Or would you ask the patient not to use the water floss again? Incisional biopsy. So my assessment, I was scared actually when I look at the patient's tongue, and I was thinking of squamous cell carcinoma or metastatic cancer from the patient, old cancer. I, of course, ruled out traumatic ulcer because there was no cause for the trauma and it has been there for 4 months. So we did incisional biopsy for the patient ASAP. And this is the biopsy report. So the patient had an invasive squamous cell carcinoma, moderately differentiated. Actually, the whole pathology slide was with cancer cells. It was very deep. So this is very important also, to notice the oral cancer red flags. This patient, my patient, went to several providers. Most of them were specialists, and nobody recognized the red flags for oral cancer. If there is any ulcer that lasted more than 2 weeks with no reason or on a high-risk site, such as the floor of the mouth or lateral tongue, it is a red flag for oral cancer, so we should biopsy these cases. If the patient have localized pigmented lesion in the oral cavity, it doesn't mean that this is a cancer, but any single pigmented lesion should be biopsied to rule out melanoma. If the patients have red, white, or mixed red and white lesions in the oral cavity with no reason, this is a red flag. If the patient have an ulcer that has rolled margins or indurated when palpation, also is a red flag. Fixation, it means that the cancer cells infiltrated into the submucosa, and this caused the fixation. The lesion is not movable. This is also a red flag. Lymphadenopathy, you know that most cases of lymphadenopathy is benign, usually a passing infection. But sometimes, if you have a fixated, non-tender lymph node, especially unilaterally, it could be a red flag for oral cancer. That's why it's important to do extraoral examination, including lymph node examination for every patient. If the patient have a facial paresthesia for no reason, or pain with no reason, before we used to say that a painful ulcer is a good thing because cancer lesion is non-painful. This is wrong. So actually, recently it was found that pain was one of the first signs of oral cancer. So non-painful or a painful does not mean it's not cancerous. Also, the patient is immunocompromised. You know that the immune system is important not only to fight infection, but also to fight cancer cells. So if the patient is immunocompromised for example, medication he's taking or a condition he's having, you should suspect that he has a risk to develop cancer. If the patient has self or family history of cancer, like our patient, she has history of colon cancer. If there is a systemic signs with no reason, also we should be aware it's a red flag of cancerous process. Our fifth case for today is of a 45-year-old male presented with chief complaint. The dentist told me I have swelling on my tongue. He said that I need biopsy because I may have oral cancer. The patient actually was crying on the dental chair. He cannot eat or sleep for days, and he is now convinced that he has oral cancer. So he was just going to the dentist to do some filling, and the dentist examined the mouth and said that there is a swelling, looked like something that needs a biopsy. And although he was asymptomatic, there was no pain, and he was unaware of it. The patient's past-medical history, past-surgical history were non-contributory, no known allergies. He was married with 2 children, not on any medication, non-smoker, no alcohol or drug abuse, and the review of system was as the history of present illness. Extraorally, intraorally, everything was within normal limits when we did the examination. And this is the clinical picture for the patient. So another question for you, what would you do for this patient? Would you do a biopsy ASAP? Would you reassure the patient that this is a normal thing? Or would you prescribe some topical and ask him to come again after 2 weeks? Reassure, reassure. Why? Because it's just a bunch of lymphoid tissues and the base of the tongue and extending posteriorly and laterally. This is called the lingual tonsils, which is normal anatomy. So another thing that we have to focus from the objective is that we have to distinguish pathology from a variation of normal. Everyone else in the oral healthcare system should know that, either specialist, a GP, or even hygienists. They should know the normal anatomy. الحين تطلع. Okay. So this is the normal anatomy of the tongue. This is called lingual tonsils, and it's a normal anatomy. So this is inappropriate referral. Our final case for today. 50-year-old male.
Dr. Fatma?
Yes.
We have 5 minutes.
5 minutes? Okay, I'll go quickly. 50-year-old male presented to the oral surgery department for evaluation of oral and perioral ulcers. Regarding the history of present illness, he complained of the presence of embedded glass under his oral and perioral ulcers with crawling sensation for about 1 month. He reported that the oral cavity is infested with worms and that the crawling sensation and pain relieved after inflicting wounds with a razor blade or a sewing needle to extract the crawling worms. This affected his personal hygiene. He became socially isolated. He couldn't sleep. He lost 3 kilograms because of the ulceration. And he actually brought with him a bag of folded papers. These are filled with clotted blood and dead tissues. And he considered this as an evidence that he has worms. He's infested with worms, and he extubated them. So regarding the patient's past medical history, past surgical history was all within normal limits, no allergies. He was married with 3 children, not on any medication. He smokes 20 cigarettes a day for 30 years, but no alcohol or drug abuse and no recent travel. Extraorally was normal. Intraorally has a lower anterior gingival margin with erosion and erythema, and skin at the commissure with ulceration extending to the lower lip bilaterally with also evidence of smoker's melanosis. So this is the patient ulceration. He actually inflict this by himself. So my assessment is to rule out a true parasitic infection and also to rule out psychosomatic disorders like delusion of parasite or Malgren's disease, and we'll explain this in a bit. Also, we have to rule out organic causes for the ulceration like hematinic deficiency, hormonal or metabolic deficiency. So we ordered some labs, CBC, complete metabolic panel, TSH, glycosylated hemoglobin, and vitamin B12 because these are organic causes of the crawling sensation, neuropathy. And also we prescribed a topical cream with dexamethasone, chlorhexidine, and nystatin for the ulceration. So he came after 2 weeks, moderate improvement with the topical cream, but he is starting now to inflict wound in the lower labial mucosa. And all the labs were within normal limits. So at that point, we have to rule out psychosomatic disorders. So we referred the patient for psychiatric evaluation. And we also referred him to improve oral hygiene. So this is where this case is very difficult because the multidisciplinary approach was a problem. In this case, we don't have any shared or electronic records with the psychiatry hospital, so we have to call the patient psychiatrist by phone. She said that they did diagnose the patient with psychosis, delusion of parasite, and they prescribed antipsychotic called olanzapine. Actually, after 1 month, he had significant improvement of the crawling sensation. He was worried about the scarring he had left because of the ulceration, so we referred him back to dermatology for aesthetic purposes, and he is still under both psychiatric and oral medicine care. So what is the delusion of parasite and how it is different from Morgellons? Both of them, they are psychosomatic disorders. They are a form of psychosis. In delusion of parasite, the patient have a belief that he is infested with parasites, with worms, and there is a crawling sensation. It's more common in females, actually. While the patient with Morgellons disease, they have a sensation of filaments or crystal-like material emerging from under the oral mucosa. So actually, we published this case because obviously, it is only rarely reported in the literature patient with delusion of parasite happening inside the oral cavity. So we have only 2 cases in the literature with oral Morgellons, 1 with delusion of parasite, and 2, including our case, with the overlap syndrome, both the delusion of parasite and Morgellons. So how can we diagnose a delusion of parasite? We have to exclude primary causes, organic causes for the crawling sensation. And we also have to rule out any anemias, diabetes, hypothyroidism, cocaine abuse, or head trauma because they can cause the sensation of crawling. And actually, this is pathognomic for patients with delusion of parasite. They usually bring specimens with them. So it's called sometimes matchbox box. They put it in a box, the specimens, or Ziploc bag sign. What is the cause? Still unknown, but there is a problem with the midbrain dopamine transport system causing extracellular dopamine, and extracellular dopamine will cause psychosis. Treatment, pharmacologically through antipsychotics, and non-pharmacologically with cognitive behavioral therapy. So this was the difficulties that we face for this case, because any confrontation with this patient will lead to loss of rapport. The patient will not come back again. They will ask, do you think I'm crazy? So if you tell them, yes, you have psychiatric problem, they will not show back. They will not come back again. So you have to tell the patient that the psychiatrist will provide medication that help with the crawling sensation. Also, we have to subject this patient to a lot of examinations, laboratory testing to exclude secondary causes. And also the multidisciplinary approach with psychiatric hospital was difficult. So this is just a summary of today's cases. We have wide arrays of conditions. And I hope by now you have this ability to appreciate the importance of multidisciplinary approach in treating our patients, how to distinguish pathological from non-pathological processes, how to detect serious pathology, life-threatening situations, and when to refer to oral medicine specialists. And thank you. Ready for questions.
Thank you, Dr. Fatma, for this very informative lecture. Anyone has a question for Dr. Fatma? Okay. You have a question?
No questions. يعني ليش ما رديتي عليها رديتي عليها أنا عشان أنا أنزل. Here you go.
أول شيء يعطيك العافية على المحاضرة الحلوة. Very informative. Actually, my question is about referrals. Usually with an oral medicine, it's very important to be like an emergency referral. So how is the process here to refer to you, and how fast the patient can actually get to you?
So
since you're in, I think, in the
Farwaniya. I'm at Farwaniya Specialized Dental Center. So we have about only one oral medicine specialist for every government. So it's very difficult to get the patient ASAP unless there is an emergency, for example, biopsy or an emergency case we can see, but it is, we are promoting now for oral medicine. We want oral medicinists, yes. I think we see as much as possible. So, for example, a good day would be 12 to 13 patients. This is the average. What is really annoying is that we get inappropriate referrals. So we waste the patient time, the specialist time. This time may be needed by another patient. So this is the problem. If everyone else is just little bit keen about the variation of normals or examining the patient, taking good history and doing good clinical examination, the patient will be sent to the right person. But I face about minimally 3 inappropriate referrals a day. That's the problem. But we try to see all the patients ASAP, really.
Okay, thank you very much. That's for appreciating your time. Let's have a photo for this. Okay, so since I value oral medicine topics وللحين ما حد صفق فأنا راح أصفق صفقوا ورايا. Okay, so our next speaker will talk about common temporomandibular disorders. and we will start in 5 minutes, 3 o'clock. كل شيء شغال إن شاء الله. بس شلون بس تمام يلا. Okay, so now we will continue the session.
Test. Okay.
With Dr. Jose Shidiaq. ايش رايك قلتها صح؟
صح.
حبيبي.
شكرا.
His title, or the title of his talk, is Diagnosis of Common Temporomandibular Disorders. This session continues to the evening, so I hope you will join us after the break. Dr. Jose is a former clinical affiliate, American University of Beirut Medical Center, and professor of prosthodontics, occlusion, and orofacial pain at the Lebanese University. He is the founding member of the Lebanese Prosthodontic Society and the Lebanese Society for the Study of Pain, member of the European Academy of Orofacial Pain and the International Association for the Study of Pain. There's too much pain. His practice limited to prosthodontic work, temporomandibular disorders, occlusion, and sleep apnea devices. Another important topic. You have 40 to 45 minutes to complete this presentation. We're here for you and listening to you.
Thank you, Doctor. Assalamu alaikum. I would like to thank the KDA for giving me this opportunity of giving you this lecture. So our topic today will be the diagnosis of common temporomandibular disorder. The lecture outline: what is a temporomandibular disorder, or TMD? What is pain? How do we screen at the clinic for a TMD problem? What is a risk factor and how do we assess the risk factors? How to diagnose a TMD problem? And finally, when do we treat or do we refer the patient to a specialist? So what is TMD? It's a collective term. When we say collective, we need a collection of things. So you have to get many things together that embraces a number of clinical problems that will involve the masticatory musculature, the TMJs, or both. Collective means what? You will need several physical, psychological traumas that will be happening together. And what are the clinical problems? You know that usually patients, they have the capacity to adapt to any type of occlusion or muscular position within certain limits. So many times you just adjust the occlusion to the patient, and that's okay, no problem, okay? When several factors need to adapt together because you have several problems all happening together, then you have a problem. When you have an occlusal problem, you get a trauma, you have muscular tension, you have stress, so the capacity to adapt to all this is much lower, and the outcome becomes a TMD problem. So TMD in the International Classification of Pain is just a musculoskeletal disorder, and you should be diagnosed and treated as any other type of musculoskeletal disorder. You know that TMD is the second most common type of pain after lower back pain. Each one of you here, including me, in a lifetime will at least have once in a lifetime lower back pain, at least once. The second most common type of pain is TMD. So when does a person consult for a TMD disorder? When they are in pain, they will consult, otherwise they don't come. Or because they cannot move their jaw properly. They will come, they say, my jaw is not moving properly. So pain is the major concern. So if you want to treat a TMD, you should need to have a basic knowledge of pain. Like if you want to repair a car, you have to be a mechanic. You have to know how to deal with the motor. This is why we come to our second part, what is pain? In all undergraduate studies, you will learn that pain is an alarm system. It means that your body is being aggressed. There is an aggression. And this is commonly used for acute pain. Sorry. Yes. Doesn't show. Okay. Acute pain is made of several components. And you will see that it's a very important concept. We talk about nociception. What is nociception? It's the sensory encoding of noxious stimuli via afferent fibers of the nervous system from the periphery to the brain, to an area in the brain called the thalamus. So any part in your body which is painful, will pass through the spine up to the higher centers to reach the thalamus, except the head on and the face area, where the pain will go through the trigeminal ganglion to the trigeminal nucleus and then to the thalamus. And the sensitive receptors that will reach the pain are called nociceptors. So until now, we are just talking about a sensation, which is a noxious stimuli. There is no pain here. It's only a sensation. To become pain, this noxious signal should be interpreted in higher centers of the brain. And this is where comes the other components of the pain, the memory component. So from the thalamus, you will go up to the memory center in the brain. Why? Because you need to know whether this unpleasant sensation, is it a new sensation? This is the first time you feel this? Or do I know this feeling? And from the memory component, you will have a different reaction. If this is the first time that you feel this sensation, you will be anxious. You will have fear. You don't know what's happening. Whether if you know already this feeling, you're not in fear, you're not so anxious. You know that's a very small, painful area, no problem. So there is a memory component. The second thing is the affective component. You will be in distress, you will have anxiety, fear, and all this is in acute pain. In chronic pain, you will have depression. So there is an affective component. There is an autonomic component. You will have sympathetic fibers reacting. If the pain is very tough pain, you are really in pain, you will have increased heartbeat. You can have sweating. And some people will have lacrimation. They will cry because they are in pain. So there is an autonomic component. And there is finally a motor component, and that is the reaction you have to pain. From afferent fibers of the nervous system in the central cortex to the muscles involved in pain or the organs or whatever. So all this will become pain. Just having the sensation is not pain. Pain is everything. It's all this. And finally, let's talk just few words about chronic pain. Chronic pain is a disease. Chronic pain is a disease. While acute pain is physiological and is an alarm system to your body's aggression, chronic pain becomes a disease. Why? Because you will still having pain lasting 3 months after the healing has ended. You know, in acute pain, if you fracture your foot, then you cannot move. Each time you try to move, you have pain. And this is to protect you. Why? Because if you move, you won't heal. Once you have healed, the pain is finished. If the pain is still persisting, it means that is not a normal pain, it's chronic pain, it's a disease. Now that we know the pain, when we treat pain, what do? We give pain medication. This is to treat the physiological sensation. You give non-steroidal anti-inflammatory drugs, you give Panadol, paracetamol, over-the-counter painkillers. You are only treating the physiological sensation. We are, as dentists, are very good at that. We are the best people to treat acute pain like that. This is not enough for TMD. Why? Because in TMD, you will need cognitive behavior therapy. You will need trans-electrical nerve stimulation. And these will work on what? On the memory component, to release the memory of pain in the brain. When you give neuropathic medication or psychotherapy or counseling, or you learn relaxation techniques, you are dealing with the affective component of pain. And this is mainly important in chronic pain or in chronic TMD patients. When you do physiotherapy or you do stretching or exercises, you are dealing with the motor component of pain. You know that when a muscle is in pain, he will contract as a reflex, because each time you try to pull it out, you will have pain. So you contract it just to relieve the pain. You need stretching, you need physiotherapy to treat this motor component. So treating TMD is not only giving pain medication. Now that we know what is TMD and what is the pain involved in TMD, we can go to the screening technique. How do we screen that the patient has a TMD problem? There is a quick mode, a very quick mode, a very simple mode. You first ask, do you have pain when you open your mouth wide or chew once a week or more? Or a second question, do you have pain in your temples, in your face, in the temporomandibular joint, once a week or more? Have you lately registered that the jaw is locked or that you can't open wide? And finally, do you have often headaches more than once a week? Only 4 questions, 2 minutes, 4 questions. On the fourth question, a positive answer can be an indication to refer the patient first to a neurologist. Why? Because new headaches, especially after 50, are risky. And the neurologist would have to diagnose between a primary and a secondary headache. And this is very important. So we as dentists are very keen to refer to a neurologist every time the patient says, I have everyday headaches, it's impossible. So, if the patient replies yes to one of the 4 questions, then you know that he might be a patient with a TMD problem. And then you will start assessing and taking a more thorough history to know what is really happening. So this is just to know whether you say to him, go home, you don't have anything, or yes, you have a problem, let's see what is your problem. And this is why we get to the risk factors and do the assessment of the risk factors. What is a risk factor? It's a physical or a psychological trauma happening once or more. Why do we say a risk factor? Because it does not mean that you had this factor and because of this factor you have a TMD problem. No, it's only a risk factor. But ending up having 2, 3, 4, 5, 6 risk factors happening together, at the end you will have a TMD problem. So the main goal of the assessment is to gather information to establish a working diagnosis. And this goal will be achieved through a thorough history and examination. And you need to find a collection. You need to find how many risk factors you have happening together to constitute the basis of a probable TMD problem. And the question is, do we have an acute or a chronic problem? The limit is 3 months. If the patient comes and says, I've been 3 months having pain in my jaw, this is chronic. don't go to this, don't enter this. Just say to him, no, you have to go to see a specialist. If it's an acute problem, very well, you can treat. Chronic, stay away. Pain is a major concern. Joint impairment in function is a major concern. Chronic transformation is a major concern. Before doing anything, just you have to ask for a panoramic X-ray. Why? First, you have to examine the joint space. Then you need to eliminate if there is any ankylosis, any fracture, or any asymmetry between the two sides. If you look at this panoramic X-ray, this patient was 18 years old. He went through 5, 6, 7 dentists. Every dentist tried to adjust his occlusion, give him a splint. The problem was he cannot open wide. Nobody asked for an X-ray. If you look at the coronoid process, you will see that it's a very long coronoid process. So the problem was only mechanical. He had nothing in the joint. It was only the coronoid process. We referred him to a maxillofacial surgeon. He just cut the coronoid process and the opening was normal again. So this is important to have a panoramic X-ray, at least to screen any problem. What about bruxism? Bruxism is a microtraumatism. Okay? It's a microtraumatism. It is a sleep disorder, nothing to do with the mouth, in the brain, central brain, sleep disorder, centrally mediated, involuntary. During an episode of bruxism, you have the jaw opening and the jaw closing muscles that contract simultaneously. And when the two group of muscles contract simultaneously, it means it cannot be occlusion. So it is not related to any type of malocclusion. And it's different than the parafunctional habit of clenching the teeth during the day, because the parafunctional habit of clenching the teeth during the day is voluntary, while this is involuntary. And there is a high association between TMD and bruxism, meaning that not every bruxist patient can have a TMD. But if you have a TMD problem and you are a bruxist, you will increase the problem of the TMD. What about occlusion? Unilateral crossbite is a problem. You know why? Because when you have unilateral crossbite, you will eat only on the crossbite side. And you will eat on the crossbite side because on the other side you have normal occlusion, so you will eat normally. While if you reverse the eating and you eat on the normal side, you will have an interference on the crossbite and you won't be able to eat. So you are overloading the joint on the crossbite side. And this is a risk factor. You have people, they eat for 40 years on one side. They don't have any problem. But if you might have a risk factor like that, you add to it other risk factors, you might become to have a TMD problem. What about the angle class 2 division 2? You know, in angle class 2 division 2, you have at least 5 to 6 millimeters of freeway space, while the normal is 2 to 3 millimeters. So you are doubling the effort to open to be able to eat. And doubling the effort to be able to eat is doubling the effort on the joint. So doubling the effort on the joint is a risk factor. Risk factor can cause a TMD problem. What about an overjet of more than 6 millimeters or an angle class 2 division 1? In both situations, you will need to go forward at least 6 millimeters to be able to open and bite. So here again, we are overloading the joints. What about a patient with more than 6 posterior teeth smithing? The same as the class 2 division 1. We have to go forward, we put more load on the joint, so this is a fatigued joint. You can have a TMD problem. What about the macro traumatism? We talked about the micro traumatism like bruxism. What about the macro? You should know that extracting a lower third molar is 33% of all our TMD cases come from extracting a third lower molar tooth. Why? Because the dentist is tense, we are doing surgery, we don't see, we overstretch the mouth opening, we overstretch the ligaments of the joint, and then we have a TMD problem. The second macro trauma is a whiplash injury. You are sitting in your car, relaxed, the mouth is in a rest position, not tense, you are listening to music, and somebody bumps from the back and hits you. So your neck will go backwards, your mouth will open and will close suddenly, you have a trauma. So you will have an injury in the joint. And after a whiplash injury, even after 6 months, you can have a TMD problem. So you should ask your patient, did you had any car accident? And the final macro trauma is sports injury. I receive every week in my practice maybe 2 or 3 cases of martial arts, karate, taekwondo. He do fights and he gets a blow. Or the basketball player, he gets, a shoulder on his jaw. And this is a cause of TMD problem. What about the posture? You know that when you lean your head forward, you put tension on all your posterior neck muscles. This is typical for dentists because you are sitting on your chair and putting your head forward, okay? And all the people who work on computers for more than 6 hours, they have this problem. You have to make a differential diagnosis with cervicogenic headache or tension type headache. On the right picture, you will see that the head is between the white lines, while in normal situation, the head should be between the black lines. And as a reference for you, take the chin. The chin of the patient should be at the sternum. If it's not at the sternum, then the head is in a forward position. This is the normal posture of the head. You can see that the center of gravity of the head should be in the middle between the neck and the front neck, and the posterior muscles should be relaxed. Dr. Fatma talked about the Perkins and Trevor trigger points. Also, I will not go very long on it because she explained it in details, and I'm very thankful for her presentation. It was a very nice presentation. So this is the trigger points. if you put any pressure on any trigger point, you can have referred pain. And this is what we call it a risk factor. Finally, no. Cervical nerve compression. Okay. You know that cervical nerve 2, sensitive innervation, will innerve the lower part of the mandible up to half the ear and behind the ear. So any problem in your neck can transmit pain in the TMJ and the angle of the mandible area. So if you have a patient, he says, I have pain in my joint. You examine the joint, there's nothing. You don't see anything. Everything is normal. Try to think about the neck. Maybe it's coming from the neck. It's not a joint problem. It's a cervical spine neck problem. And this is a risk factor. Finally, you will have some people coming with tinnitus or tension in the ear area. This is also another risk factor. Now that we made a round of everything, what is TMD, we have an idea of what is pain, how do we diagnose a common temporomandibular disorder? You know, in the 50s, all problems were under one umbrella. It's a TMJ problem. So every problem coming into this area is a TMJ problem. What is the main purpose? The purpose is if you have everything under one umbrella, you have one diagnosis and then you have one treatment. While if you have subclassifications, then you will see that you can have many problems. And if you have many problems, you can have different diagnoses. And if you have different diagnoses, then you will have a different treatment. And this is why Okeson in 1995 already subclassified all TMJ problems into fracture, congenital, ankylosis, disc derangement, TMJ dislocation, inflammatory disorders, or osteoarthritis. So when you know in which subclassification you are, you will see that you will have a different treatment. So it's very important to diagnose well a TMD disorder, to exactly know what we will do as a treatment. Is it an acute or a chronic problem? More than 3 months? Don't bother. Refer to a specialist, because chronic cases are very difficult. Acute? Try, no problem. Is it nociceptive, physiological? Is it neuropathic? Do we have a central mediation problem, or both? Is it asymmetric? Why? If I have pain on my right TMJ, and the patient comes and says, you know, I'm clenching on my teeth. Yes, of course, but you clench on both sides. Why you have pain only on one side? You should have pain on both sides. What are the risk factors? All the risk factors that we described before. What are they? Do I have a trauma? A micro trauma like bruxism, or a macro trauma like a whiplash? Do I have bruxism? Do I have a posture problem? Do I have a neck problem? Do I have an occlusion problem? Is it a relapse? How annoying is it? You should ask the patient from 0 to 10. How painful is this? 0, no pain. 10, you're going to shoot yourself. Give me a number. Is it muscular? Is it a muscular problem? We said that TMD is a musculoskeletal problem. So is it muscular Or is it articular? Or is it both? How do I know? Is it local or systemic? شو صار هون؟ You know, if it's systemic, let's say you have polyarthritis, okay? Then all the joints will have problems. You have arthritis on all the joints. So the TMJ is a joint. It's like any other joint. So if you have polyarthritis, you just refer the patient to a rheumatologist. You tell him, your problem is not with me. You have a systemic disease. How do we diagnose if the problem is articular or is muscular? We do a test. We call it the end-feel test. What is this test? We test the end opening from the AROM of the active range of movement position. We just ask the patient to open wide as much as he can. And we measure. Okay? You know that the normal opening is around 45 millimeters. So if he opens 30, it's less. If he opens 60, it's more. Then once he opened wide, we test the passive range of motion. The passive range of motion is that I put my thumb and my index on the incisors and I try to force the opening. So, if nothing moves, it's articular. It's a lock in the joint. While if I push and I can obtain 2 or 3 millimeters more of opening, then what? It's muscular. And it's only a reflex because when I will try to push, he will feel pain. Okay? So basically, if there is no movement, we say we have a heart feel problem, and this is an articular disorder. While if there is a movement, we call it a soft feel, then it is muscular because the muscle is shortened to prevent it from having pain. Let's move to all the articular problems. The ankylosis. What is an ankylosis? You have an AROM of 18 to 20, a history of trauma, a short side ipsilateral to ankylosis. On this panoramic X-ray, the left side is ankylosed and is shorter than the right side. What is a capsulitis, or a scientifically termed disc displacement with reduction? First, you have a normal range of movement. It's 45. You have history of trauma. You have clicking sounds. Why clicking sounds? Because the disc, which is between the two bones, is outside the joint. So every time you open, you hear a click. And when you close, you hear another click. You can have or don't have bruxism. Both can be present. The mandibular condyle is off the disc when the jaw is closed. If you do an MRI, you will see that the disc is not at the 12th position, it's forward. You will have a clicking sound either once or twice. And then, in this situation, when you have a capsulitis, you don't treat. Only if there is pain. If there is pain, you treat. No pain, nothing. Observation. You say to the patient, come back in 1 month or 3 months, and we will see how it goes on. And this is the capsulitis. What about the closed lock? In scientific terms, it's called the disc displacement with no reduction. What is a disc displacement with no reduction? It means the disc went out of the joint. It's completely out. And because it's completely out, when you try to open, the disc will come between the joint and the bone, and you will not be able to open. You will lock. This is why the active range will be around 20 to 35. Remember, ankylosis is less. This is 20 to 35. On opening, you will have a deviation of the mandible towards the affected sides, the side that has the closed lock. On the right picture, you will see that the green sticks, the lower side is going to the right of the patient because this patient has a right closed lock. And the opening is 24. And the green sticks are not aligned. So this is a sign that we have a closed lock. If you go to the contralateral side movement, it will be less than the normal. The normal is between 8 to 10. It's 4. If you do the end feel test, you will have a hard end feel. You try to push and nothing happens. If you palpate the area, you will have pain around the right TMJ. And very important, normal occlusion in closed mouth. So the patient can close normally. But when he opens, he just opens 20. So this is a closed lock. What about the anchored disc phenomenon? It's a sudden onset. No clicking sound. The patient has never heard of clicking sounds. And suddenly, he cannot open. What's happening? His active range is less than the closed lock. It's 10 to 15, almost like an ankylosis. And there are no clicking history. And the contralateral side also is restricted. He cannot go into laterality very wide. He just goes 3 to 5 millimeters. While on the side of the lock, it's normal. He cannot go into protrusive, and there is no pain, no muscle pain. What is happening? The disc is completely dehydrated, and it is inside the joint. And the treatment here is not neither occlusal adjustment, nor a splint or a night guard or a non-steroidal anti-inflammatory drug. It will serve for nothing. Here what you need to do is to do a lavage. You need to wash the joint with an arthrocentesis. And then the joint will get back all its fluids and everything will go back to normal. And with the arthrocentesis, you will get out all the inflammatory mediators and the inflammatory fluid that is inside the joint. The open lock is completely the opposite of the closed lock. The patient will open wide, and usually it happens when he's yawning. He's very tired, he comes after work. He yawns very wide, or because I'm not very funny, so you are sleepy and then you yawn, you know. And he opens very wide and suddenly he locks. Okay? So this is the open lock situation. On the upper panoramic, here you have the lock and here we manipulated the patient. To manipulate the patient, you have to put your thumbs on the molar area, on the mandible, and you have to hold the mandible with your finger, and you will push very hard on downwards and backwards. And this maneuver was created by Nélaton. Nélaton was the private physician of Napoleon III. He described this maneuver. And usually, with the open lock, you will have a joint hyperlaxity. all the joints will be hyperlax. So if I try to push my hand here, I'm not very hyperlax. The hyperlax will touch. And because we have joint hyperlaxity, the opening is very wide. He can open 55 to 60, while the normal is 45 to 50 maximum.
Doctor, you have 5 minutes.
Okay. What about the vascular problems? We have myofascial pain. The jaw closing muscles or the jaw opening muscles, the neck muscles, is it unilateral, bilateral? Is it a Tyson type headache? As Dr. Fatima also showed you how to palpate the muscles, I'm not going to go further, she already did. The trismus, the active range is between 13 and 17. You have a passive and end feel soft. You can add 2 millimeters. It's muscular origin and traumatic, usually after third lower molar extraction. Internal pterygoid muscle spasm, it's pain on resistance to protrusion. You put your fist on the chin, you ask the patient to go forward. He cannot or he is in pain. This is usually due, and you have to check for an atypical deglutition. The bruxism is a sleep disorder. You are loading the joints. You have to use a conservative approach. Never do any occlusal correction. Just do a night guard. The parafunctional habits are the same, but during the day. It is a stress-related. Also, we are loading the joints, conservative approach, no occlusion correction. Cognitive behavior therapy exercises, no splint. Treat or refer. Is it an acute problem? Yes, treat. Do you have a working diagnosis? Yes, treat. No trial and error, because when you try and then you go 2 weeks, 3 weeks, he comes back, you try another thing, it becomes chronic. From a simple case, you are transforming your patient into a complex chronic case. Always prefer a reversible therapy versus a non-reversible one. What does this mean? Means occlusion is a potential aggravating factor, not a causative one. Orthodontic treatment is not for treating TMD, and no need to adjust occlusion by grinding or changing restoration. Finally, always aimed at combined therapeutic approaches. What does this mean? It means a teamwork is always preferable. Physical, psychological, and physiotherapy team help is better. Splints and night guards are not universal panacea. Bruxism is a sleep disorder not related to occlusion. Always aim at preventing an acute simple problem to become a chronic complicated one. And when in doubt, please refer to a specialist. Thank you for your attention.
Thank you very much, Dr. Jose. محاضرة جميلة مهضومة مثلك هيك.
خليك.
متى رايح لبنان؟ خدي معك.
تفضل.
الله يعطيك العافية. شكرا. Okay, do we have any questions related to the presentation?
First of all, Doctor, thank you so much for your very lovely presentation. Now, my question is, and this is regarding the risk factors, so how significant is a cervical disc prolapse as a potential risk factor for temporomandibular disorders? And if so, can you give us a reason for that?
Yes, this is a very good question. The reason is that pain, you have a limit of tolerance to pain, okay? So if you are every day having pain because of your cervical spine problem, then any other minor thing will provoke pain, and your tolerance to pain is becoming less and less and less, so you will feel the pain. While if you don't have any problem and there is a minor pain coming and you are psychologically in a good health, in a good condition, you are a happy person, your endorphins of your body will secrete endorphins and the pain will go away. But this pain will become very relevant if you are already having many places in your body which are in pain, and then your tolerance to pain is much lower. Because as I said in the beginning, pain is not only a physical sensation, it's also an emotional sensation. So when your emotions are tired because you are having pain every day, then your tolerance to pain and your sensitivity to pain will increase. Did I answer your question?
Yes, thank you so much.
Any other questions?
Yes.
When you say refer to a specialist, would that specialist be a TMD specialist or an oral medicine specialist?
There are two specialists. Oral medicine, Dr. Fatima should be able to be, she is a specialist, so this is the one. And the second would be a person like me who did an orofacial pain specialty.
Thank you for this much needed answer, because there's lots of confusion regarding who should treat TMDs.
Yes. No oral medicine, these are the people who can also treat all these conditions.
Any other questions?
Okay, that's a good question also. First, it should be hard and not soft, because the soft appliance will have sorry, I have to rewind a bit. You only do night guards for bruxism, not for other conditions. You know, 20 years ago, we used to do anterior repositioning appliances and a jig of Lucia and all this stuff. This is all into the rubbish now. Don't use. You only do splints for bruxism and for night bruxism, not for the day, because the day is voluntary. You do CBT. You don't do a splint. So this splint should be hard and not soft, because if it is soft and you are sleeping, you don't know what you're doing, then you will bite more on the splint, okay? So it should be hard. And then upper or lower, there is not such a big difference. Usually, personally, I do it on the upper, because I think that when your mandible goes forward, then it is stopped by the upper. While if you do the lower, and the mandible can go forward. So depending on the occlusion of the patient, but usually I do the upper ones.
Any more questions? Since you mentioned martial arts as a risk factor, there's lots of, nearly all the sports activities. I had one day a handball player كان عندهم I think game بس وحشية يعني كان ضرب كتير يعني. فإجاني هذا with some TMD mainly articular, and I told him what he has. بعد أسبوع الفريق كله جاني، وبعدها بأسبوعين حتى الفريق اللي ضربوا معه. Anyway, thank you very much.
Okay, thank you. Thank you.
So we have the opening ceremony in the other hall. And we're back here at 5 o'clock, 5:30, to continue the session. Thank you for being here and see you later.
الله الرحمن الرحيم. أي شيء ماشي الحال. أيوه. بوه الصوت وايد بسندرهم انا بروحي صوت عادي.
See this. Good evening, everyone. Please welcome Dr. Suhaila Al-Bannai. She is a prosthodontist, a consultant prosthodontist, and head of department at Hamad Medical Corporation in Doha, Qatar. Dr. Suhaila has a MSc in prosthodontics and a fellowship in quality and safety in healthcare management and a fellowship in prosthodontics from the Royal College of Surgeons of Edinburgh. Please welcome Dr. Suhaila. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you first for the KDA. بسم الله الرحمن الرحيم وقل ربي زدني علما صدق الله العظيم. Prevention and treatment of tooth whitening complications. Introduction. Tooth whitening is not a new technique in dentistry. It is evident from the published literature that the technique was used for over 150 years. Teeth whitening is a famous cosmetic dental treatment because it can enhance the smile by making the teeth several shades whiter. But like other dental services, tooth whitening also comes with risk. Changing the color of teeth is an evidence that involves a serious burden on the patient's body. Despite the great experience accumulated in this area, no one can guarantee a certain result. This happens not only because of the differences in the condition of conducting, but also mostly due to the reaction of the human body to certain influences. The question concerning the whiteness of teeth is a complex one, since tooth whitens will vary from individual to individual and is also dependent on the age, culture, and other factors. Tooth whitening following treatment may also be dependent on the type of the whitening system used to whiten the teeth. It is evident that individuals have different responses to tooth whitening. Some may respond very well to the process and have dramatically whiter teeth as a result, whereas others may notice very little differences at all. There are several side effects to the process, and these include tooth sensitivity and gingival irritation. For example, some individuals may experience no pain or sensitivity at all following the procedure. However, according to several investigators, many individuals will experience some kind of sensitivity either during and/or after initial treatment. This is usually described by the patient as sporadic, sharp shooting pain coming from their teeth following the procedure. Normally, these side effects should result after approximately 48 hours, although in extreme situations, this may last for several months. Overuse or misuse of teeth whitening products can also lead to enamel damage, gum irritation, and discoloration. Definition of tooth whitening. Tooth whitening is defined as any process that lightens the color of the teeth. Whitening may be accomplished by physical removal of the stain or chemical reaction to lighten the tooth color. Natural color of teeth. Teeth made up of many colors with natural graduation from darker gingival third to lighter incisal third. This variation is affected by the thickness and the translucency of enamel and dentine, as well as by the reflectance of different colors. Canine teeth are naturally darker than central and lateral incisors, and teeth become darker with age, whereas lighter teeth are common in younger people, especially in primary teeth. The color of the teeth is primarily determined by the dentine, but is influenced by the color, translucency, and varying degree of calcification of enamel, as well as its thickness, which is notably greatest at the occlusal or incisal edges. The normal color of teeth is determined by the blue, green, and pink tints of enamel, and is reinforced by the yellow through to brown shade of the dentine beneath. The appearance of teeth depends on their absorption or reflective properties of light and is influenced by all the structures that makes up the tooth, including dentine, enamel, and the pulp. Any changes to these structures during formation or throughout development of post-eruption from 3 months in uterus to 20 years can cause a change in light transmission properties and hence discoloration. Classification of tooth discoloration, intrinsic discoloration and extrinsic discoloration. Intrinsic discoloration occur following a change to the structural composition or thickness of the enamel hard tissue. Thickness of the dental hard tissue. This classification can be further divided into the following categories: metabolic causes, inherited causes, iatrogenic, traumatic, idiopathic cause, and aging causes. The route by which pigments may become intrinsic are developmental defect or acquired defect. Acquired defects like tooth wear and gingival recession, dental caries, and restorative materials. Extrinsic discoloration. Discoloration is outside the tooth substance and lies on the tooth surface or in the acquired pellicle. Extrinsic tooth discoloration has usually been classified according to its origin, whether metallic or non-metallic. Metallic extrinsic staining of teeth may be associated with occupational exposure to metallic salt and with a number of medicine containing metal salts. Non-metallic, the non-metallic extrinsic stain are adsorbed onto the tooth surface deposit, such as plaque or the acquired pellicle. The possible etiological agent include dietary component, beverages, tobacco, mouth rinses, and other medicament. Extrinsic discoloration, the cause for extrinsic staining, can be divided into 2 categories: direct extrinsic tooth staining and indirect extrinsic tooth staining. The direct extrinsic tooth staining, direct staining, chromogene derived from dietary source, such as tea, coffee, are taken up into the pellicle and their natural color imparts the stain into the tooth surface. Smoking or chewing tobacco, medicines, and vegetables are also known to cause direct staining. Indirect extrinsic tooth staining, those which lead to staining caused by chemical interaction at the tooth surface associated with polyvalent metal salt and cationic antiseptic such as chlorhexidine chloride and other mouth rinses. History of tooth whitening. From reviewing the published literatures, it is evident that attempts to find an effective bleaching method have been made throughout the history of dentistry. The desire to have whiter teeth dates back to at least 2,000 years ago. During the 1st century, Roman physicians claimed that the use of urine, especially Portuguese urine, when brushing the teeth would whiten the teeth. Barber surgeons also used a solution of nitric acid to lighten the teeth after using a coarse metal file to abrade the enamel. This technique was practiced until the late 18th century. According to Dahal and Pellinson in 2003, a bleaching of discolored pulpless teeth was first described in 1864, and a variety of medicaments such as chloride, sodium hypochlorite, sodium perborate, and hydrogen peroxide were used, alone or in combination, with or without heat activation. Furthermore, in 1895, it was reported that the combination use of pyrozone 25% and electricity was effective in bleaching endodontically treated teeth. Then in 1916, it was reported that the use of hypochloric acid was effective in treating endemic fluorosis. In 1939, the use of 30% hydrogen peroxide, ether, and heat was advocated to treat fluorosis staining. And in 1966, the combination use of hypochloric acid and hydrogen peroxide was promoted as a technique to remove a brown stain from motile teeth. In 1970, there is a published literature. They published a method for bleaching tetracycline stained teeth in young adults with a history of cystic fibrosis. The so-called walking bleach technique was introduced in 1961 and involved the placement of a mixture of sodium perborate and water into the pulp chamber, which was subsequently sealed off between the patient's visit. The method was later modified, and the water component was replaced by 30 to 35% hydrogen peroxide to improve whitening effect. An observation by an orthodontist that the application of 10% carbamide peroxide in a tray whitened the teeth following treatment for gingivitis lead to the concept of night guard bleaching. This observation subsequently led to the night guard vital bleaching technique for whitening teeth in 1989, when Haywood and Heyman described the use of 10% carbamide peroxide in a mouth guard for overnight use. The night guard was for vital bleaching technique for whitening teeth is still recommended as a take-home bleaching system for patient self-application. Currently, 4 different approaches to vital tooth whitening have been recommended and are as follows. 1, the use of high concentration of hydrogen peroxide. They use 35 to 50% of carbamide hydrogen peroxide or carbamide peroxide 35 to 40%, and this is called dentist-administered bleaching. Second, the use of a bleaching tray with high concentration of carbamide peroxide 35 to 40%, which is placed in the patient's mouth for 30 minutes to 2 hours, and this is called in-office dentist-supervised bleaching. 3, at-home or night guard bleaching, which is patient-administered in the form of custom tray with a solution of carbamide peroxide 5 to 25%, and this is called dentist-provided bleaching, patient-administered. And the 4th, various concentration of hydrogen peroxide or carbamide peroxide product available in a prefabricated tray or whitening strips to be used by patient consumers, over-the-counter product available for administration by the patient and consumers. Tooth whitening system. Tooth whitening with different concentration of peroxide has been demonstrated to be safe and effective in a variety of regimens, including in-office procedure, dentist prescribed and supervised home treatment, and over-the-counter system approach. First, take-home system. Second, in-office system. 3, combination technique of take-home system and in-office system. 4th, whitening strips. 5, light-activated whitening system. 6, toothpaste. 7, over-the-counter product. The take-home system, it is the most common regimen in the at-home use for 2 to 4 weeks, based on the color of the teeth at the start of the whitening. The use of hydrogen peroxide for removing intrinsic stain from vital teeth has been used for many years. Haywood and Heyman in 1989 published the first article describing night guard vital bleaching. A tray was fabricated from a model of a teeth using a soft plastic night guard. Take-home system. This tray was then loaded with carbamide peroxide gel and seated over the teeth for approximately 2 hours. The most commonly prescribed concentration are 10% to 22% of carbamide peroxide. The advantages of take-home system is the decreased cost compared to the in-office bleaching options. The major disadvantages are they require significant patient compliance with the number of applications, usually involving 1 to 2 hours, twice a day, or overnight wear. And the entire treatment usually at least takes 4 weeks. Second, in office system, it is the most acceptable application. The use of 15, 30, or 35% hydrogen peroxide bleaching agent, heated or non-heated, with the use of heat or without the heat. The advantages of the in-office procedure are it requires minimum patient compliance and immediate results are attainable. The advantages are chair-side requirement, cost to the patient, and usually require multiple office visits. Combination technique, by combining the two techniques, the in-office and take-home system, there is a reduction in the amount of time and the need for the repeated office visits, as well as the expense associated with in-office bleaching as a standalone technique. It increases the overall success and patient's satisfaction. This procedure involved the use of high concentration of hydrogen peroxide, about 35%, delivered chairside for 1 hour, followed by take-home regimen for 5 days. This is often followed by additional chairside application. Whitening strips, a new method involving using a 5.3% of hydrogen peroxide impregnated polyethylene strips for 30 minutes twice daily. This method is recommended for maintaining already whitened teeth. It can also be a good option to the patient who cannot afford the cost of other whitening treatments or who do not have the time for multiple dental visits for tray fabrication. Development of this flexible polyethylene whitening strips allow for consistent bleaching using shorter contact time. Studies demonstrated that a modest increase in peroxide concentration ranging from 0.4% to 10% on a flexible bleaching strips result in increased whitening effectiveness without adversely impacting on overall tolerability. Light-activated whitening system. The introduction of light-activated devices such as plasma arc, light-emitting diode, argon laser, metal halide, and xenon halogen lights by dental manufacturers has helped to create a public demand for the light-enhanced tooth whitening system. The efficiency of this whitening system, however, is controversial. Published studies appear to be equivalent. For example, there is a study done in 2003 reported positive results, while there are 2 studies done in 2003 and 2002 repeated negative findings. Such studies, therefore, would either support or would refuse the efficiency of these systems. The use of hydrogen peroxide for bleaching teeth has also been supplemented with the use of heat. To gain treatment time, clinicians have attempted to accelerate the degradation of hydrogen peroxide by using light or heat. Cohen and Parkins in 1970 introduced a technique for bleaching discolored teeth using hydrogen peroxide and a handheld heating source. As in vitro study has demonstrated that the use of intense light does elevate the temperature of the bleaching material and as a result may cause an increase in intrapulpal temperature. This observation may therefore have an impact on post-bleaching tooth sensitivity and pulpal health. Light-activated chair-side bleaching system, however, probably offer the benefits of being less time-consuming while producing faster results. Toothpaste. Various types of toothpaste are available in the market as a tooth whitening product, but only a small number of them show stain removal ability and effectiveness. Whitening toothpaste contain mild abrasive to remove surface stain. The peroxide content of these toothpastes are very low, 1% or less, and the exposure of these toothpaste on the tooth surface is minimum. Hence, would be a minimum whitening effect. Over-the-counter product. Easy available of the over-the-counter product whitening has made the whitening of the teeth more popular among people of all ages. There are different types of over-the-counter product, like whitening dentifrice, tray-based whitening strips, and the recently introduced brush application. The latest inclusion of over-the-counter product is a brush technique. This technique is non-tray-based, paint-on application. Over-the-counter bleaching kit require the customer to use either a prefabricated tray or fabricate their own semi-molded tray, then fill it with supplied bleaching agent. These types are less than ideal because the tray are not custom fitted. Development of night guard vital bleaching. A successful home bleaching technique using hydrogen peroxide was first described by Klosmer in 1968. When it was noticed that the teeth became whiter after treatment of the mouth injury with glycoside, hydrogen peroxide mouthwash, in an orthodontic retainer. The result were lighter teeth in addition to healing of the injury. This technique received worldwide acceptance when described by Haywood and Heyman in 1989, which employed 10% of carbamide peroxide in custom-made tray worn at night. The night guard vital bleaching technique introduced by many published literature. Development of power bleaching. In surgery, bleaching technique used since the early 19s were further modified in 1991 with the introduction of the 30% hydrogen peroxide gel activated by conventional light curing units rather than a heat source. This technique is often referred to as power bleaching. Although this power gel could be controlled easily compared to the liquid used previously, full mouth isolation was still needed to protect the gums and surrounding soft tissue. Power bleaching was frequently combined with home-use tray systems to maximize the bleaching effect and give a start to the whitening procedure before the patient continued with night guard bleaching at home. Current bleaching material. A further modification to the power bleaching system was the use of argon laser and as an activating light source to replace conventional curing lights. The present day system are activated by a variety of light source, plasma arc lamp, xenon halogen, light emitting diode, light and diode lasers. Light sources are not essential, and they are systems that require chemical activation only and are merely painted on the tooth with the usual use of gingival and mucosal isolation. Safety concern with tooth bleaching material. A variety of peroxide compounds, including carbon dioxide, hydrogen peroxide, sodium perborate, and calcium perborate, have been used as an active ingredients for bleaching material. However, all extracoronal bleaching material currently available for whitening of vital teeth contain carbamide peroxide and or hydrogen peroxide. Most over-the-counter bleaching products are hydrogen peroxide based, although some contain carbamide peroxide. In an office bleaching material contain high hydrogen peroxide concentration about 25 to 38%, while the hydrogen peroxide content in at-home bleaching product usually ranging from 3% to 7.5%. However, there have been home-use products containing up to 15% hydrogen peroxide. Chloride dioxide is not safe to be used as tooth bleaching treatment due to the low pH of the material and the resultant toothache. Carbamide peroxide decomposes to release hydrogen peroxide in an aqueous medium. So, 10% carbamide peroxide yields roughly 3.5 hydrogen peroxide. Because of the potential of hydrogen peroxide to interact with the DNA, concern with carcinogenicity of the hydrogen peroxide has been raised, although these concerns so far have not sustained through research. However, studies have shown that hydrogen peroxide is an irritant and also cytotoxic. It is known that at a concentration of 10% hydrogen peroxide or higher, the chemical is potentially corrosive to the mucous membrane of the skin, causing burning sensation and tissue damage. During office bleaching treatment, which routinely uses material of greater than or equal to 25% hydrogen peroxide, severe mucosal damage can occur if the gingival protection is inadequate. Clinical studies have observed a higher prevalence of gingival index in patients using bleaching material with higher peroxide concentration. Regarding hard tissue, transient, mild to moderate tooth sensitivity can occur in up to 2/3 of the users during early stage of bleaching treatment. Sensitivity generally related to the peroxide concentration of the material and the contact time. It is most likely the result of easy passage of the peroxide through intact enamel and dentine to the pulp during 5 to 15 minutes exposure intervals. However, there have been no reported long-term adverse pulpal sequelae when proper techniques are employed. The incidence and severity of tooth sensitivity may depend on the quality of the bleaching material, the technique used, and an individual response to the bleaching treatment method and material. To date, there are little published evidence documenting adverse effects of dentist-monitored at-home whitens on enamel, but 2 clinical cases of significant enamel damage have been reported, apparently associated with the use of over-the-counter whitening product. The damage may be related to the low pH of the product and/or overuse. In March 2005, the European Scientific Committee on Consumers Product concluded the following: the proper use of tooth whitening product containing less than 0.1 to 6% of the hydrogen peroxide or equivalent for hydrogen peroxide releasing substance is considered safe. Then it was subsequently updated in 2007. The safety of the tooth bleaching for children and adolescents is also considered. More research is needed to establish appropriate use and limitation of these patients. However, bleaching is a controversial approach compared with the restorative options when tooth discoloration causes significant concern. If possible, delaying the treatment until after permanent teeth have erupted is recommended, and is use of custom fabricated bleaching tray to limit the amount of bleaching gel. Close professional, parental, guardian supervision are needed to maximize benefit and minimum the adverse effect and overdose. Customized bleaching tray should be used to limit the amount of bleaching gel. Adverse effect following tooth whitening procedure. According to study done in 2002, the most common adverse or side effect of using custom-made bleaching tray using 10% carbamide or 30 to 38% hydrogen peroxide as a transient tooth sensitivity, gingival irritation may also occur if the tray is improperly made. The so-called internal bleaching or walking in office technique using 35% of hydrogen peroxide when treating endodontically treated teeth has been reported to cause root resorption. So some of the adverse effects following tooth whitening procedure, cervical root resorption. A review published case reported on cervical root resorption revealed in 22 such a case following intracranial bleaching. 58 bleached teeth, pulpless teeth, which is 30%, they use 30% hydrogen peroxide and heat, were followed for 1 and 8 years, and 4 cases which account for 7% of the external root resorption were observed. A high concentration of hydrogen peroxide in combination with heat seems to promote cervical root resorption, in line And this is in line with the observation made in animal experiments. Tooth sensitivity. Tooth sensitivity is common side effect of external tooth bleaching. Data from various studies of 10% carbamide peroxide indicated that from 15 to 65% of the patients reported increased tooth sensitivity. Higher incidence of tooth sensitivity from 67 to 78% was reported after in-office bleaching with hydrogen peroxide in combination with heat. Tooth sensitivity normal persists up to 4 days, and 4 days after the completion of the bleaching treatment. But a longer duration of up to 39 days has also been reported. Patients with a previous history of tooth sensitivity may thus have a higher risk of such tooth sensitivity from the external tooth bleaching, and this should be taken into the account before treatment begins. Mucosal irritation. A high concentration of hydrogen peroxide from 30 to 35% is caustic to mucous membrane and may cause burn and bleaching of the gingiva. In a clinical trial, used 10% of carbamide peroxide in custom-made tray from 25 to 40% of the patient reported gingival irritation during the treatment. During the active treatment phase of their study, participants using the experimental group 7% hydrogen peroxide bleaching solution reported significantly more tooth sensitivity, gingival irritation, and days of the each compared to the control group. Tooth sensitivity and gingival irritation, as reported by the participants, was mild to moderate. After ending treatment, tooth sensitivity, gingival irritation was resolved in 2 to 3 days and did not recur during the 10-month post-treatment. The result of this study indicate that the hydrogen peroxide bleaching solution evaluated can be safely used to treat teeth. Alteration of enamel surface. Morphological alteration of enamel followed tooth bleaching has been addressed in several studies. Significant surface alteration in enamel topography were observed in enamel slabs treated with the bleaching solution for 4 weeks. Incidence of bleaching sensitivity during and following tooth treatment. Haywood et al. In 2001 reported an incidence of tooth sensitivity of 53% using 10% of carbamide peroxide in custom-fitted trays. Haywood in 1999 published literature reported an overall general sensitivity rate to whitening of 75% of the patients. Another study done in 2004 reported that 67% of the patients experienced transient sensitivity during bleaching. Transient tooth sensitivity in the absence of hydrogen peroxide or carbamide peroxide is related to both dose and time. The higher the dose or the concentration of the whitening agent and the longer the time of the teeth are exposed, the greater the risk of tooth sensitivity. If such sensitivity occurs, the easiest way to address the problem is to decrease the treatment time or the dosage of hydrogen peroxide or carbamide peroxide. For whitening agent delivered with a tray, it is critical to trim the tray accurately, not only to ensure that it is accurately reflects the position of the gingiva, but also the position of the tray border at the cement-to-enamel junction. Although pain in bleached teeth can be evoked by thermal or other stimuli, most patients complain of tingling or shooting pain ginger without provoking stimuli, and this pain may continue for a period following the actual bleaching treatment. Teeth with defects such as caries, defective restoration, or exposed dentine have been suspected of being more prone to bleaching sensitivity than intact teeth. These defects may provide a direct diffusion pathway for peroxide to the deep dentine. Patients with sensitive teeth prior to bleaching are described as being considered particularly prone to bleaching sensitivity. It has been suggested that there may be some degree of pulpal inflammation associated with the bleaching sensitivity. Here is some of the literature's review regarding the bleaching sensitivity during tooth whitening. Several investigators have advocated the use of desensitizing product when considering bleaching or whitening teeth. For example, the use of the product containing 5% potassium nitrate or fluoride in a tray prior to, during, and following treatment may be beneficial in reducing bleaching sensitivity. Amorphous calcium phosphate can also be used either as a toothpaste or as a professionally applied product. For patients with the pre-existing dentine sensitivity, the use of desensitizing product, toothpaste, or in a bleaching tray prior to bleaching the teeth may alleviate further discomfort during the bleaching phase of the treatment. The efficiency of desensitizing agent used in patients who experience tooth sensitivity during tooth whitening has been reported in a study of such patients who had pre-existing symptoms prior to the start of the whitening procedure. According to the study done in 2000 and 2006, sensitivity is a common adverse reaction of external bleaching and may persist up to 4 days following bleaching, although a duration of up to 39 days have been recorded. Reported incidence of dentine sensitivity range from 15 to 65% of the patient using 10% carbamide peroxide. حتى السماعة تعبت. نعم. ليش ما صار اوف؟ لا ما شاء الله صوتي. شو ده عدل؟ كويس كده؟ And then reported incidence of dentine sensitivity ranging from 15 to 65% of the patient using 10% carbamide peroxide, whereas higher incidence, like 67 to 78% were reported when using hydrogen peroxide in combination with heat. Risk factors for the development of a bleaching sensitivity and gingival irritation that are associated with night guard vital bleaching were reported. No statistical relationship exists between age, gender, or tooth characteristic with the dental arch bleached and the development of side effects. However, there was a statistically significant association existing between the side effect and the whitening solution used. This association, however, disappeared when the analysis was controlled for the usage pattern. Patients who changed the whitening solution more than once a day reported more statistically significant side effects than who did not change the whitening solution during their usage time. Precaution for teeth whitening. During teeth whitening procedure, manufacturer's instruction should be followed carefully. Teeth whitening treatment should never be done more than once a day. Contact with gum and lips should be avoided. Patients should stop immediately and consult their dentist if they experience any sensitivity or discomfort during treatment. Teeth whitening is generally not recommended for pregnant or breastfeeding, have cracked teeth or gum disease, children under 16 years of age, patient with periodontal disease, patient with teeth decay, cavities, exposed root, people who are allergic to teeth, bleaching, whitening agents like peroxide, and individuals with sensitive teeth. That's why patients are advised to consult their dentist before starting any whitening procedure. Professional teeth whitening preferred in a dentist office is recommended once every year to 1.5 years, depending on how long the result lasts. At-home kit can be used as often as once every 4 to 6 months. Whitening teeth too often could cause a certain oral health concern, such as worn down enamel. Custom-fitted trays and in-office treatment are the safest and most effective way to whiten teeth. Following whitening of teeth, avoid the following for at least 48 hours, 2 days after treatment. Drinking strongly colored beverage, eating food that stain, colored dental hygiene product, tea and coffee should cut out tobacco product. According to dentists, any drink with the color, especially things that like coffee, soda, tea, can negatively impact teeth whitening after treatment, which is why we do not recommend drinking any substance with coloring for 2 days after whitening treatment. After whitening, patients are also advised to avoid acidic food and drinks. Acidic food and drinks such as soda, citrus fruit can irritate the mouth, increasing the tooth sensitivity. Continue using of desensitizing toothpaste, brushing with desensitizing toothpaste and or applying a desensitizing gel for the first 2 days after the whitening procedure will help the patient to cope with any sensitivity that may experience. Brush gently. The use of soft, bristle toothbrush and to rinse with warm water help to minimize sensitivity. To drink through straw. Drinking through straw right after the whitening treatment will help to prevent the liquid from contacting the teeth, which can minimize discomfort. If the patient are absolutely must drink an ice-cold beverage, they can sip it through a straw to avoid contact with teeth. To use a fluoride product like toothpaste and mouthwashes containing fluoride can help to remineralize the teeth and block the pain signals to the oral nerves. Okay, patients are advised to avoid any foods or beverage that are extreme in temperature for at least a couple of days after teeth whitening treatment. This includes cold food like ice cream, as well as hot food and beverage like coffee, tea, and soup. The bleaching agent in the teeth whitening solution open the pores of the teeth and leave the nerves that reside inside the teeth vulnerable, which is why sensitivity is common. However, if the teeth are not exposed to food and beverage that are irritating, heightened sensitivity shouldn't be an issue. To help to prevent some of the sensitivity, patient can ask the dentist to use teeth whitening product with a lower concentration of hydrogen peroxide for an office treatment. The lower the hydrogen peroxide concentration, the longer the patient need to use the product, but they will likely experience less sensitivity because of it. It's also recommended that the patient speak to dentist if they are experience recurring sensitivity. Most importantly, the patient should always avoid over-the-counter whitening product. This system use generic tray which don't fit the contour of the mouth properly, causing the bleaching gel to contact the gum, and this will increase the sensitivity that the patient might experience after treatment. If the patient has sensitivity before start of the whitening, it is recommended to use a desensitizing toothpaste 2 weeks prior to the at-home whitening treatment, as well as to continue use during and after whitening treatment. Patients should consult the dentist about using desensitizing toothpaste to help to relieve sensitivity after whitening. Using soft bristle toothbrush, brushing with a toothbrush with finer bristle, especially if the patient brush too vigorously, can lead to further damage to the gum and tooth enamel. Brushing the teeth is one of the most important aspect of the good oral hygiene routine. So patients should continue to brush regularly, but they should use a soft brush. Internal bleaching with 30% hydrogen peroxide solution is aesthetically very successful in the short term. However, in the long term, the success rate falls below 50%. This procedure is associated with the risk of external root resorption documented both clinically and experimentally. If irritation develops after pain medication can wear off, and this week they can use anti-inflammatory medicine like ibuprofen. Conclusion: tooth whitening has become one of the most requested dental treatment by the public. Tooth stain are classified according to their origin into two categories, intrinsic and extrinsic. The whitening system are generally organized into two classes: in-office and at-home product. Most of the whitening system use hydrogen peroxide as an active oxide agent to degrade the organic compound that causes stain. Modern tooth whitening procedure include the treatment with carbamide peroxide and hydrogen peroxide gel of different concentration, with or without the application of light from various sources. Carbamide peroxide breaks down into hydrogen peroxide and urea, with the hydrogen peroxide concentration being approximately 1/3 of the original carbamide peroxide percentage. According to current scientific data, the time required to achieve the greatest whitening effect depends directly on the treatment duration and the concentration of the applied gel, but does not depend on the gel type. Various concentration of tooth whitening gel can be used during whitening procedure, with or without the use of different light source. Light is a catalytic that increases the absorption of the gel and accelerates the chemical oxidation process. Tooth whitening procedure may adversely affect both hard and soft tissue in the oral cavity, as well as dental pulp, although when these procedures are performed as per manufacturer instruction, these effects generally mild to moderate. Whitening solution with greater than 10% carbamide peroxide appear to cause tooth sensitivity. Studies using night guard vital bleaching with 10% carbamide peroxide reported two main side effects: tooth sensitivity and gingival irritation. Tooth sensitivity is more prevalent than gingival irritation, but both of them will go after the end of the treatment. For whitening, two major approaches can be distinguished: chemical bleaching by peroxide and mechanical bleaching. Using fluoride toothpaste significantly reduces the tooth sensitivity. For internal whitening in teeth previously treated with endodontic treatment, studies reported 1% chance of cervical root resorption, especially in case of whitening with a thermocatalytic technique. The whitening procedure remains a procedure that is always sought by the patient, who mainly evaluate the aesthetic changes without going into the detail on the microscopic damage that occurs on the tooth substance where the tooth whitening is applied. Patients who have pre-existing history of tooth sensitivity or with recession and associated tooth sensitivity may be more likely to experience tooth sensitivity during the bleaching process. The main concern when it comes to whitening teeth is that some product may contain harsh chemical that can weaken or damage enamel over time. The most common ingredient in these products are hydrogen peroxide or carbamide peroxide, which can be abrasive when used in high concentration. Studies designed especially to assess the long-term safety of high hydrogen peroxide concentration in at-home bleaching material are needed, especially for repeated use of these products. It appears to be insufficient evidence to support unsupervised use of peroxide-based bleaching material.
Thank you very much, Dr. Sahila, for this informative lecture.
شكرا.
And unfortunately, we don't have time for questions because we have another lecture coming up. If you do have any questions, you can speak to Dr. Sahila directly. We're going to honor Dr. Sahila now. Thank you.
Okay, test.
السلام عليكم جميعا.
Test.
Mic is not working, so I don't think I need one right now. Is it working? On. Hello. سامعيني بالمايك؟ سامعيني من غير مايك؟ تمام؟ يعطيكم العافية. مرحبا فيكم في آخر محاضرة بأول يوم. We have 5 amazing specialists from different Hello? I need to whisper now. We have 5 amazing specialists from all over the country. We have 5 great minds. As a GP myself who's working in a polyclinic, sometimes I do have the question is, when do I refer and who do I send it to? So welcome to our lecture for today. And to start her off is Dr. Abdelhamid Al-Sarraf, who is a specialist in oral medicine and oral pathology. Thank you.
شكرا. السلام عليكم. يعطيكم العافية. نتشرف اليوم محاضرة من several different specialties. I'll be talking about oral medicine, when to refer. كلمت الشباب قالوا لي أنت أخذ نص ساعة، فأنا راح أخذ نص ساعة وكل واحد فيهم 5 دقائق. عدل؟ ما حد معارض. زين. when to refer. أنا أدري إن يوسف أوكي، عبد الرحمن أوكي، سلمان أوكي، الكل أوكي إلا جواري. زين. I have to disclose some stuff. There are no personal or financial interest in any of the contents discussed in this presentation. The information is based on my own opinion on when to refer oral medicine cases, and all cases shown in this presentation are my own, okay? So there are no textbook photos or anything like that. I've put this tongue for a reason because lots of cases attend the oral medicine clinic وللأسف يعني ترى ما كانت النية اني انا اتكلم في المحاضرة. شفت محاضرة وين تو ريفير كلهم ربعي قلت ما راح يمانعون انا اتكلم وياهم، بس للأسف يعني لما تصير في مثل هذه الحالات الى الان 2023 احنا نسأل او اسمع في دكاترة في المستوصفات يسألون وين احول في اورال ميديسن، احول بيريو، احول جراحه، ما ادري. هذا لازم يتعدل بطريقه واخرى. انا طلعت تكلمت، طلعت شرحت، بطلع بفيديوهات اتكلم اللي كان. هذا المفروض الجي دي بيز نفسهم يعرفون where to refer oral medicine cases and when. ما تنسأل هذه الاسئله و patient is in the chair with this tongue. مفروض ما يكون مقبول حق أي أحد، والحركة هذه لا تصير. The patient comes in terrified. لما هذه الحركة تصير، لما you call الدنتس اللي معاكم كلهم في المركز وكلكم تطلون على البيشنت للحين ما ندري شنو، فلازم تروح هذا الشيء gives lots of anxiety to the patient. يلا خلينا نجاوب where أول شيء بعدين ندخل حق when. في سبيشالست بالأميري، في سبيشالست في الفروانية، في سبيشالست في جابر، في سبيشالست بالعدان. The most recent hospital is حتى مستشفى النفط فيها سبيشالست recently. نشوف العلاقات الحالات اللي لها علاقة بالنفط. صدقت؟ ما له علاقة. زين؟ بس الحالات اللي في هذا المكان this region they do come to me in the KOC hospital to see them, as well as في الجهرة, okay, where I work, and I have that affiliation in 2 hospitals here on this map. So you can refer to oral medicine anywhere, no excuses, okay? هذه ورقة التحويل كلنا نعرفها. يحول لعيادة oral medicine. ما تعرف عيل شنو الشهادة اللي أنت عندك؟ ما أدري عيل شنو you are qualified in what. إذا أنت you don't know how to write oral medicine here, and we see the complications that the patient go through. Okay, this is the referral letter. These are the 2 hospitals I work in, Al Jahra or KOC, and I'm also affiliated with the Royal London Hospital because I'm teaching the students there until now. Okay. We refer when gingivitis is not plaque-induced. Let's start with some cases. Okay. When gingivitis is not plaque-induced. There's something I should have done, which I forgot, but I'll do it now. Have a look at those cases. شو رايك بالحركة بس؟ Okay. This is another case. Same condition. This is a case on the left, this is a case on the right. Juvenile spongiotic gingival hyperplasia. It's not gingivitis. The patient doesn't need deep scaling twice. The patient doesn't have to see a periodontist, okay? So you have to distinguish between plaque-induced with non-plaque-induced. This is another one, generalized erythema with ulceration. Ask the patient, oh yes, this is not plaque-induced. There's no plaque, there's no calculus. There's plaque here because the patient can't brush because of the pain. You have to ask if there are skin lesions. This is pemphigoid, okay? You have to distinguish. When the inflammation extends to the attached gingiva, then you'll be thinking about autoimmune diseases rather than doing scaling and deep scaling 3 times in 4 different clinics. Next, when ulcers don't heal. This is a large ulcer. She's being kicked between a clinic and another. She's been trying so many medications that are not indicated to treat the case, okay? Another ulcer. Prolonged inflammation causes malignant transformation. You need to know this. When the ulcer stays there for more than 2 weeks, you should refer the patient. Some ulcers are deep. You have to ask about the duration. If there's any induration, is there pain? Is there weight loss? Red flags. Just after 10 days, these 2 ulcers have improved significantly, okay? Just after 10 days with topical therapy. This is another one, okay? The ulcer has gone. We have to stop doing this. You have to stop prescribing so many medications without a diagnosis, okay? We have to stop this. This is from 1 patient only. This is just 1 patient. This is just 1 patient. It's just unfortunate, okay? A large ulcer. Let's have a look. What happened to this patient? 9 September, look at the date. 9 September 2021, 2 years ago. Non-healing ulcer. وين تحول؟ الجراحة ليش؟ Since when we refer ulcers to surgery? Since when? متى هذا بأي تعليم؟ خل أعرف بأي تعليم قاعد يصير هذا الشيء. Since when we refer buccal mucosa ulcers إلى الجراحة? Since when? Another year, this patient is living with this ulcer, huh? 25/10/2022, ulcer of mucosa from 6 months. They insist to refer to الجراحة ليش? Why? What will the surgeon do? Obviously nothing. The ulcer is still there. 2023. متخيل؟ والله البيشنت يقول لي ما أقدر آكل. والله يقول لي ما أقدر آكل. ما أقدر آكل. ما يصير. شنو هذا الليجن اللي مو قاعدة تروح مع كل الميديكيشنز اللي أعطوني إياهم؟ بس أسبوعين. Topical therapy ها؟ Topical therapy. صار قلب حب بعد. ايش رايك؟ وين تحصل؟ شوف ترى اسبوع توبيكال ثيرابي. شايف انت 3 years يبي يبوس ايدي البيشنت. ليش نوصل الى المرحله هذه؟ ليش يتحول؟ ابي افهم انا بس لما يجيك بيشنت ليش ما تدري؟ ليش كنا الدنيا كافختك؟ ليش؟ You've seen the map. We're across the country, okay? When you detect oral precancer, white patches, lots of them, there's lots of them, okay? When you detect oral precancer, white patches, certainly in smokers, okay? Red patches. If it's not trauma, then this is an erythroplakia. So leukoplakia, erythroplakia. شلوني مع الوقت؟ تمام؟ 5 minutes. الحين تقول، تو ما تقول. When you don't, شو يصير؟ I don't think anyone would be happy to see this in one of their patients. This is a leukoplakia. It's not referred, أكيد. أو referred to, لا هذا الكيس was referred to surgery. Oh, you're fine. صدق والله. Who's responsible? Another one. When lesions are suspicious. الحين خلاص وصلنا لمرحلة إن باقي 4 دقائق ولازم أخلص. فالحين the most important part, huh? When lesions are suspicious. شوف growth coming from everywhere, okay? This must ring bell that there might be something going on here. ترى هذه ما تطلع بيوم وليلة. يعني البيشنت ما ينام ويقوم اوه لمب، لا هذه موجودة من زمان. موجودة as a pre-cancer من زمان. وموجودة وأكيد شافها dentist بس he didn't refer it properly. He didn't detect it well. أهمل الكيس. This is another one. It's a preventable disease. ليش أنا قاعد أسوي highlight على هذا؟ لأن أول شيء باقي لي 3 دقائق. ثاني شيء this case is the most recent one. هذه كارثة. This is similar to the growth we've just seen. زين. This is the case. This is the lesion. Fine. Bleeding on presentation. The patient is in pain. حلو. في عوار. A large growth in the gingiva, buccally, lingually. There's pain, okay? خلينا نشوف his journey. هذا التحويل يحول لعيادة الجراحة طبعاً. انسى الشخطة الحين بنهي بالشخطة أنا تمام؟ He's referred, patient came to my clinic with painful in lower right under tongue, white to red lesion. Come to patient 20 days ago. An X-ray for شنو bone resorption. حلو؟ خليك من الفوكابلري انت الحين. هذا البيشنت حولها هذا الدنتست حولها سيرجري. حلو؟ I called the dentist. ليش كلمته؟ ليش انا اتصلت على الدنتست اللي انا مغطي اسمه لانه ما اعطاني permission اني انا I didn't ask him for permission. هو وايد كان متعاون يعني لو اقول له كان يقول لي عادي، يمكن يقول لي عادي وما ادري اذا موجود الحين موجود. قلت له منو شخط؟ انت شاخط؟ انت غيرت التحويل من الجراحه الى طب الفم؟ كان يقول لي لا، التحويل طلع من عندي الى الجراحه. 17/10/2023 شافه 18/10/2023 عطاه جل. تمام؟ كتب ورا نفس التحويل اسمي اي يوم ثلاثاء الساعه 8. زين انا عيادتي يوم واحد وهذا يدري ان انا عيادتي يوم واحد. ينطر البيشنت 1 ويك لان شوف عندك بالكالندر انت 18/10 اي يوم يصادف، وشوف عندك انا متى شفت البيشنت. انطر البيشنت اسبوع عشان انا اقول له ان this is suspicious for cancer. الكوست is unforgivable. شفت اسمه قادر مات قادر. Thank you.
Thank you, Dr. Hamid Sarraf, for that wonderful presentation. And if I ever send him a referral, it will be featured in the next presentation. Next up, we have Dr. Abdurrahman Akbar, who is a prosthodontist specialist.
Okay. يعطيك العافية دكتور عبد الحميد. اوكي. يعطيك العافية دكتور عبد الحميد على المحاضرة. I'm Dr. Abdurrahman Akbar. I work as a prosthodontist in Jabir Hospital. And I've did my studies in bachelor in Kuwait University and in the UK for the postgrad. So we're going to talk about, in this lecture, about the cases that is suitable to refer to a prosthodontist from the polyclinic, because there are many confusions that happens between referrals, especially to other departments. Sometimes the patient is referred to a prosthodontist and they need to be referred to the perio department or the endo department first. So we're going to discuss all the issues and the errors that happens between the polyclinic and the specialty center. So in brief, what cases are needed to be referred from the polyclinic to the specialty center? Of course, the main and the most important factor is that the GP in the polyclinic has to carry out the phase 1 and phase 2 treatment, where they control all the periodontal conditions and the active caries that the patient has. After that, they can refer any case that is related to a prosthodontic work. So this includes, and is not limited to any of these, but they include any cases with like large fillings, tooth structure is compromised, where the tooth needs to be crowned, if the patient is suitable candidate for removable or complete dentures, if there is any defective prosthetic work and they need to be reassessed, so the GP will not put his hand in these cases. And if there is any case in which the GP is in doubt, like if many of the cases that gets referred to us is when the tooth is broken or it has recurrent caries under the filling. So the GP just writes the referral to the specialist, please do a restorability assessment. This is one of the most confusing things to us because the GP has to do the restorability assessment. Okay? So as a GP in the polyclinic, you have to remove the filling, you have to remove the caries. Then if you are in doubt of the restorability of the tooth, you can place a temporary filling and refer it back to the specialist. But referring it directly to the prosthodontist with the caries active, this will be a waste of time for the patient because we will not accept the case. We'll be sending the patient back, and you know our schedules in the ministry are long due, so if the patient comes as an inspection, the appointment has been put like for 1.5 months or 2 months with the flow of the patient. So you have to sympathize with the patient, try to take control of as much as of can as a GP before sending the patient to a specialist. And there are certain cases, as we discussed, is when not to refer to a prosthodontist. So if the patient has active caries lesion, if the patient has an active periodontal disease, and if there is any thing that is related to phase 1 and phase 2, basically, you should not refer the patient until everything is done. So sometimes the GP would take a bite wing to the chief complaint side of the patient, let's say the right side, and they treat just the fillings on the right side, and they didn't take any x-rays for the left side. And then they refer it saying that this tooth is ready, let's say it's root canal treatment and ready for a crown. When he comes to the special center, we're gonna waste time taking x-rays again because he doesn't have a full enclosed x-rays. And when we take x-rays to the opposing side, most likely because he had caries on the right side, he will have caries. And then we would go through the loop again and refer him back to the polyclinic. The patient would complain, why am I being referred if I'm not ready? Please don't send me back to the polyclinic. So these things has to be managed from the beginning, okay? So these are some examples of the correct referral forms. So everything has to be filled in the referral form, as Dr. Abdul Hamid said. The one on the left, if you can see, the chief complaint, the site of the chief complaint, the exam and the x-ray that has been done, and the referral is regarding the bridge itself. So please assess if this bridge is defective or not. The one on the right, the doctor carried out the tooth restorability assessment. He said that I removed the caries, I reached a certain point where I don't know if the tooth is restorable, I temporized it and sent it back to you for restorability. So this is a correct way of sending a patient that is in need of prosthodontic work. Okay? This is an example radiographically of a case that is suitable to be referred. Let's say if you encounter this in a polyclinic and the patient has been treated with multiple crowns and bridges, and they came with defective crowns, let's say recurrent caries, periapical lesions. The GP will not be able to do anything in this case. They will not put their hand in doing anything because they don't have the proper material and skills to do it. So they would refer this case to us, which is acceptable because this is how they should refer to us. This is a clinical picture. So let's say on the left side, you can see a large filling on the molar. So if the patient has finished phase 1 and phase 2, then the GP should refer this case to us, even if it's not the chief complaint of the patient. Let's say you're doing something else. You should scan the mouth and see if there is any compromised teeth that needs of crown. Let's say this patient had this tooth for 6-7 years and didn't break. It doesn't mean that it will not break eventually, because there is weakening in the structure and flexural strength between the composite and the tooth's enamel and dentine. On the right side also is a correct case to be sent. So this patient has done in a private clinic a full mouth rehab treatment with veneers, and the dentist that did the cementation left all the cement in the mouth. They didn't even clean the cement. So what you're seeing here is not calculus. This is cement, resin cement. So they just put the veneers and cured. They didn't even take the time to clean it. So the polyclinic and the GP, they will not be able to do anything in this case. If they try to remove the cement, they might end up with debonding of the veneers. So in these cases, you have to refer to a prosthodontist. These are also a few examples. So this patient has on the right side cleared phase 1 and phase 2, but they had a provisional bridge that had fell. So it's okay to send this case to prosthodontist because they need to be treatment planned properly. The case on the left, you would think that it's a clean case. There's nothing wrong, right? This is actually one of the most common things in the prosthodontic department, but many of the GPs maybe skimp upon. So this patient is complaining from tooth wear. She has erosive tooth wear. She's a bulimic patient. She has bulimia nervosa, where she binge eat and purge, so she puts her thumb and vomit intentionally. So all the acid is wearing the teeth, and she's a young patient. So she has to be referred to a prosthodontist in order to prevent this and control this habit. So there are some examples of the incorrect forms of referrals. So let's take, for example, the referral on the left. What can you see missing from this referral? You can see that the civil ID is not there, the date is not there, okay? And the medical problems, the treatment done, nothing is there. In addition to that, you cannot read the handwriting. So I don't know what's written in there except for the word implants. And the teeth are not specified, so this is a waste of time for us. When the patient comes, we in the Ministry of Health, as a prosthodontist, we have appointments for the patient. So in the inspection, patients come in between the appointments. So the patient can be there from 8 o'clock, and I have an appointment from 8 to till 10. And then when the patient comes, he said, I'm waiting for 2-3 hours. And when they enter the clinic, I tell them, you're not ready. You have other things. The referral is missing. You have multiple caries. So why did you let me wait for 2 hours? And many problems happen because of the miscommunication and wrong referrals to us. So this referral is invalid, and it's a waste of time when I inspect the patient. The referral in the middle, so what's wrong with the referral in the middle? Everything seems to be filled properly. The name, the date, the civil ID, okay? If you see the context of the referral, it's not related to PROS. So, and even if it's related to PROS, it's not specified. So just painful tooth, painful while eating, evaluation, and assess the pain on upper left 7. Why is this a concern for a prosthodontist if you didn't specify if this is a crown or anything else? From what I read, this is a phase 1, phase 2 case. So before even I enter the patient inside the clinic, I see this referral. It's a waste of time because I will know I will gonna see the patient and waste my time with it. Okay, the referral on the right is the most hilarious one. So this doctor referred this case. She wrote on the top left, sorry, I forgot my stamp. And down, she put her name, and she put her name twice, also on the upper right side. So if your stamp is not with you, you have a colleague, you can stamp the referral with his name. If your colleague is not your friend, you can then bring your stamp. If you cannot bring the stamp, then bring the patient on another day and refer it properly. How would I know if this referral is written by the patient or the doctor? And even the name of the patient is written ad doctora. So I don't know if this is really in the civil ID or she's just putting that. So, and then if you read down also, your kind care, the patient requesting a night guard. The patient is not the one to request. You are the dentist. You have to diagnose and see. If some patient comes and says, I want a night guard, I just write a referral, the patient needs it. You have to assess if they really need it or not. You're a dentist, okay? So you have to assess the patient properly, sympathize with the patient, do the proper work, because the hassle of the patient going back and forth, this is just a waste of time for the patient and for the doctor. These are few examples of, in my opinion, cases that should not be referred directly to pros. So on the left side, it's correct, the patient has multiple prosthodontic work done and defective bridges, but they also have active caries and some teeth that might end up with extraction or not. So it depends here, like if these teeth need to be extracted immediately, or if the general practitioner elaborated that this case is a full mouth rehab, and maybe they don't want to do the extraction in the polyclinic, they want to be treatment planned properly in a prosthodontic case. So this is like a gray area. Sometimes this case is suitable to be referred depending on the chief complaint of the patient. Sometimes it's not suitable. It depends on what the patient has. The tooth on the right is the most common case of referral. So the tooth is fractured, or there is recurrent caries, and they just refer it just like that with the caries. Please do a restorability assessment. This is wrong. So you as a dentist should take care of the active lesion, remove the filling, not just the active lesion and the caries. You have to remove the whole filling. This is a compromised tooth now. If you then end up with the tooth being in a gray or shady area, then just place a cavit or a temporary filling and refer it to the pros department for assessment. This case also, they have a lot of active caries, so do not refer cases like that until you control them. Sometimes we get referred cases like that. This is suitable to be referred for ortho before referral to a pros. Okay, thank you.
Thank you so much, Dr. Up next, we have Dr. Hassan Jawahiri, who is a periodontist.
Okay, تمام يعطيكم العافية. Thank you for sticking in. I think شهادة الحضور should be, our تكريم should be all for you, not for us. So thank you for staying for this hour. So we're going to speak about when to refer patients for periodontal specialist. So quickly, you know your pathway to diagnosis بالperiodontology or periodontics depends on 3 factors or 3 main categories. عندك visual examination for the periodontal tissues, probing the periodontal tissues, as well as your radiographs. Okay. Once you gather all the information from your examination, the patient condition can fall into one of the categories presented in the most recent classification of peri-implant and periodontal conditions. Okay. Now, us in the periodontal department, we try to simplify this to suit what you see daily in your routine clinical practice, what you expect to see when you examine periodontal patients. So once we try to narrow this down together, فريق التنسيق والتطوير دكتورة بيار وايل موجودة زميلتي باقي التيم, we just put 5 different blocks. to try to see what conditions the patient usually fall into. So عندكم أول شيء periodontal health or peri-implant health. Then عندك limited inflammation, gingivitis, peri-implant mucositis. Then actually the inflammation gets deeper to the periodontal tissues, so عندك periodontitis or peri-implantitis. Then you have other conditions affecting the periodontium or peri-implant tissues, such as mucogingival deformities around teeth or implants, periodontal abscesses, other conditions such as necrotizing periodontal diseases or non-implant induced gingival conditions مثل ما قال دكتور عبد الحميد. And then lastly, we have the most commonly requested procedures from a periodontist, مثل شنو gingivectomy, crown lengthening to enable placement of a restoration, or عندك implant work, إذا عندك teeth planned for extraction, you want to replace with implants, or عندك edentulous sites, same thing, planned for extraction. So فريق التنسيق والتطوير بغى يحط protocol official release from the department, so not based on my opinion, somebody's opinion, it's the paper that you should be following. And they put together this referral protocol. So this is officially released from the Department of Periodontology. You as general dental practitioners, if you want to refer patients to the specialists across the centers in Kuwait, you need to be following this. And based on that, you're going to understand what you're going to do for that patient in terms of initiating treatment or not, and when to refer that patient for their specialist. Okay? That was the main point of focus for us over the last 3 years. كنا نعطي multiple workshop sessions. بالجهرة كان خصوصا we met all dental practitioners from all of Kuwait, and newly graduated dentists. So most of the people who just finished their degrees and they started the internship period, they're all familiar with this. Okay. فليش we did this all together? Because we want to improve the communication between the specialist and the general dental practitioners. Secondly, most importantly, we want to alert the general dental practitioners because you are the first line of defense. We rely on you for screening the patients for periodontal conditions. So it's important to be screening patients for periodontal or peri-implant conditions because most of these patients are asymptomatic until the patient gets into an advanced stage. For condition is they're going to have more pain, more tooth loss, more complex treatment. So we want early screening. We want to ensure the referrals are filled in correctly مثل ما وراكم الزملاء بالريفيرالز الخانات كلها معبيها صح المعلومات واضحة التحويل صحيح عشان we make the referral process more efficient. Lastly, we don't want to get unnecessary referrals. Everybody is in high in demand. We want to get patients who are in real need to seek periodontal treatments. So let's just dissect the referral protocol bit by bit. We have the top part of the table, what you need to be your checklist before referring patients to the specialist centers. Please devote some time to do some oral hygiene instructions for your patients. Caries control, if they have cavities, restore them. That phase 1 treatment, which was Dr. Abdurrahman was speaking about. Scaling and polishing, if they have calculus or stains. Re-evaluation. Re-evaluation is very important because us in the periodontal department, our treatment is lengthy. Some patients can be with us for over a year before they get discharged. For the patient with the wrong mentality, that's a waste of time for that patient or other patients, and for us as well. You need to assess that patient that have the right set of mind, the right motivation, the right attitude, the right compliance for your instructions. Once you have established this, then yes, fill in the referral form and send the patient with radiographs if they have it on a CD possible. Okay, let's look at the first block. So periodontal or peri-implant health, okay? So since it's healthy, then you're gonna see there is absence of redness, absence of swelling, there is no bleeding on probing on that specific site, there is no attachment loss. You'll take radiographs and usually there is no bone loss. The periodontal pockets are not more than 4 millimeter in depth. And if you're familiar with the basic periodontal examination, that will give you a code of 0. So for such patients, obviously referrals is not needed. Just re-emphasize the oral hygiene instructions and give the patient recall on every 3 to 6 months. Right. Okay. Second block, gingivitis. So you have limited inflammation or peri-implant mucositis. So now we're going to start seeing some redness, some blunting of the papillae. You're going to have bleeding on probing on that specific site. Patient going to be complaining of some sort of pain or discomfort. However, there is no attachment loss. The pocket depths are not more than 4 millimeter. And if you take radiographs, usually there is no bone loss. So in terms of BPE, this is the code 1 or 2. For such patients, again, you're not going to be referring that patient. It's easily manageable. You're just going to do some scaling around that site. Are you going to refer patients that have peri-implant mucositis? Just some inflammation around the implants. No, because we don't have anything special in our centers. We don't have any special tips. We use the same scaler. So don't be afraid of scaling around implants. So do that and then review the patient in 2 to 4 weeks' time. If the inflammation has resolved, then that's it. You've done your treatment. Then see the patient every 3 to 6 months on recall. The third block, now we have more inflammation, so you're going to have some bone loss now. So on top of the symptoms we mentioned before, plus of that, you're going to have pocket depths of more than 5 millimeter or more. You're going to have some drifting teeth, some loss of teeth, mobile teeth, more pain, more discomfort, passing of the pockets, and you're going to take radiographs and you're going to find there is some bone loss. In terms of BPE, this is called 3 or 4. Now, not all patients are the same. We know from the new classification that periodontitis could be a different stage or different grade. The more advanced the stage, the more advanced the grade, the more complex the treatment, the more lengthy the treatment. So in your clinic, if you get somebody presenting like this with a uniform pattern of bone loss, more moderate kind of bone loss, don't rush in to send this patient to the specialist center, because the pockets here are between 5 and 6 millimeter. It's easily cleansable with your hand instruments, easily reachable with your scaler tips. So what you need to do for such patients is to start your treatment of non-surgical periodontal therapy. So give anesthesia and do some debridement for these sites. And then recheck the patient in 4 to 6 weeks' time. If the pockets has gone, you've done your treatment. But if they still remain or the condition deteriorates, then refer the patient to the specialist center. But somebody presenting like this, obviously, is not the same. Now, this patient is in more advanced stage, more later stage. There is more mobile teeth, more drifting of teeth. There is more teeth loss. There is more bone loss. You're not sure how to put prognosis on these teeth, whether you're going to take them out or keep them in, if they're mobile or not. So you're not sure about what sort of things it's going to do. And you know it's going to be more complex, the treatment. And you know it's going to involve multidisciplinary approach, maybe some form of endo treatment, pros treatment, even implant treatment once the condition is stable. So for such patients, you want to refer. These patients are more in need of referral. But obviously, you're going to run through your checklist again. So do your scaling and polishing or root surface debridement, review the patient in 4 to 6 weeks' time, and if the condition is still the same or deteriorates, then refer that patient. The fourth block, other conditions affecting the periodontium. So you could have excess gum or delayed passive eruption. You could have recessions, whether it's localized or generalized. You could have aberrant frenum attachments or high frenum attachments. Drug-induced gingival overgrowth. A lack of keratinized tissue around implants or teeth. Periodontal abscesses. And necrotizing periodontal disease. Once you identify any of these conditions, then those patients need referral as well to the periodontist. Okay? So, but again, you do the same checklist, scaling, polishing, re-evaluate in 2 weeks' time, and refer to the periodontist. Our last category, before we finish this, is the most commonly requested periodontal procedures in terms of crown lengthening and gingivectomy. And this category, usually we get referrals for patients who have a class 5 cavity who's gone a bit subgingival, or a last standing molar in a quadrant, and there is a deep DO filling that requires distal wedge procedure. Then yes, refer to the periodontist. Your main question should be whether that tooth needs a crown or not. If it doesn't need a crown, then yes, refer to the periodontist. Otherwise, if that tooth in question has lost integrity and you need assessment from the prosthodontist, so please refer to the prosthodontist to assess restorability. If that tooth is restorable, the prosthodontist is going to initiate the treatment and is going to refer to the periodontist for gingivectomy or crown lengthening. Same thing for implant therapy. If you have teeth planned for extraction or edentulous sites, you have to refer first to the prosthodontist, not the periodontist. We still get this mistake. The prosthodontist, because these treatment plans are prosthodontally driven. So don't refer to the periodontist because it's just going to waste the patient time. راح أقول له اطلع من هني روح للبروس first بعدين نرجع لي. And he's been already waiting for 1 hour plus. Okay, that's it in a nutshell. Hopefully that was concise. Please, you can scan the code. If you want to obtain a digital copy of the referral process, I really encourage you to do that. And thank you for listening.
Thank you so much, Doctor. Next up, we have Dr. Yusuf Abel, who is an endodontist. Abel? I'm sorry.
مساكم الله بالخير. أول شيء أحب أشكر دكتور عبد الحميد ودكتور عبد الرحمن ودكتور حسن. I'm not sure how I'm going to compete with them, but I'll try. Okay, so for the last 30 minutes, I think we are talking about referring patients. So what is referring? Generally speaking, very simple. Referring that you refer someone or an object to someone else that you might think he has more understanding or he's more knowledgeable or he can provide more or better service for that person, okay? How can we apply it for the dental field? Simple again, it's transferring one patient from one dentist to another dentist, okay? Or it's directing or redirecting the patient to a specialist so he can provide the adequate treatments. Okay, what's the purpose of dental referral? Why we need to refer patients? As maybe my colleague said, they might know better, okay? So they can provide adequate treatment. They provide the care that your patient needs. Maybe you might ask, if there's one dentist that I can refer the patient, he can do all the work? No, simply. There's no such dentist called a superhero dentist. To make this example very simple, I think most of us have seen comics, read or have seen superhero movies, either Marvel or DC. Every company, they have their own superhero, and every superhero have his own movie. But in that movie, the superhero has a limitation that his rival always can take advantage of it. So they came up with the Avengers and the Justice League. Why they did that? Because every other superhero can overcome the limitation with the other superhero. It's the same applied in our specialty, okay? So you're referring to us because we have a limitation that we can take care of that limitation and provide a good care for our patients. Okay, so let's talk about the protocol, how to refer the patients to the endo departments. First, we have to fill the referral form. We were talking about the referral, for the referral form for Dr. Hamid, Dr. Hassan, Dr. Abdul Rahman. Okay, so we have two types of the referral forms. We have the printable one, and we have the one with the handwritten. The most problematic is with one with the handwritten. It's the most mistake that we have seen in that referral. So this is an advantage of a good referral and a bad referral, okay? Just take time to fill the patient info. Name, civil ID, give me a chief complaint. Tell me exactly if there's any medical problem, what exactly treatment has been done, and what the patient needs, the treatment that he needed, okay? Just don't send me a blank referral. Just take, it's not gonna take 1 minute from your time just to fill it. Okay. Clinical assessment of the periodontal status. Don't refer a patient with such condition to our department. Please do scaling, do give the patient oral hygiene instruction. And it's all about prevent and eliminate infections. The presence of calculus does mean there's an active inflammation, okay? It's all bacteria on that site. It's gonna affect our treatment. Restorability assessments. It's the most, I think, dilemma in all specialty. There's one question. Why do you refer your patient for restorability assessment to the endodontic departments? Maybe I can only think about one reason in your mind, that you're a dentist before you became an endodontist, so you might know how to assess restorability. Yeah, you are right. I'm with you 100%. But in my prospect or my point of view, I might see something is restorable, but when I do the root canal and send it to the pros department, they might see the opposite, and they said, no, this needs to be extracted. To make it very simple, let me give an example. If a patient comes to your clinic and he's in pain, and you did everything to detect the source of pain, and still you couldn't. So to where you might refer your patients? to the orthodontist. Yeah, he's a dentist before he became an endodontist, orthodontist. He knows about pain. But why you gotta refer to me, to the endodontist? Because I studied pain. I know the pattern of pain. It's the same apply for restorability assessments. But before you do such, please take time to remove all the existing filling, the defective filling, remove all the carious lesion. Then you might yourself see that tooth is not restorable. I'll give you some example. This is cases has been referred to our departments, okay? This one has been referred to do a root canal on this tooth. Come on, if you just take a time to remove the caries over here and the filling, you in the bullet clinic, you will see it's not restorable. And also, like there's the remaining roots, there's broken fillings, and again, endo is all about eliminate and prevent inflammation, okay? So don't send the patient like this. Take a time to do caries control, please. Don't refer to cases like this, okay? This is the radiograph of one patient, the same patients. Believe me, it has been referred for that tooth for root canal, also for this for root canal. Case difficulty assessment. There are certain cases that might require root canal, but the case itself is difficult. Such as like if the tissue had like severely reduced calcified pulp chamber, okay? These cases, if really required root canal, don't do the initial pulpectomy in the polyclinic. Send it directly to us because this is can categorize in the high risk of maybe perforation or like any mishaps. Also, if there's extensive pulpostone, obstruct the pulp chamber. You cannot see the pulp chamber clearly, such like these cases. If they do really need the root canal, send the patient to us. We will do the treatment from A to Z. If there's any deviation from normal, okay, such dens and dente, fusion, microdens, okay, send the patient to us. We will do the treatment for him. Don't try to do the pulpectomy for such patient. But one thing, please don't abuse this because we can tell if you abuse it and you send the patient, it's a simple case, but you just send it because you don't want to do the pulpectomy. We can tell. To know more about it, the AE has generated a case difficulty case form. Just if you go to that, if you want to read any more about how they assess the difficulty of cases, just go to that website and you will find them. Okay, teeth that require retreatment with a crown. If you really think that tooth needs a retreatment, but it has a crown, first send the patient to the process department so they can dismantle the crown, check the restorability of the tooth, then can they refer the case to us to complete the retreatment, okay? Don't send the patient like with the crown, just go to the end department because we're gonna send the patient in our turn to the pros. It might take a long cycle. He will come to the endo, he will take a number, like he might wait 10, 15, 20 minutes until we see him in the examination room. We're gonna check, oh, there's a crown. We need to remove it before we do any retreatment and to assess. We will tell the patients, please go back again to the recipient, just take a number to the pros. They will go, as Dr. Abdurrahman said, they have appointments, so the patient might wait for 1, 2, or 3 hours until he gets in to see him. He will give him an appointment, okay? Then, on like maybe the appointment, like 2, 10, 1 week, then he will go for the appointment. Then the patient will be upset. Why they send me to the endo? Then the endo, they send me to the pros. It's a long process, long cycle. So just to shortcut this, send him directly to the pros. Okay, compromised teeth, which requires advanced restorative planning, such endo treatment. They need the pros, maybe post-encore. They need the crown lengthening.
There's a protocol. Has been generated by the Department of Endodontics. Just follow that protocol. It's very simple. Okay, first thing, it's gonna start in you in the polyclinic. Remove all the caries, all defective restoration, do the pulpectomy, place calcium hydroxide. If you doubt about restorability, send the patient again to the pros, not the endo, to the pros. Okay, the pros department, they will re-evaluate the restorability. If they think the tooth is restorable and he needs a crown lengthening, it will be directly referred from the pros department to the perio department. They will do the crown lengthening. After 2 to 4 weeks, the perio department directly will refer the patient back to the endo. We will do the root canal. Then we will refer the patient back to the pros for the final crown. If the pros detect the tooth is not restorable, then he will directly just either gonna send the patient back to the polyclinic for the extraction, or he might send it for the oral surgery department just to take the tooth out. As simple as this. Take home message, please, before referring the patient to any department, do oral hygiene instruction. If there's defective filling, remove the filling. If there's caries, remove the caries. Then refer the patients. If you look at the referral slip, always you can see this message. Don't tell me the patient insists to get the referral. You are the dentist. You have the control over the patient, not the opposite. Okay? I think that's it. Thank you.
Thank you to the superhero, super endodontist, Dr. Yusuf. Next up, last but not least, we have the wonderful Dr. Salman Sarkho, who is an orthodontist.
Okay, let's try. Okay, so thank you very much for having me. It's a true honor. Thanks to my colleagues for the invitation as well. When to refer to an orthodontist, I feel like the entire specialty's weight is on my shoulders right now to talk about a very, very important topic and a very important part. I would like to mention that Usually I give this lecture in sort of 2 hours, and then there's a workshop, and Dr. Abdul Hamid, I think, has a workshop. So there's a lot into this, but I'll try to do 10 to 12 minutes. Time starts now, not before. Okay. All right. So, 8-year-old patient, Faisal, referred to me to Jabir Ahmed Specialization Dental Center. I hope that everyone looking at a case like this would say, yes, Dr. Salman, I would refer a case like this. The upper right lateral incisor is tilted towards the side. There seems to be some sort of tooth structure there. The upper left lateral incisor isn't through. What's really going on? We'll look into a little bit more detail. We look at things palatally. Well, we've got a retained A there. Where's the lateral? Where's the canine? Where are things? I think the point I'm trying to make is that there are a lot of obvious conditions where we would refer in orthodontics, and it becomes quite obvious. But I think it's important to be as objective as we can rather than subjective, and that's what I'm going to be talking about today. So, the orthodontic referral, to be able to identify abnormality, we need to know what is normal. So we're going to talk about that in the primary dentition, mixed dentition, and then the permanent dentition. We're going to talk about eligibility for orthodontic treatment. I know people here, they might be from the public sector, but also the private sector, so we'll get into that. Finally, utilizing the IOTN. I talk a lot about the IOTN, but we're going to use some of the concepts because obviously we don't have enough time to go over all of this, okay? So let's start off with identifying normality and abnormality in the primary dentition. So if you start with the primary dentition, we're thinking about the normal eruption pattern, and that's really important. If teeth are coming out at the right time, everything's fine in relation to that, then things should be running quite nicely. Primate spaces, residual deciduous spacing is actually quite a good thing. If you've got those spaces, then it's a little bit more room for the permanent teeth to start to come through. Thumb sucking, all right, is something quite paternal. A lot of kids do it. It's fine, but up to a specific age, if it continues, then you can end up in situations with anterior open bites, so we need to try to get our patients to stop that. And as orthodontists, we can help. As pediatric dentists, they can definitely help as well, and they've got a lot of experience in that area as well. So we need to think about that in terms of normality and abnormality. What about abnormalities? Severe skeletal discrepancies, severe delayed dental development in cases like this. Obviously, you look at a case like this, this is going to go referred to on the side there, missing our supplemental teeth as well. We want to look at those cases. Now, if we look at these right here, with A's, B's, C's, D's, E's, do we extract, do we balance, do we compensate, all that sort of thing. Our pediatric dentists as well as orthodontists, we can work together quite closely to be able to think about whether we want to compensate or balance extractions in relation to these. Those are a little bit of guidelines right there. Okay. If we go over to the mixed dentition, what are we looking for? Again, the same thing with the primary dentition. We're looking for normal eruption pattern. If you know your eruption pattern, if you're at a stage where you can think about the patient's age and work out the teeth that should be there, if we're missing some teeth and teeth aren't there, we have to ask the question, what's really going on? Why aren't the teeth there? Are they impacted? Are they congenitally missing? What's really happening in a situation like this? Contralateral teeth should erupt within 6 months, and that's one of the issues that we get with a lot of family members as well, where the upper right one is coming through, the upper left one is nowhere to be seen yet. That's fine. There's a bit of time. There's 6 months that's usually our cutoff point. Then if it's more than 6 months, we have to start asking some questions. Significant deviation in the eruption sequence as well. Say the lateral's hasn't come through, but the upper four is coming through, or the upper first premolar. What's going on in that situation? So there always has to be that question mark in situations where the teeth aren't coming through. Maxillary incisors that remain unerupted as well a year after the eruption of the mandibular incisors. A median midline diastema, normal, abnormal. Well, at a certain stage, the ugly duckling stage, we expect that. Once the upper canines come through and the permanent come through, they push things forward. So it can be normal, but when it goes forwards, things might be just a little bit different. Maxillary canines, I can't stress this enough. 10 years of age, try to make sure and check where those canines are. Are they buccal in position? Are they palatal in position? If they are palatal, we'd like to see them, please. Abnormality. Severe skeletal patterns, severe class 3s, severe class 2s. we want to see those patients. Even if they are in the mixed dentition, there are things that we can do to help out those patients. Developmentally missing teeth, if they've got missing lateral incisors, cases like these, you might want to take an OPG. You want to see where that lateral incisor is at, but if it's not there, then you might want to refer to an orthodontist to take a look. And teeth in unfavorable positions as well. We get actually a lot of these cases in Jabir Al-Ahmed Specialization Center, and we get good referrals from you guys. Now, I will say this, we do get a lot of good referrals. They're not just bad, they're not everything bad. I was a general dental practitioner. Don't take this away from my time. You're taking it away from my time. I need to work the room shway. It's part of presenting, okay? So, yeah, we do get a lot of good referrals. I was a general dental practitioner, Rigga Polyclinic, 30 patients come in. It's difficult. We know it's difficult, but you have to try and take your time. These are patients, and you have to give them the time and to take a look at everything as well. Wow, time flies. All right, impacted first permanent molars. We want to make sure we're looking at those submerged and infraoccluded teeth. Crossbites, especially those crossbites where there's displacement, anterior crossbite where you're hitting on the teeth and then advancing forwards. Those cases we want to look at, as well as posterior crossbites, so with displacement. All right, the permanent dentition. Yeah, you guys are going to kill me. The permanent dentition. Normal development. As an orthodontist, I like to talk about Andrew's 6 keys. I like to talk about perfect molar relationship, canine relationship, incisor relationship. I want to talk about an average overjet, an average overbite, well-aligned arches. That's the sort of thing that we consider normal and abnormality. But what is abnormality? This is where I like to talk about the IOTN. All right, anyone who knows me, usually there's like a sign on my head called IOTN, all right? I talk a lot about it. The Index of Orthodontic Treatment Need, developed sort of in the UK and in Sweden. It works quite nicely. But before I talk about that, for people who aren't in the public sector, in the private sector, what are we looking for? If you are in the public sector, we'll talk about the IOTN. The dental health component's important. هل في حاجة طبية لعلاج تقويم الأسنان? Is there a dental health need? ولا فقط حالة تجميلية? Is it purely aesthetic? If you're in the Ministry of Health, we want to focus on the dental health need. There's the concepts of beneficence. We only have a certain amount of cases that we can see. So we want to make sure that the patients that are most in need get that care. All right? And in borderline cases, that's where the aesthetic comes in. It's mainly dental, but in borderline cases, we think about the aesthetic. It's not just the aesthetics. But if you are in the private sector, well, aesthetics works. If there's a bit of aesthetics, a slightly rotated tooth, anything like that, there's nothing wrong with calling over an orthodontist and saying, would you mind taking a look at this case? Just like with any other presentation in this conference where you have a lot of aesthetic work, there's nothing wrong with that. But we're going to focus mainly on what we do in the public sector in the Ministry of Health. Now again, we talk a lot about the IOTN. If you don't learn anything from today, if you don't take on anything from today, I would recommend that you take on this acronym, which is, here we go. All right, something just paused here. Here we go. All right, take on this acronym, which is MOCDO. And it really helps me. I still use it. It really helps me in clinic, thinking about what cases we want to refer. Follow MOCDO. If you don't learn anything, I don't want to say from today, from my part, just learn MOCDO. Because MOCDO is essentially divided into missing, overjet, crossbite, displacement, and overbite. I've got loads of time, man. It's 8 minutes and a half. I've got a timer. All right, so missing. If we're looking at missing teeth, hypodontia, whether it's less extensive or extensive hypodontia, all right, in need of pre-restorative orthodontic treatment, all right, we want to see those cases, all right? So whether it's less extensive or very extensive, what do we mean by hypodontia? Where it's a congenitally missing tooth. We're not talking about a 6 that's extracted. We're not talking about a 4 that's extracted. They want a closed space or open space for implants. We're talking about congenitally missing teeth, and that's very, very important. Impeded eruption as well, impacted teeth. We want to make sure that we look at that. So in MOCDO and in our acronym, all right, that's done with missing, all right? Missing, we're looking at congenitally missing teeth, and we're looking at impactions, done. Overjet. We're looking at overjet if they've got incompetent lips, because the problem is if they don't have competent lips and they fall on their faces, they can break them. they can break their teeth. So obviously, in cases like that, there is a dental health component, but we mostly want to focus on that 6.1. So over 6 millimeters, send it through. Reverse overjets, 1.1 to 3.5 millimeters. If it's within that range, we want to think about if there are any aesthetic complications because it's considered borderline. Over 3.5 millimeters, send it through. Now, I'm in a polyclinic. I was in that situation, a CP12, a BPE. If you don't have a ruler, it's fine. You can still measure with that. Just take your CP12 and measure your overjet, whether it's positive or whether it's reversed. So overjet, positive, negative, done. Crossbites. Crossbites with displacement, whether it's anterior or posterior, if it's greater than 2 millimeters between the treated contact position and intercuspal position, we want to see those cases. Lingual crossbites as well are very important. Displacement. This is one of those that's, you know, it's a bit tricky for general dental practitioners when they look at crowding. What are we looking at in relation to displacement? I think the main thing here, just breathe, you take your time, you look at the distance between the contact points in one tooth, right? So one tooth. So if we're going to look at the worst out of these, I'm sure you guys are looking into this area, yeah? So that distance from the contact point there, from that contact point there to this one here, if I get a CP12 or a BPE and that distance right there, okay, is more than 4 millimeters, I want to refer, okay? So just do that. Don't think about all the crowding, just that area, that one tooth, the worst part. Measure that distance and send it through if it's more than 4. Last but not least, overbite. We're looking at overbite, increased and complete overbite without gingival trauma, but definitely if there's gingival trauma, we want to see those cases. Anterior open bites. We get sent a lot of these cases as well with anterior open bites. 2.1 to 4 millimeters is quite a small anterior open bite. There's no real dental health component. There's no real dental health need. But if there's a massive aesthetic complication, then yes, you would want to refer a case like that. Over 4 millimeters, definitely refer. Okay. Others, supplemental teeth, partially erupted teeth that are tipped against their deciduous teeth, defects of cleft lip and palate, submerged deciduous teeth again. These cases obviously need referrals. Now, I would recommend if you want to go online, there's nothing wrong with going on Google sometimes, all right? Now, I know we're in clinics and things. There's a lot of information here. Dr. Jawahiri, you were able to scan. There's nothing wrong in taking a look. You don't say to your patient, well, wait a second, everything. But take a look. Just refresh your memory on certain things, and that's absolutely fine. I swear. That's 12 minutes and 40 seconds. Wallah al-azim, all right? All right, aesthetic component. Now, I will talk about the aesthetic component a little bit. This is partly, you can take a look at this from 1 to 10. This is in borderline cases, 7, 8, 9, 10. If it's close to that sort of number in the aesthetic complications, you can send it through. Those are only in the borderline cases. I don't like this image. I don't use it a lot because there are no class 3s. There aren't the complications that we usually look at. Quick messages from our orthodontic colleagues in Jabir Al-Ahmed Hospital, and we'll end. All right? Saying to the patient that they're in need of orthodontic treatment, it's very difficult. I see most of the cases that come through from the new patient clinic. It's very difficult, as our colleagues mentioned. They come in, they sit down, they've come in their day, they might have taken the morning off, and they come in, and they have been told by a general dental practitioner that you definitely need orthodontic treatment. Just say, I'm going to refer you for an opinion. Give us a little bit of leeway, and let's help each other out as much as we can. Referring patients with caries, evident periodontal inflammation, calculus, they're not brushing properly across the board. Obviously, this is an issue. And ask yourself, are they a good candidate for orthodontic treatment? Age isn't an issue, so you can refer patients in relation to that. If a case requires assessment, refer in relation to everything we've spoken about today so far. And when in doubt, obviously, refer. Hopefully, by the end of this presentation, you'd refer a patient like this 3/4 of the way through their treatment. Ladies and gentlemen, it's been a true honor. 14 minutes, 19 seconds. Thank you very much.
Thank you so much, Dr. Salman. I know that each and every one of our special guests can talk for 3 to 5 hours about their specialty, so it's very hard to condense them in 10 to 15 minutes. As you figured, unfortunately, we do not have time for any questions. So if you have any questions, you can ask the specialists directly. I would like to ask the specialists to all come on the stage, please, so we can celebrate you all. And this concludes the last lecture of the last day. You folks are free to go if you'd like. And thank you all for coming. First day. What did I say? First day. It's been a long day. So thank you for all coming and have a good night.